हाँ जी मोना मैम, हेलो, जरा आवाज ये बंद करना साउंड। हेलो मोना मैम, हेलो।
Yes, Avnish, sorry, I was on.
हाँ जी, हाँ मैम, क्या कह रहे हो आप? क्या प्रॉब्लम आ रहा है?
I don't know how to go to settings to put my background picture.
अच्छा,
ट्यूटोरियल तो दिया था, इसमें तो है नहीं सेटिंग का बटन।
नहीं मैम, वो साइड में होगा। एक
नहीं अवधेश, ये तो साइड में तो बस स्टिकर चल रहा है। Do I need to log into Zoom?
But you are already logged in Zoom, man.
Avnish, do I need to log into Zoom?
No, you are already logged in.
आप जूम पे नीचे देखो, वहां पे दिखा रहा होगा। आप अपने जूम पे देखो।
So I have to sign into my Zoom, right? मुझे अपने Zoom अकाउंट में साइन करना है ना?
Ma'am, what's the problem?
अरे I don't know, सेटिंग दिख ही नहीं रहा है कहीं पे।
सर मैं आपको भिजवाता हूँ। अविनाश, एक मिनट सर, बोल। अविनाश, जरा मैडम को वर्चुअल बैकग्राउंड लगवाना।
हाँ हाँ, मैं कर।
हेलो हेलो।
यस,
नीचे स्टार्ट वीडियो का ऑप्शन दिख रहा है। म्यूट एंड देन स्टार्ट वीडियो लेफ्ट साइड।
म्यूट दिख रहा है, उसके बाद स्टार्ट वीडियो दिख रहा है, राइट?
स्टार्ट वीडियो के ऊपर में हम अप एरो होगा।
Yeah, so I click on the arrow.
हाँ, click on that, then choose virtual.
There are videos. Then what do I do?
Then do you have the virtual background?
Video setting.
No. Do you have the virtual background?
Choose virtual background.
Yes.
अब ऐसे बताओ ना, मैं सोच रही हूँ। Okay, so I choose virtual background and then okay, you can see me now. Then how do I choose it? मैंने save कर दिया है। So
आपने सेव कहाँ पे किया? डेस्कटॉप पे?
नहीं, not desktop, in the folder, मतलब
हाँ, जहाँ भी सेव किया आप वहां से।
I click on plus. Where do I click on? Virtual background?
Yes ma'am.
Plus. Yes ma'am.
Plus पे. Okay. Add image. You know, people who make these software sometimes.
I'll call you. We are live, so I'll call you on call.
Okay.
And we can start now.
Hi, very good afternoon to everyone. We welcome you all to day 2 of Gynae-Onc Maxcon 2021. After a great session yesterday, we have a host of activities lined up for you today. So without wasting any time, and we're really going to be cautious of time today, let's start our first session, Adnexal Mass, the Optimum Care, in a panel discussion. And I would like to invite our chairperson for the session, Dr. Abhilasha Chaturvedi, who is the director of Abhilasha Hospital at Allahabad, and Dr. Manju Khimani, who is a senior director at Max Smart Super Speciality Hospital, Saket. Would request Dr. Khimani to introduce Colonel Bikram Bhardwaj, who complied in the very last moment for moderating this session. And thank you so much, Colonel Bikram, for pitching in. Over to you, Dr. Khimani.
Thank you so much, Kanika. It's my privilege to introduce Colonel Bikram Bhardwaj for this very exciting session, very important session on, how to investigate adnexal masses.
बाहर से मेरा खाना ले लियो और रख दियो.
So Colonel Bikram Bhardwaj is Associate Professor and Gynae Oncosurgeon, AFMC Pune, and he has done fellowship in MIS. He's also done diploma pain and palliative care from the Kerala. So over to you, Dr. Colonel Bikram Bhardwaj, for this to begin with this session.
Thank you, Chairperson, for the kind words of introduction. First of all, I would like to thank the organizers for giving me this opportunity to be part of this esteemed platform. Before we start the session, let me introduce the panelists who are part of this session.
Next slide.
We have Dr. Bindya Gupta, who is Associate Prof. Obs and Gynae from UCMS and GTP Hospital, Delhi. Dr. Savita Verma, she is Consultant Gynecologist, Dr. Makad Orthopedic and Maternity Center, Saharanpur. Dr. Hitendra Kalita, who is Head and Senior Obstetrician and Gynecologist, Swasti Hospital, Guwahati. We have Dr. Lieutenant Colonel Dr. Monica Saraswat, who is a budding gynae surgeon from Armed Forces, and she's presently posted at Military Hospital, Roorkee. And we have Dr. Raka Guleria, ma'am. She is Senior Obstetrician and Gynecologist, Fortis, New Delhi. I welcome you all the panelists for today's session. As you all know, adnexal masses, they pose a dilemma at times, diagnosing the mass and at times coming to a conclusion what management we can offer our patient. It becomes challenging for the treating gynecologist at times. So just to ease this dilemma, we'll be bringing in front of you 3 case scenarios in next half an hour, which will address this dilemma and give you a fair idea how to address these scenarios at your workplace. So we'll start with the case scenario first. A first case, a 25-year-old lady presented with pain in the lower abdomen for last 2 months, and on examination, it was found that she's got a right-sided adnexal mass around 7 centimeters, which is tender and with restricted mobility. Dr. Bindya, can you take this question? What all things you would like to ask in the history to this patient to come to a provisional diagnosis?
Thank you, Colonel Bharadwaj. And at the outset, I would like to thank Dr. Kanika and Dr. Manas Viswas for giving me this opportunity to be a part of this panel. So regarding this case, this is a 25-year-old girl with a mass and with pain abdomen. So first of all, I would like to rule out what is her LMP or the last menstrual period, and whether there's any period of amenorrhea in her case, or whether she has any menstrual irregularities which are associated. alongside whether she has any history of any dysmenorrhea, and if she is sexually active, if she has any history of dyspareunia, any associated bladder bowel symptoms, or systemic symptoms like loss of weight, loss of appetite. And also, what is the nature of the pain? I would like to ask whether she has any acute episodes of pain. So, we have to also rule out some torsion in case she has any acute exacerbations. That also we have to keep in mind. And apart from it, if she is like married, she has, what is her obstetric history, whether she's doing any contraception, and whether she has any past history of any tuberculosis or any family history of tuberculosis, that also has to be kept in mind. And in case she has any family history of any malignancy also, that also we need to ask. So quick brief history is very important to delve into the details of the case.
Yeah, very rightly brought out. History of amenorrhea is very important in these patients, especially the reproductive age group. And at the same time, all other points as you brought out, dysmenorrhea, dyspareunia, any vaginal discharge, any family history of tuberculosis, any history of infertility treatment. So these are all pointers which help us in clinching the diagnosis. Yeah, Dr. Monica, can you take the question number 2? How will you further investigate after taking this brief history? You come to a conclusion that you are either dealing with some infective pathology or it is a benign pathology. So how will you further investigate to come to a confirmatory diagnosis? Dr. Monica? Dr. Monica, are you
please
there?
unmute yourself.
Dr. Raka ma'am, can you take this question?
Yeah, okay. Well, thank you, Kanika, for inviting me to be part of this panel and making me reopen my textbooks. Thank you very much. This patient, I think we need to first do an ultrasound to see exactly what we're dealing with. And if we are suspecting anything, complete blood count, complete blood investigation to rule out any infective pathology, we will, yes, do a CA-125, but that is also to rule out other things, and again investigate her further regarding these parameters, do a complete blood count, do a CA-125 ultrasound, and then proceed from there.
And any other tumor markers you would like to do other than CA-125, keeping in view her age?
Yes, we will look for the keeping her age in mind, we look for the germ cell tumors. So we look for alpha fetoprotein, we look for the LDH, we look for the beta HCG. So we all do all these.
Yes.
Tumor.
So basically, we'll investigate her in terms of tumor markers and imaging in the form of a transvaginal sonography, or if need be, a higher imaging in the form of MRI. So this is the
MRI,
picture
yeah.
what we got on ultrasound, that she's having a right at axial mass with a ground glass appearance, which is present on the sonography. Her CA-125 is raised, it is around 450, and HE4 levels are 40. All other tumor markers are within normal limits, and Roma index is 5.6%. Dr. Hiten sir, can you take the next question? What type of surgery, if you are going for a surgical management in this case, you would like to plan, and what will be the extent of surgery in this patient?
Dr. Bikram, Dr. Kalita could not join us.
Dr. Monica, can you take this question? Dr. Bindia, ma'am.
Monica.
Shall I answer it?
Yeah, please.
Yeah, all right. So she is 25 years old now. The CA-125 is pretty high. It was 450, and her HE4 also was 40. So it is, although there is, the ultrasound doesn't show any solid area, no papillary projections, and the signs, the M signs, if you go by the IOTA ruling, so those M signs are not there, just it is a simple ground glass appearance. So considering this is a possibility of an endometrioma, I will keep in this. And if like I do laparoscopy, so if the laparoscopic surgeon is quite confident that there will be no spillage and we can have an in-bag, extraction without any spillage. So laparoscopy is can be done in this case. And however, like in those people who are not confident, in that case, we can even go for an open surgery. And the extent is, in this case, I would also go for frozen section because, you know, this, although there's a ground glass appearance, CA125 is 450. So in that case, I would also like to go for frozen section in this patient. And depending on the intra findings, then we can proceed according to it. In case if it's just an endometrioma, then we just do a cystectomy. And if we, sometimes in an endometrioma also, you know, we have had surprises that when we did the cyst, there were some papillary projections inside. And when the frozen was done, it was suspicious of something. So in those cases, it depends on what the intra findings are. But right now, we can take the patient for laparoscopy and safely remove the cyst because it looks like an endometrioma.
Yeah, I do agree with you that CA125 is raised, but CA125 is not a very specific marker.
Exactly.
That's why I purposely put HE4 in the slide. HE4 is within normal limits, that is more pointed towards a benign disease. So we can safely offer a laparoscopy. Roma index is also pointing for a benign disease only. It is 5.6% only. So with all this background, a young patient who's got a tender mass, though CA125 is raised, CA125 can be raised in certain benign conditions like fibroids, in pregnant patients, in patients of chronic PID, and even in tuberculosis. So HE4 is a better marker to distinguish between benign and malignant. And at the same time, Roma index is pointing that it is a benign disease. So what you told, we can go for an in-bag delivery of this mass, but we can offer her a laparoscopy. And in case need be, we can do a cystectomy also, keeping in view her future fertility. But you will have to explain the patient that by doing a conservative surgery in the background of endometriosis, she can have recurrence in the times to come.
Dr. Bikram, can I interrupt? I'm the chairperson, but I think, you know, I just have to put few points if you don't mind.
Ma'am.
I'm Dr. Manju Khimani, right? So, Dr. Bikram, like Dr. Bindya said, you know, we'll remove this mass without spillage. That is not possible in endometriosis. The moment you touch endometriosis, the spillage occurs one thing. She's a young girl, so we'll only do a cystectomy.
Yes,
we will not remove that.
Planning to do cystectomy only.
You can
cystectomy only for her,
and
if
you
possible,
can prevent
then,
even with
there is a lot of chances of the spillage in endometrioma. So in case it's an endometrioma, we are quite confident that, you know, we are dealing with a benign mass, and I said cystectomy only for this case because she's 25 years old.
No, you said you will remove it in toto in a bag. So that's why I just said, you know, that, you know, yes,
so in case, so in case if it is possible, but however, the chances of rupture in an endometrioma are almost there.
Always there.
Most of the time, when we do a cystectomy, it is there. So, but we have to be careful, and we try to remove the complete cyst. And also, we should not, you know, do a partial cystectomy. Try to remove the complete cyst and
complete cyst
avoid.
Needs to be removed. Even that,
avoid recurrence.
Yeah, even that, ma'am, we can attempt in a bag only. You can still prevent spillage by putting a bag underneath the mass before going for an incision over the mass. So coming to our case scenario number 2, we've got a 28-year-old nulli gravida who is married for 9 months. This is a real life scenario which I only operated around 8 months back. She came to me with abdominal distension of 9 months. On clinical examination, she had a large mass, 30 centimeter on the right side, and fluid thrill was there. On bimanual examination, we could feel a large, soft, cystic mass, which was corresponding to around 28-week size gravity uterus. Surprisingly, when we did her tumor markers, they were all nearly normal in their values. Upper and lower GI endoscopy was done, which was again normal, and a higher imaging in the form of contrast enhanced MRI was done, which showed a large thin walled abdominopelvic cystic multiloculated mass with no papillary projections, no mural nodule. Raka ma'am, what will be your differential diagnosis in this background?
Well, keeping the history, your examination and the investigations in mind, my first diagnosis would be a benign ovarian mass. It could be serous cystadenoma, mucinous cystadenoma, but other non-gynecological conditions like a mesenteric cyst should also be kept in mind, because they are very notorious to mimic such tumors. So these are the things one should keep in mind before going in for any sort of management of this patient.
Yeah, another thing in such young patients, when they present with large masses and nearly normal tumor markers, we should entertain the entity of borderline ovarian.
Borderline tumors, yes, definitely.
Yes.
Yeah.
So borderline is another entity which we should entertain in these patients. Borderline tumors, I'll just give a brief outline. They usually tend to occur at least 10 years earlier than their malignant counterparts in the age group of 25-30 years, and tumor markers are not of much help in these patients, and fertility preservation surgery can be easily offered to these patients. So whereas the pathological criteria for borderline is, they usually have absence of stromal invasion, nuclear atypia with increased mitotic activity, and papillary projections. These are the three criteria which on histopath can make a diagnosis of borderline or low malignant potential ovarian tumors. Dr. Bindya ma'am, any role of frozen section in such cases?
Sorry, Kanika, were you saying something, Dr.
No,
Kanika?
I was just reminding Dr. Bhardwaj that Dr. Monica is also audio-visual complete now. So.
Okay. So shall I take this question?
Yeah.
Okay. So in this case, when you're doing a surgery, so role of frozen section, say there's a large tumor, multiloculated, and most likely this kind of a picture is of mucinous tumors. So mucinous tumors, large tumors, they have pretty more discrepancy with the frozen as well as the final histopathology. So the chances of having the familiarity is only up to 50 to 60%. Frozen section is very useful in mainly for serous tumors. The success rates of the same report with the final histopathology is more than the serous tumors or when the smaller tumors. Also on frozen section, like borderline tumors, if you're doing frozen section, 10% can get upstaged and be on a final histopathology be invasive cancers. So overall, the success of frozen tumors in borderline cases around 70%, 65 to 70%. So we have to take it with a pinch of salt when we are, relying on the frozen report in this case.
Yeah, frozen section is of much help in epithelial and germ cell tumors, but in the entity of borderline ovarian tumors, the accuracy is less. It is just to the tune of 70% only. And as you have rightly brought out, 10 to 15% can get upstaged, and only around 3 to 5% cases we have downgrading of the
tumor.
Yeah. So we also offered this patient a frozen section, and it turned out to be borderline mucinous tumor. So, Dr. Monica.
So, good evening, sir.
What is FPS?
So, good evening, everybody. First of all, I would like to apologize for my internet connection initially. So, starting with the question, FPS or the fertility preserving surgery, also known as the fertility sparing surgery. It is the primary modality of treatment for the borderline ovarian tumors, because the borderline ovarian tumors are basically less aggressive and have better biological behavior and better prognosis. This surgery is defined as a surgery in which we preserve the uterus and at least one ovary, either completely or part of the ovary. Mainly, we offer this to the young patients in the reproductive age group who definitely after an appropriate counseling, who have not completed their families. And the surgeries which we can actually offer them are either a unilateral cystectomy, a unilateral salpingo-oophorectomy. We can also offer bilateral cystectomy or a unilateral salpingo-oophorectomy with a contralateral cystectomy.
Can we advise this patient fertility preservation surgery?
Definitely, sir. The patient is very young in a reproductive age group and has not completed her family. We should go in for a fertility sparing surgery, as there are no differences in terms of an overall survival in borderline ovarian tumor if we go for a radical approach or a conservative approach in these kind of tumors. Even the pregnancy rate after the fertility preserving surgery have been as high as 80%, range is between 30 to 80%. So definitely it has a role in this patient, sir.
So what all things you will like to include as part of fertility preservation surgery in the background of borderline mucinous? What all surgery you would like to do?
Sir, a complete surgical staging, but preserving the uterus and the ovary, one ovary or part of an ovary.
Yeah, good. And how we will follow up this patient in future after the surgery is done?
Yeah, so follow-up of the patient is very, very important. But since there is a lack of a universally accepted guidelines as to how we need to follow up, it is generally recommended that a close follow-up of these patients are recommended for the first year, maybe every 3 months in the first year, with a complete history, a clinical examination, a tumor markers, which was raised preoperatively and in imaging studies. So first year, I would say 3 monthly follow-up, thereafter 6 monthly to yearly follow-up for at least 10 years, sir.
Yeah, that is the take-home message. Borderline tumors, they tend to recur at times very, very late. There have been instances where the patients have come after 15 years also. So at least 10 years follow-up with a clinical history, examination, imaging, and at least the tumor markers which were raised pre-op should be done in these patients. Now moving on to our next scenario. In the third case, we've got a 65-year-old postmenopausal lady who's presented to us with pain lower abdomen for last 2 months, and clinical examination revealed a uterus which is normal in size. An axil mass is present on the right side around 5 into 6 centimeter with restricted mobility, and along with that patient has got ascites. Raka ma'am, how will you evaluate this patient with this background?
Well,
what
firstly,
tumor markers, my question is basically what tumor markers you would like to do in a 65-year-old?
Well, in this patient, she's postmenopausal, 65-year-old with an adnexal mass. I would like to do a CA125 and an HE4 marker. These are the two main markers which are very significant in postmenopausal women. So these are the ones I would concentrate on, definitely.
Yeah. Along with that, we can even offer them CEA and
CEA,
CA
19.9, yes. Yeah.
The only thing is that we should omit germ cell tumor markers. Any patient beyond 40, the incidence of germ cell tumors is very, very low. Only germ cell tumor which is seen closer to 45 is the dysgerminoma. Other germ cell tumors, they do not occur at this age group. So we should offer them these 4 markers. Dr. Bindya ma'am, which imaging modality in this patient?
Sir, in this, see, any adnexal mass, so the first ultrasound we will do, first imaging is basically an ultrasound in which we have to evaluate the mass, and we will look for the nature of the mass on a good TS combined with the TVS. So accordingly, and it looks like a malignant mass because she has ascites also, and maybe if a CA125 is raised, in case we are suspecting a malignant mass, then we will go for further imaging, and which will be a comprehensive contrast enhanced CT scan of the abdomen and the pelvis, and sometimes we also combine a CCT of the chest along with it also. That will help us to understand the distribution of the disease, whether there is any extra ovarian implants or extra ovarian disease, and what is the amount of ascites, or whether we have what is the involvement of the other organs like the bowel, the liver, etc. So that will be my
very true.
Approach.
Patient is already having advanced disease. She's already presenting to you with ovarian mass along with ascites. So we'll definitely go with a contrast enhanced CT to see the volume of disease so that we can plan the management, whether we can go for upfront surgery or not.
Or a new adjuvant treatment, chemotherapy.
Dr. Monica, any role of FNAC or USG guided biopsy in such patients?
So the role of FNAC and true-cut biopsies is mainly done for an early stage CA ovary. If you want to go for an upfront surgery, because it actually may delay the diagnosis and treatment, and there is also a risk involved in upstaging the disease. However, there is a role in the subset of those patients who presents to us in the advanced stage disease and with gross ascites, where we definitely require a tissue histopathological diagnosis before we subject these patients to neoadjuvant chemotherapy. So no role in early stage, I would say, and a definitive role in the advanced stage and with gross ascites.
Yeah, definitely. When you are dealing with the stage 3, stage 4 CA ovary, then definitely when the patient is a candidate for NACT, we do subject these patients to FNAC or USG guided biopsy for tissue diagnosis to start chemotherapy. Otherwise, in early stage, when we are going for an upfront surgery, there is no role at all. Rather, we will be upstaging the tumor by putting a needle into the tumor. Raka ma'am, can you take this question? When should a patient be referred to a onco center or a gynae onco surgeon for further management? What parameters you will take into account to decide this?
Well, I would firstly go on the clinical features, then on her ultrasound and CT findings. If I'm finding a mass with deposits, with enlarged lymph nodes, with any mets anywhere else, I would definitely refer her to a gynae oncosurgeon, because it is not a simple surgery and it should be done by people, you know, who are experts in it. Plus, if her tumor markers are very high or she has any other comorbid conditions also, even then I would prefer her to undergo any sort of surgery under a gynae oncosurgeon, where she will be under follow-up, and then chemotherapy or adjuvant therapy can be planned at that same place only.
Yeah. So we have got certain scoring systems. As you all know, RMI, what is known as the risk of malignancy index, in which we take three things into account: the menopausal status, if the patient is perimenopausal or postmenopausal, the absolute value of CA125, and we take into account ultrasound features in the form of bilaterality of tumor, solid areas, ascites, metastasis, or it is a multiloculated tumor. If two or more than two features on ultrasound are there, we give a score of 3 multiplied by CA125 level, and if it is postmenopausal, the score is 3. So the overall score, if it goes beyond 200, then she definitely warrants a onco opinion. And another thing which you can do is the ROMA scoring, which is a calculator to calculate the risk of malignancy in a patient. Here we take into account the postmenopausal status of the patient along with the value of HE4 and CA125. It is an app. When we put all the three things into the app, it gives us a score. In premenopausal patients, less than 11% goes in favor of low risk for malignancy. Similarly, in postmenopausal, if the risk is less than 29%, it again favors a low risk for malignancy. So what happened in our patient? She had a ROMA score of 7,056, 82%. Her RMI index was 7,000 plus, and she had IOTA 3M features. Dr. Monica, can you elaborate what is this IOTA?
Colonel Bhagwat, we'll just have to wind it up. So perhaps this could be the last question.
Yeah, ma'am, this is the last one.
Yes, sir. Basically, IOTA stands for an International Ovarian Tumor Analysis. It was formed in 1999 by Dirk Timmerman, Lal Winton, and Tom Bone. The basic aim behind this classification system was to develop an internationally standardized classification system terminology to describe the sonographic features of adnexal masses and also discriminate between the benign and the malignant ovarian masses. So basically, in the hands of an expert radiologist, it was found to be conclusive in 75% of cases. So we have IOTA rules to define whether the mass can be a malignant mass or benign mass depending upon the features. So there are B features, which are 5 in number, and M features, which are again 5 in number. So in B features, we have B1, which is a unilocular cyst, B2, which has presence of a solid component, where the largest solid component has a diameter of less than 7 mm. B3 is the presence of an acoustic shadow. B4 is a smooth unilocular tumor with the largest diameter less than 10 centimeter, and B5 is no blood flow. So M features, in the M1, we have an irregular solid tumor. M2, we have presence of ascites. M3, at least 4 papillary structures should be present. M4 refers to an irregular multilocular solid tumor with largest diameter of more than 10 centimeter, and M5 with a very strong blood flow. So basically, depending upon these features, we have 3 rules of IOTA. So rule number 1 is classify the mass as malignant if at least 1 M feature and no B features are present. Rule number 2, classify the mass as benign if there are no M features or 1 or more B features are present. And rule number 3, if both M features and B features are present, or if no M features or B features are present, classifier is at inconclusive.
Dr. Monica, we'll just have to stop at that.
Sure.
Yeah, just ma'am, last slide, a take-home message. We should offer tumor markers as per the age of the patient, have a sound clinical judgment so that we are able to distinguish whether we are dealing with a benign or a malignant mass. Fertility preservation surgery is the route nowadays in young patients. Surgical staging when you are dealing with a CA ovary, that too at a onco center, and wherever required, frozen section, if it is available at your center, please utilize it. It helps a lot in managing such complex adnexal masses where there is always a diagnostic dilemma. Thank you.
Thank you. Would request Dr. Abhilasha Chaturvedi for her comments on this.
It was wonderful. I'll not take the time because we are already late. It was a great session, but most important part was that we gynecologists are guided where to refer the patient to the oncosurgeon. That's the biggest advantage of attending this meeting. Thank you, everybody.
Thank you so much, Vikram Bhardwaj, and all our esteemed panelists. Thank you.
Hello.
For a great session.
Hello.
And yeah, Dr. Abhilasha, thank you. So I would just hand over to Dr. Shifali, who's going to take over for the update.
Yeah, that's all. That's all. Thank you.
So thank you, Dr. Kanika. And now we move on to our next session, which is the awaited session on updates in gynae-oncology. And for that, I would like to invite my chairpersons for the day. The first chairperson will be retired Major General Reena Bhardwaj. So Dr. Reena Bhardwaj has previously served as professor and head pathology at Army Hospital RNR, and she is currently working as senior consultant oncopathology in Indraprastha Apollo Hospital. Welcome, ma'am. And our second chairperson would be Dr. Aarti Sareen, who has served as professor and head of the department radiation oncology at Army Hospital RNR and is presently the commanding officer of the flagship hospital of Indian Navy, INHS Aswini. Welcome, ma'am. And third chairperson is Dr. Amit Bhargava, and who is a senior consultant medical oncology in Fortis Hospital, Vasant Kunj. So welcome, sir. I welcome you all for this update session, and I would request you to introduce the respective speakers also. Please take over. Thank you. Dr. Aarti Sareen, ma'am, you please introduce the next speaker.
Is the privilege of introducing to this August gathering Dr. Umesh Mahanta Shetty, Director and Professor Radiation Oncology at the Homi Bhabha Cancer and Research Institute, Visakhapatnam. Umesh has been a colleague as well as a friend, and who does not know Dr. Umesh Mahanta Shetty and his achievements as far as oncology is concerned. Umesh Mahanta Shetty is actually synonymous with Tata Memorial Hospital, and we're all extremely proud of his achievements. So without coming between you and what he's going to tell us, I would now introduce the topic, adoption of image-guided brachytherapy in cancer cervix, the Indian context. Dr. Umesh Mahanta Shetty, kindly take over.
Thank you, Aarti, for that nice, kind introduction, and I would like to thank Dr. Manas and Dr. Charu Garg for giving me this opportunity. I would share my screen, and the mandate given to me in 15 minutes is to give you an overview of what has happened in image-guided adaptive brachytherapy for cervical cancer with a special reference to Indian context. So to set the ball rolling, this is a slide which shows what we have been doing for decades. And I'm sure there are many gynae oncologists who would agree that the chapter in gynecology would be dealing with cervical cancer treatment in terms of radiation and brachytherapy. And we always were bombarded, even in MBBS, with ICRU38, point A, X-ray based treatment. And what I've shown in this tall bars here, bar chart here, is the outcome of these patients who have been treated with conventional brachytherapy. And what I've highlighted is stage 2 and stage 3. This is major problem in our country. And if you see the outcome, local control ranges from 55% to 75% for stage 2 and stage 3. And in the other part of the slide, the toxicity which has been reported with conventional brachytherapy is roughly around 10 to 15% grade 3, which means out of 5 patients, at least 1 patient will have some toxicities which will hamper her quality of life. But I'm fortunate enough to be in this fantastic world where a lot of changes, lot of developments happened in last 2 decades for cervical cancer brachytherapy. And what I would like to present in this meeting is more on applicator development and the use of newer imaging modalities rather than X-ray for cervical cancer brachytherapy. And because of these 2 developments, image-guided adaptive brachytherapy is more or less a new standard of care for cervical cancer today. And I will try to convince you. So this is the same bar chart. And the intention of showing this bar chart is that in last two to three decades, the intention was to improve the outcomes. And this to a large extent came from addition of chemotherapy as a radiosensitizing agent. And it helped to improve the outcome by 5% to 10%. But then the question was, if we adapt these newer applicators as well as newer imaging, can we improve the outcome further in terms of local control rates, survival, as well as morbidity? So because of this, what has happened is the contemporary radiotherapy practice now, when a patient walks into my OPD for cervical cancer, the prescription is no more simple radiation therapy. Now it has become more and more complicated in terms of we do have a planning aim based on the stage, based on the patient's capacity to tolerate the treatment. And more importantly, differentially, we try to define what is the dose which has to go to the primary tumor at cervix, what is the dose which has to go to the gross disease in the parametrium, for example, in stage 3, what would be the doses to the nodes if there are no nodes on imaging, or if there is node, then what the doses would be delivered with contemporary external beam radiation. So, and the doses, total doses now, we calculate what is called as biologically equivalent doses. And these doses become very vital to understand the outcome, both in terms of disease as well as toxicities. What also has changed over time for us is that when I was resident, we were giving brachytherapy as early as possible after starting external radiation. But this publication from University of Vienna shows that it is better to target a smaller tumor during or near the ending of the external beam radiation. And because of this, now we have different fractionation schedules which are implemented in routine clinical practice. Having said that, what is most important, which has not changed, is the treatment time. External beam plus brachytherapy should be still within 7 to 8 weeks, and this has a major bearing on the outcome. Coming to the tips and tricks. What I do in my clinic is that any patient who has completed or near completion of external beam, we try to categorize them into various categories. For example, category 1, when there is no residual disease or residual disease confined to cervix and limited to immediate paracervical tissues. Category 2 would be if the disease is going into medial parametrium and or upper vagina. And the third category is if it is extending into distal parametrium. This classification becomes very vital because your brachy application as well as the treatment and the doses has bearing on what category the patient belongs to. The next important slide is a very basic slide for radiation oncologists who would practice cervical cancer brachytherapy. This is a standard pear-shaped distribution which we would achieve with a standard intracavitary application. And when we go into the details, for non-radiation oncologists, the red pear is the area which gets very, very high doses. And within that is even higher doses to the extent of 200 to 250% of the dose which goes into the cervix. But if I go into the details, at the level point A, we tend to treat roughly around 4 centimeters width. If I come 1 centimeter below, roughly around 5 centimeter width, and another centimeter below is 6 centimeters width. How this information is important is shown in this slide. If the patient has residual disease confined to the cervix, which is shown in the cartoon here, or immediate medial parametrial tissue, then your conventional intracavitary brachytherapy with pear-shaped distribution is good enough for treating adequate doses with brachytherapy. Whereas if it is the residual disease is going beyond medial third parametrium, then you can see that the residual disease in the lateral parametrium beyond this red line is undertreated. And this is the reason why the outcome in 2Bs and 3Bs is less as compared to patients in 1B because of this situation at the time of brachy. So the first development which happened was in the form of applicators. Earlier, we had conventional stainless steel applicators. Now we have CT-MR compatible applicators. What it means is they do not throw any artifacts if we put these applicators in place and imaging is done in the form of CT or MR. The second development was, apart from being CT and MR compatible, now we have option to push needles through the vaginal ovoid or the ring, and these needles go into the parametrium additionally apart from the standard intracavitary, and we call this approach as combined intracavitary and interstitial approach. And with the start of this Vienna applicator, now we have at least 3 or 4 new applicators which are in market where state-of-art brachytherapy can be application can be done for any clinical scenarios seen in the routine clinical practice. For radiation oncologists, what is the principle? This is a pear-shaped distribution with intracavitary. When I push needles into the parametrium, the red line gets pushed more laterally to treat the medial parametrium to a larger extent. So if we are treating 2 centimeters on one side, now it becomes 3 centimeters. This is a very busy slide which shows various steps involved in brachy application. What I want to highlight here is 2 things have become very vital now and mandatory. One is use of this intraop ultrasound to find out whether there is perforation of the uterine cavity and that the applicators are going in the right place. Second, when we are trying to push needles, if you have a transrectal ultrasound probe, you will be able to guide the needles into the parametrial tissue appropriately. And the additional step which is involved apart from doing standard intracavitary is the ring or the ovoids with the needles are pushed into the vagina, and the needles are negotiated or progressed in the parametrial tissue for roughly 3 to 4 centimeters, sometimes even 5 centimeters. But the principles still remain the same as intracavitary. Dr. Charvo made a specific request that these applicators are very expensive. So how do we do it? Of course, Tata Hospital is also government of India. So we didn't have fancy applicators when we started this. So this is just an example how you could start in your department. What we did was we used the red rubber catheter, roughly around 3 centimeters. And in this red rubber catheter, we started piercing the needles and making this as a template. And this template would then be applied after doing the standard intracavitary application. The needles with the rubber tube are placed lateral to the ovoid surface, in the lateral fornix. And very important is the needle tips are within the rubber tube when I push it inside. Then once it is in place, lateral to the ovoid, each needle by needle is progressed into the parametrial tissue roughly for 3 to 5 centimeters, depending on my examination findings. And this is quite easy. There is some learning curve for people who are not used to interstitial, but once you do 5 and 10 cases, this will be easily possible. Then we progressed in making some grooves into the ovoids before these Vienna applicator or uteric applicator came, and then try to negotiate the plastic tubes or needles through these ovoid surfaces so that we could implement these brachytherapy applicators in the form of treating more advanced disease at the time of brachytherapy. We also had some successful collaboration with the University of Vienna, where we also modified the Vienna applicator, put on add-on caps, and with the add-on caps, we were now able to push another set of needles into the lateral parametrium so that more advanced disease can be catered to with high doses of brachytherapy. And this is dosimetrically shown here. If I put one plane of needles, we treat 3 centimeters. If I push another set of needles, we roughly treat around 4 to 4.5 centimeters, which is more than enough for most of the cervical cancer patients. So how do I utilize this? Not every patient goes for advanced brachy. Very simple. The choice of applicator depends on the residual tumor and then availability of applicators. And depending on the category, I would do intracavitary alone or intracavitary plus interstitial or advanced interstitial as shown in the previous pictures. Coming to second part, more fascinating was incorporating the imaging modalities. The gold standard approach for sure is clinical examination, 3D documentation, and an example of that 3D documentation is shown here in this picture. And in MRI is the gold. It's such a beautiful image to see the gross disease at cervix, the normal tissues in the cervix, the normal endometrium, and other anatomical structures which are in the near vicinity. Having said that, it is very difficult to implement. So we have done a lot of research on CT and ultrasound, where we are now practicing the image-guided brachytherapy even in non-MRI environment. I will not go into the details. I think you have a talk or by Supriya later. This is an example of a patient who has been treated with advanced application and MRI, and this is example from ICRO 89 where we have contributed. And in this patient, you will agree that this patient probably had a very, very less chance of local control if this disease was seen so extensive at the time of brachy, and it's shown is here, and the picture shows extensive disease. But what we landed up achieving is very, very high doses to target and very, very less doses to bladder, rectum, and sigmoid. Did it translate into clinical benefit? Yes, these pictures are serial MRIs done at 3 months, 6 months, 12 months, and now post 38 months, patient is perfectly fine, sexually active, no evidence of disease anywhere. So there is a lot of literature which has come up in last 10 years. I will not go into the details, but this is a slide which summarizes our experience at Tata Memorial Hospital, because we always feel that whatever can be implemented in India could be done, implemented in Tata, could be done anywhere in centers in India. So we did a systematic study to find out what is the exact outcome. And you see here nice pictures, Kaplan-Meier pictures, which shows excellent outcome. And when we checked with the historical cohort, we had an increment of roughly around 15% in the outcome, which was quite exciting for us. And then subsequently, we participated in EMBRACE studies, and then you will see our final results of EMBRACE study, which has come in Lancet Oncology in June 2021. 95% local control rates, irrespective of stage, is something phenomenal outcome which has not been reported in cervical cancer, especially for advanced disease. Last few slides on other imaging modalities. CT scan is a very popular imaging modality, easily available for radiation oncologists. So what we have done is we have tried to identify two environments where CT is utilized without a target concept and CT with a target concept. It's very easy for without target concept. We do a brachy application, CT is done, we contour rectum, bladder, and sigmoid. We do a standard intracavitary application, identify the doses to OAR, and document the doses to point A. This is very easy and simple to implement in any of the centers. The second important is the CT-based target concept. This is a bit difficult and dicey and is tricky to implement, because you need to have a fixed protocol in terms of imaging for CT, in terms of IV contrast, bladder filling contrast, and adopt the MR-based definitions of the target to a large extent. And this I will show you in the last slide. The other imaging modality which was important was the ultrasound, especially transrectal ultrasound during the brachy application is quite useful and handy, where we identify the residual disease in relation to the target. So this is a workflow which shows how we could implement CT and ultrasound, where target can be contoured on CT. I will not go into the details, but I would encourage everybody to go through this latest recommendations, which was a joint venture of Indian Brachytherapy Society, Jack Estro, and ABS, where CT-based contouring has been defined in detail for various environments wherein people are practicing. And this is just
Dr. Umesh, sorry to interrupt. So if you can wind up a little quickly.
Yeah,
sure. Thank you, sir.
So to conclude, there are two reports which have come in recent past, one ICRO 89 and another is IBS guidelines, where every practical process has been defined in detail. And this has come from various ROI ISTRO teaching courses which we have undertaken. And this is the fourth course. And I must admit that there are quite a few centers who have successfully implemented this practice. So my take-home message to all the young people listening to me is that strengthen your brachy skills, embrace newer imaging modalities, implement image-guided adaptive brachy so that you can revive and refine brachytherapy for cervical cancer and achieve best outcome in terms of disease as well as toxicities. Thank you very much.
Yeah, thank you, sir. So we'll take the questions in the end. I would request the chairperson to introduce the next speaker, please, Dr. Amit.
Yeah, hi, good afternoon, and I really thank the organizers for inviting me for the same. It's a pleasure to introduce Dr. Seema Gulia. She's a professor in medical oncology at Tata Memorial Hospital. So without wasting much time, Dr. Seema, please take over the dais.
Thank you so much for the introduction. I'm going to speak about the recent updates in the ovarian cancer. My slides are visible?
Yes, ma'am.
Yeah, right. So I have divided the talk into three main areas. One is the recent development in the preclinical areas, phase 1, phase 2 clinical trials, and the phase 3 clinical trials. Sorry. So enduring question in ovarian cancer research has surrounds the cell of origin of high-grade ovarian cancer. The dualistic cell of origin will support the notion because we see significant biological heterogeneity in the high-grade serous ovarian cancer. And this is the recent study which looked at the organoids derived from the ovarian surface epithelium as well as the fallopian tube epithelium to generate the tumors that resemble the human tumors. Later on, further extension of the study, the CRISPR modification was used to knock out the tumor suppressor gene, particularly the T53, BRCA1, NF1, and the PTEN mutation. And it was shown that both the types of tissues can give rise to ovarian tumors. However, the tumors that derive from the mutant fallopian tube tissue, they expanded more rapidly and they had a higher malignant potential. Moreover, this study also showcased that there is a distinct lineage-dependent sensitivity to therapies commonly used in ovarian cancer. For example, the tumors that were derived from the oviduct, that is from the fallopian tube tissue, they were more sensitive to paclitaxel and PARP inhibitor, but less to cisplatin. However, the tumors that derive from the ovarian surface epithelium, they were more sensitive to the cisplatin compared to PARP inhibitor and the paclitaxel. We have seen that immunotherapy have improved the outcome in lung cancer and melanoma, but the immunotherapy has not shown to be of much response in ovarian cancer. And this is a phase 1, phase 2 study where niraparib was combined with pembrolizumab in patients who had recurrent platinum-resistant ovarian cancer. The response rate was only 25% and the median PFS was 3.4 months. None of the known covariates like either presence of BRCA mutation or HRD status could identify the patient who had a response versus those who did not have a response. So the immunogenic profiling from the same study, that is Keynote 162 trial, was done along with the highly multiplex single cell imaging on the tumor samples from the patient who were enrolled in the trial. And the authors found out two determinants of response. One is the mutational signature 3, which is synonymous with the defective homologous DNA repair mechanism. And the second is the positive immune score, which is a surrogate of interferon primed exhausted CD8 positive T cells in the microenvironment. So if we look at the same data again, patient who had a immunogenic signature 3, they had improved PFS compared to those who did not have that signature. Similarly, if we look at this waterfall plot, patient who had a positive immune score, they had a significant response to this combination compared to those who were either negative for this score or who had signature 3 was absent. So what we conclude from this study, that the combination of PARP inhibitor and immunotherapy is effective in a tumor cell, which shows signature 3 in the immunogenic profile, as well as which also expresses the PDL1. Similarly, the tumor microenvironment should also express increased level of PDL1, and they also should have presence of exhausted CD8 positive T cells. There have been significant advances in the modulation of cell cycle, and the best example is the inhibitor of V1. Whenever there is a single strand or a double strand break, the DNA repair mechanism gets activated, and this will activate the V1, which basically inhibits the cyclins and cyclin dependent kinase, so that the cell does not progress from GT to M phase. But if we inhibit this V1, it will lead to transition of cell from G2 to M stage, and thus it will make the cells more sensitive to the chemotherapy. And the same concept was tested in this recent study, which is a phase 2 trial where platinum sensitive relapsed ovarian cancer who had P53 mutation were randomized into paclitaxel alone versus paclitaxel with adavosertib. And we found that addition of adavosertib has led to improvement in progression-free survival in and above with addition over and above the chemotherapy. They also looked at whether the improvement in PFS was affected by the type of P53 mutation seen, and it was seen that patients who had a hotspot mutation in P53, they had the best PFS compared to rest of the P53 mutation. Similarly, the adavosertib was also recently tested in platinum-resistant ovarian cancer, where adavosertib was combined with gemcitabine, and then they looked at the results. So in platinum-resistant ovarian cancer, addition of adavosertib has led to improvement in progression-free survival, and also there was an improvement in overall survival with the use of this new agent. We have seen that in last 2 years, there is significant increase in the use of PARP inhibitor, and various trials in first-line setting have shown improved progression-free survival with the use of PARP inhibitor versus placebo. There have been slight differences in the inclusion criteria of this trial and the different PARP inhibitors that have been used. But if we look at the results, use of PARP inhibitor in first-line setting in patients who had either achieved CR or PR to first line of therapy has improved the progression-free survival. If we look at the SOLO-1 trial, the progression-free survival has gone, and has improved to 45 months compared to the placebo, and this improvement is quite significant compared to the bevacizumab, which was used in earlier trials. But if we look at the overall results, the benefit is seen maximum in patients who had either germline or tumor BRCA mutation. Second best effect was seen in population who had HRD positive with or without BRCA mutation. But in patients who had HRD negative, there the benefit of PARP inhibitor was only modest. Similarly, the PARP inhibitor have also been used as maintenance therapy in platinum-sensitive relapsed ovarian cancer, and this is the updated analysis from SOLO-2 trial, which has shown that with the use of PARP inhibitor as maintenance therapy in patients who had platinum-sensitive ovarian cancer and who had either stable disease or partial response to the most recent platinum-based therapy, there is an overall survival advantage, and which is up to the magnitude of 12.9 months. We have also seen that there is now an evidence to suggest that secondary cytoreduction does improve outcome in relapsed ovarian cancer, and this was the results presented in ASCO 2020. This is the DESCOP-3 trial, where 407 patients who had recurrent platinum-sensitive relapse, they were randomized into 2 groups. One group received surgery followed by chemotherapy, and second group received chemotherapy alone. And you can see clearly there is significant improvement in the overall survival. The point to be noted here is that this trial selected patients who had a positive EGO score, which was defined as performance status of 0 and a ascites volume which is less than 500 ml and a complete R0 resection at the time of initial surgery. If these criteria are fitting in, then these patients should be referred for secondary cytoreduction. Just to conclude, we have seen that in last 2 years, there have been significant improvement in understanding of the biology of ovarian cancer, and particularly we have understood the cellular origin of high-grade serous ovarian cancer. We have identified newer therapeutic pathways, particularly targeting the DNA repair pathway as well as the cell cycle modulation that has led to improvement in outcome of ovarian cancer. We hope to see a broader uptake of secondary cytoreduction in the future but we have to select our patients carefully. With the use of increasing uptake of maintenance with PARP inhibitor, we will have challenges like in the form of therapeutic resistance and the role of second maintenance therapy, that means PARP inhibitor after a PARP inhibitor. But these are the current research priorities, and we have to wait for the future trial to answer these questions. Thank you very much.
Thank you very much, Dr. Seema. It was a wonderful presentation, and now we have the third. So
yeah, so I would request Dr. Reena Bhardwaj to please introduce the next speaker.
Thank you, Shefali. Am I audible?
Yes, ma'am, you are audible.
Yeah. So the next speaker that we have in today's session is Dr. Bharat Rekhi, a very highly distinguished and eminent pathologist with years of stellar experience. He is currently the professor at Tata Memorial Hospital and has had the honor of many achievements like being associate editor IJPM and outreach editor Cytopathology Journal. He has been treasurer of IAC, and of course, he's renowned for bone and soft tissue tumors and member in the BMG gynecology group. Over to Dr. Bharat. He has chosen a very contemporary topic, molecular profiling of endometrial cancer. Is India ready for it? And I'm sure that we're all through the orthodox histomorphology, which has been complemented by IHC. But Dr. Bharat is here today to discuss genomic profiling, risk stratification of endometrial cancer. Over to you, sir. Hello.
Thank you very much, Madam Dr. Reena Bhardwaj, and thank you very much the organizers for this opportunity. I'm really pleased and honored to be a part of this CME. And are my slides visible?
Yes, they are very much.
Okay. So I was very interested and suddenly agreed to the invitation by Dr. Manas when he said about molecular profiling of endometrial carcinomas. Is India ready for it? And it was just like, if you look at my first surname, so I had a quick answer to that. But I'll come to the final answer after my sharing my perspective. So the first question comes to our mind is why molecular profiling of endometrial cancers? These are heterogeneous tumors. It's not a single disease. I think we all are aware of it. As pathologists, we have been classifying these tumors into endometrioid, serous, clear cell, undifferentiated, dedifferentiated, mixed, other carcinomas, malignant mixed carcinomas, or carcinosarcomas. Now the term MMMT is ruled out, and the carcinosarcomas are in the ambit of carcinomas. But that's not been very easy to sort of understand clinically. So in 1983, Bachmann, with his dualistic theory, stratified the endometrial cancers into type 1 and type 2, which was more clinically seemingly understandable and applicable, in terms of type 1 being endometrioid, which was vast majority, about 70% cases, and type 2 being non-endometrioid, about remaining 30%. And this also had the underlying genetics falling in place, with the type 1 being driven by the PTEN, PIK3CA, KRAS, NCTNNB or beta-catenin mutations, whereas the type 2 had the underlying chromosomal instability and TP53 mutations. So with the times that we've seen that there are limitations with the routine histopathology reporting, and there are certain scenarios which become difficult to resolve. For example, the complex atypical hyperplasia versus a well-differentiated endometrial adenocarcinoma, especially in young women, which a pathologist would, trot over this or that, and terms like bordering on a carcinoma are utilized or cannot rule out or suggested. So then there's grade 2 versus grade 3, which can have a treatment implication. So that can be an issue which a pathologist might find difficult to resolve. Grade 3 carcinomas, endometrioid versus serous, have been also, there's been an inter-observer variability within these, and serous carcinomas are notorious, and they have a treatment-associated implications, we all know. Over the years, we've seen mixed patterns that you could see an endometrial carcinoma with a clear cell pattern that can have an influence on the prognosis and also treatment-related implications. Interestingly, clear cell carcinoma shares features with type 1 and type 2. So it has molecular profile with ARID1 mutations underlying, which is in type 1. And it has an aggressive clinical behavior, which is seen in type 2 carcinomas. And of course, endocervical versus endometriosis, kind of different scenarios that have been challenging to the pathologists. And the morphological classification has been non-reproducible with inter-observer variability with the certain scenarios that I just alluded to. At the same time, there's been an imperfect reflection of the tumor biology, what's lying beneath, because the tumors are so genetically complex. And in fact, interestingly, grade 3 endometrial carcinomas can share immunohistochemical profile with grade 1 carcinoma. They both can be ER diffusely positive. And they always might not show the grade 3, or always might not show the P53 mutation, which can come in a subset. And the morphological overlap of the grade 3 is very much with serous carcinomas, including immunohistochemically. Of course, to some extent, we can resolve that. So in 2013, what came to the rescue was the Cancer Genomic Atlas integrated genomic categorization of endometrial carcinomas with the whole exome sequencing, transcriptomes, the MSI-related events, and the copy number alterations. So all these were studied, and that led to stratifying the endometrial carcinomas into 4 distinct flavors. The first being poly, that is the DNA polymerase epsilon catalytic unit, the ultra-mutated form, which is seen in about 7% of endometrial carcinomas. It drives about 7% endometrial carcinomas. And the way one can test these mutations, the poly mutations, is sequencing with the RT-PCR and Sanger sequencing. And of course, now we have the NGS, which is more expensive. The second is the microsatellite instability hypermutated form, which is again can be studied by molecular techniques, PCR and sequencing, but we have immunohistochemistry to a good rescue, and it mirrors the underlying genetic events of these MSI hypermutated forms, which forms about 30%, 28% cases of the endometrial carcinomas. Then the copy number low, or the tumors or carcinomas which have no specific molecular profiling, once we have ruled out the other categories genetically or immunohistochemically, and I will show how we can do that, forms about maximum number of cases, that is nearly 40%. And then the most aggressive ones, the copy number high, that is the serous morphology, which have underlying P53 abnormality or the P53 mutations, and these can be tested immunohistochemically and also with molecular and NGS from about 26% of the carcinomas. So we've seen how morphology has moved ahead in terms of integration with the genetics, and the WHO recent 5th edition 2020, just out of the press, has beautifully integrated the molecular subtypes with the morphological features. And I always say, as a disclaimer, I'm a morphologist who also does molecular testing. So that makes a lot of clinical sense. And we know the NCCN guidelines in 2021 have shown that MMR or MSI testing is recommended for every case diagnosed with endometrial carcinoma. And in case of MMR deficient, which we can see immunohistochemically, or MSI high, which we do test by the molecular techniques, the patient may be tested for Lynch syndrome. So hormone testing, of course, we are doing in every case, but what has been recommended is for the recurrent and advanced stage 3 and stage 4 cancers. Now, the new kid on the block is HER2 in serous carcinomas and shows the overexpression or amplification of HER2 in a subset of serous carcinomas, carcinosarcomas, or stage 3, stage 4, with the possibility being offering some of these patients is trastuzumab. And of course, the other biomarkers which are up there are the tumor mutation burden, of course, with relation to the immunotherapy. We are choosing candidates for immunotherapy, especially in the MMR deficient. So tumor mutation burdens can be seen with the NGS and NTRK gene rearrangement, again, a new kid on the block. And that makes, again, a lot of sense as the part of the PORTEC-3 trial that I think the entire audience is so well aware, and I don't have to go too much into the details. But what comes out very clearly is when the patients of these high-risk endometrial cancers were stratified into, with respect to their treatments, into the adjuvant CT-RT versus RT, it was seen irrespective of the both, the cases which had poly mutations had a better outcomes, and also the cases which had underlying P53 abnormality, which formed about 23% of such cases, responded well to the adjuvant CT-RT in contrast to the RT. So that makes it important to pick up these P53 abnormal or the serous, which vast majority of serous have the P53 abnormality, and also the MMR deficient. So there's been a smattering of literature about the MMR deficient tumors being, having their predictive value, especially if one is contemplating or considering immunotherapy, which can be in certain scenarios of recurrent or extensive disease. And of course, FDA has now approved this specific biomarker testing, which was discussed yesterday. And I was very pleased to see that we are not triaging the cases right away for the immunotherapy, but we are looking for specific biomarkers. And here MMR deficiency is important, and also the tumor mutation burden, because a large majority of these type 2, the MMR deficient tumors have high tumor mutation burden that can be tested only with molecular techniques. So we have all this up there on the platter of what we can do for the patients, but at the same time, we are fraught with certain challenges. There is limitation of the resources across the country. We don't have uniform resources. If I say about being able to test MMR deficiency with immunohistochemistry, there is a challenge because, the quality controls might not be all across. Of course, molecular is a bigger challenge, and NGS, although is available. And interestingly, we are a country of paradox. We have, the bullock carts and the Mercedes at the same time. So NGS is available, but how much is it affordable? Also, that has to be seen. Like I said, the standardization and quality checks and control very significantly influence the quality of test results that we are offering through these, be it immunohistochemistry or molecular techniques. To our rescue, if you look at only molecular techniques, there's a nice study that was published by the Vancouver group who showed that, you might not need to have genomics across all 4 types, but poly needs to be tested genetically. The other 4 can be taken care of with the immunohistochemistry, and that is a PROMISE study. That is a mutation classifier, the PROMISE proactive mutation classifier, wherein you just need to have the poly mutation testing, and the other 3 types can be taken care of with immunohistochemistry. And you can see the high-grade serous carcinoma, which as pathologists called, had no problem reinforcing our diagnosis with p53 mutation. That is what I mean when you see this diffuse intense nuclear staining in more than 70% tumor cells, or a complete loss, which is called null mutation type. It's a p53 abnormal serous carcinoma, the copy number high. So morphologically and with immunohistochemistry, we can resolve the issue. Looking at the MMR deficient tumors, I'm happy to share with you our results of the 50 cases of MMR deficient endometrial carcinomas, which we tested by immunohistochemistry. And we looked critically about the correlation of the morphological features. What we found, apart from this being the first study from our country, we found certain morphological features are triggers for the MMR deficient carcinomas. These are generally high-grade endometrioid. They are heterogeneous. They have ER/PR positivity, wild type P3 expression more than 80% cases, and we see a paired loss of MLH1, PMS2, which is more like, the sporadic types. That is more often seen than the MSH2 and MSH6, which is seen more associated with the Lynch syndrome or multiple cancers. And certain morphological features, for example, lymphoepithelioma-like appearance or extensive LVI or lower uterine segment and deep myometrial invasion are features which are more associated with the MMR deficient tumors, of course, in younger patients. So this is an example of a lower uterine segment tumor you can see involving in the form of the growth that is seen in the uterus. And simultaneously, this patient who was young had an endometrioid carcinoma in the ovary. Histologically, we see the endometrioid adenocarcinoma, and there was also a clear cell component. This is what I was meaning by saying that when we say mixed patterns in a younger patient with a tumor in lower uterine segment, this has more chances to be MMR deficient. Of course, these tumors are ER positive and show P3 wild type expression, paired loss of MLH1 and PMS2, and retain MSH2 and MSH6. Now, when we are done with all the other types, we look at something which is more differentiated. That's the copy number low possibility of a relatively well-differentiated endometrioid carcinoma. So we just introduced the poly mutation testing, and we've seen about 3 out of 30 cases of cherry-picked cases which showed this poly mutation that you can see a very lymphoepithelioma-like appearance. So these are the techniques that we can follow, the RT-PCR, NGS, and FISH also. So finally, to my takeaways include histopathology is the gold standard. We need to integrate molecular results or classification, especially poly, because it has a significant prognostic implication and also maybe predictive implications it will have to influence the chemotherapy regimes in future. We need to integrate immunohistochemistry as a good substitute with, of course, good quality related issues in place and the controls. Our challenges remain cost, logistics, quality control, and validation, which is very important, be it immunohistochemistry or molecular. We can formulate certain algorithm to ourselves that we can start our cases with poly and go on further. And that's the timeless triangle we've had of integrated radiology and pathology, and we add a new dimension of molecular to make a robust diagnosis in terms of the complete holistic approach that we can offer to the patient. So finally, the answering is India ready for molecular profiling of endometrial cancers? From my side particularly, I can say the word yes. And we need to enhance capacity building for molecular testing and logistics for referring cases to labs who can offer these tests. Thank you very much. And I'd like to acknowledge my staff at immunohistochemistry, molecular pathology, especially my colleagues at Gynec DMG, where we make active decision-making for triaging cases for molecular testing. Thank you. I'll be happy to take questions.
Thank you, Dr. Bharat, for making such a complex topic into a very algorithmic form. We'll take questions at the end.
Thank you very much, ma'am.
Yeah, so I would request Dr. Aarti to please introduce the next speaker. Ma'am, are you there? Please unmute. Yeah.
Dr. Aarti, please introduce the next speaker.
In case, ma'am, you're not audible, so in the interest of time, yeah, I would request Dr. Reena to please introduce the next speaker.
The next speaker for the session is Dr. Arvind Chaturvedi. He's the chair radiology and intervention oncology at Rajiv Gandhi Institute of Research. He has a lot of achievements, and to go through a few of them, he's the president of Society of Oncologic Imaging in India, director member Asian Society of Tumor Ablation, president ISVIR Delhi, Roentgen Oration Gold Medalist in 2012, British Council Fellow, Bristol University, England in 1994, and Fellow of Abdominal Imaging from Stanford, USA. It is no surprise that he is here with us to share a very exciting topic on artificial intelligence changing the face of gynecological cancers. Thank you.
Thank you very much, Dr. Reena Bharadwaj, for the very kind introduction. And I just want to start sharing my slides.
They're visible, sir.
Okay, great. I'm visible and I'm audible. And I want to thank the organizers of this meeting. And a few weeks back, when Dr. Charu Garg, she called me up and she gave me this topic of artificial intelligence in gynae oncology or in gynec malignancies. And I told her that, look here, Charu, I don't really work in gynec imaging a lot, so I have limited experience. But she said, sir, you can tweak the topic a little. So, but before that, before I start, I bring you greetings from Rajiv Gandhi Cancer Institute and Research Center. And some of you may have worked in this institute earlier, and some of you may have visited. Now we have a full-fledged D block, which is functional, and we are a fully operational 500-bedded hospital. The topic, as I mentioned, that was given to me is artificial intelligence changing the face of gynae cancers. So I was actually allowed to make a small change, and I just made a very small change. Is it changing the face of gynae cancers? So let us address that issue. The theme of my talk is then artificial intelligence in cancer care and artificial intelligence in gynae oncology. Well, first of all, I want to show you this tree and try to look at it carefully. You see a tree, or maybe two trees, you see water behind, you see the leaves and the branches. Do you see anything more than that? Well, concentrate here, look carefully. Do you see something there now? Yes, if you magnify, you see an aeroplane. So this picture is near the San Francisco airport. And that's an aeroplane which can be very easily picked up if this tree was to be analyzed by a machine or by some kind of a device which will scan every part very, very quickly without you having to look at it. And this is computer-aided diagnosis or computer-aided detection. And this has been in existence for some time, and this has been the first step in artificial intelligence, and it has helped radiologists. And basically, you can pick up a lung nodule. There are softwares which will pick up a lung nodule which your eyes can't see. So what I'm trying to say is there is a lot more in a picture than what you can see with your naked eyes. The same tree again. Perhaps we can say that, yes, there is a tree, and you can also now probably spot the plane because you had seen it before. It has gone a little away from where it was earlier. There are many other questions you need to answer. If this tree was a cancer, it's not enough to just say that this is a tree and this has so many branches. How many leaves it has? Are there any insects? Are there any termites? So you need a lot of more information. Like in the previous talk, we heard that, the molecular profiling, etc., how it matters. So there is, in fact, enormous data that you need to dig out. And to treat, what happens after treatment? Are there new termites? And how to treat if there are termites? All these questions need to be answered. There is so much of information you have to gather and process in the human brain. Basically, the image has a lot more information, and it has information far beyond what actually our eyes can see. Artificial intelligence is nothing but a tool to facilitate personalized medicine by synthesizing data on complex oncology. So artificial intelligence helps extract this data, coordinate and collate it, and synthesize it. In a nutshell, this is a brief description of how the artificial intelligence in imaging works. We all know that in a CT or an MR, you acquire images. And ultimately, we look at some images and we call it, well, it's a cancer, not cancer, heterogeneous, or whatever, and then we need a biopsy and things like that. In artificial intelligence, we know that actually it is the data which has been converted to create an image, but we have not analyzed the data. The data has far more information. If that data is extracted from here, it can be processed. The data will be processed for shape analysis, histogram analysis, texture analysis, dynamic curve analysis, and so many other factors. And when all these are analyzed and they are put together along with the clinical findings, there is a statistical modeling, and that is radiomics. And that also you can actually pick up even gene expression profiles and things like that, and that becomes radiogenomics. And also you can kind of judge, is there a response to therapy or not? So there is a lot happening. It is not just the images, but the data behind those images, which is now available to us, which was always available to us. But now we have the tools to analyze that data, to put it in a machine, which is an artificial intelligence system, where there is an input layer, there is a hidden layer, and there is an output layer. And you get answers based on statistical modeling. So the information has to be fed first. So that is artificial intelligence in oncology, which actually depends on feature extraction and then radiogenomics. If it's CT or MR, the CT or MR imaging and radiomic extraction is done from the data. There is an association between the radiomic data and the gene expression. And also there is an association between the radiomic data and the clinical outcome. So much in general about artificial intelligence in oncology. Looking at the potential applications of artificial intelligence in gynec malignancies, well, it works for diagnosis of cervix cancers. We'll see that in a moment. Diagnosis of endometrial cancers, prediction of prognosis. We know that the deep myometrial invasion is a very significant prognostic factor in endometrial cancers. And actually, artificial intelligence gives you information about that also. Looking at the images, it is a struggle. On MRI also, we find it very, very hard to say, is there a deep, to what extent there is myometrial invasion. It is basically, or most of the time, a pathological diagnosis. So AI can also predict the recurrence and of course, the genomic prediction, as I mentioned earlier. Coming to cancer cervix screening, cervical cancer is preventable. It's a deadly disease if there are no screening programs, and the current methods of screening cervical cancer, pap smear and liquid cytology, are time consuming. They need experts, it's labor intensive, and there are variations. So we actually need a point of care diagnostic solution for screening of cancer cervix. I'm showing this image to highlight the point that in the sub-Saharan African area, there is a very high incidence and mortality from cancer cervix. So let me take you on a short journey in Kenya, in sub-Saharan Africa, and from Nairobi to Mombasa. That's a few-hour train journey. And 40 miles away from Mombasa, there was a study that was carried out in a rural setting. Women had no access to medical care, but this study was carried out there. And this was point of care digital microscopy, AI-based sample assessment in a resource limited setting. So what exactly they did? There is inadequate microscopy diagnostics at the point of care. So the slides were digitized at the point of care and uploaded into a system, into a cloud-based system, a deep learning system. And then the system responded because the system was trained. So that was the study site. The slides were digitized, uploaded, and the answers were given by the DLS, by the deep learning system, or by the machine. Also, detection of cervical cell atypia in digital pap smears with DLS, it was easily possible from that study, and digital imaging and machine learning improved cervical screening without the need for a very expert cytopathologist availability on site. AI-based dual stain approach, I'll skip through these slides in the interest of time. Pap test is the current standard for follow-up of women who test positive with HPV screening, and dual stain for P16 and Ki67 is done, and that is uploaded again on a cloud-based server, and that actually gives you the information about the P16 and Ki67. And it resulted in a reduction of referrals to colposcopy to 41% from something like 60%. Automated system for diagnosing endometrial cancer by adopting deep learning technology in hysteroscope. All gynecologists who are attending, they would be doing hysteroscopies, and basically it's something that is visible and you see and you detect and you biopsy or whatever. Now these images, as I said, even these images will have far more information, and if these images are put into an artificial intelligence system, the images are extracted, analyzed, and the clinical data is also fed, and you can get an output answer, malignant or others. And this has been very promising. You have to train the deep neural network, as it is called. So the progress of artificial intelligence in gynecological malignant tumors is very, very promising. We do MRIs, as I said, to assess endometrial, the depth of invasion in endometrial cancers, depth of the myometrial invasion, and it's a longish process, and there is variation amongst different radiologists, and also you need a lot of other, techniques or a lot of MRI protocols. So can artificial intelligence help? Yes, it can help. Let's see how it helps. There was a study which was carried out and published in Radiology in 2017. We need to know the lymphovascular space invasion and deep myometrial invasion in endometrial cancers, and both of these are considered very important prognostic factors, even from the treatment point of view, particularly in stage 1 endometrial cancers. AI has the potential to assist radiologists to serve as a reasonable alternative for preoperative evaluation of myometrial invasion, depth of stage in stage 1 endometrial cancers. And this is based on the MR imaging-based texture analysis. Combination of radiomics, this is our small contribution in the field of artificial intelligence from the Rajiv Gandhi Cancer Institute and Research Center. We published a paper this year regarding early prediction of treatment outcomes in cancer cervix based on the radiomics data. Artificial intelligence and machine learning are transforming the way cancers are detected, staged, and treated. and artificial intelligence offers new hope and new ways to manage gynae cancers. So the question is, will artificial intelligence replace gynecology oncologists or radiologists? A simple answer is no, they will not. But those who use artificial intelligence will replace those who don't use artificial intelligence. AI is not a standalone procedure at the moment. And artificial intelligence and clinicians, when they contradict each other, then clinicians need to take a judgment call. I have come to the end of my talk. And as was mentioned, that cancer is a very heterogeneous disease by multiple speakers. Now, it was just one tree I showed in the beginning, but now I'm showing you a jungle. In fact, so many trees, and one cancer is actually having so much of information across multiple trees, and you extract that information, which is humanly impossible. And so artificial intelligence can handle that big data, which we find hard to handle. We have the information, but to collate all that and to reach a decision, we will need the help of artificial intelligence, even for decision support. And I once again thank everyone for giving me this opportunity. And also I want to thank Dr. Reena Bharadwaj once again for the kind introduction. And I think we share something in common. We both have an army background.
Sir,
Thank you. Thank you.
I was trying to recognize you.
I've gone old.
Indeed, a very
Indeed, yes.
No, I meant indeed a very lucid and illuminating presentation, sir. And as always, very, very informative. You mentioned replacing radiologists. I think pathologists are equally worried that we'll be replaced.
It will not. It will not. I said it won't.
Okay. Thank you, Shifali.
Thank you, ma'am. Dr. Aarti, your comments, please. I think that you were freeze during that session.
Yes.
So, yeah, please, ma'am.
I lost out on the opportunity of introducing Colonel Chaturvedi, who was closer to my subject than he was. And I also understand that he did come to Tata Hospital for a little while, and he did dabble with radiation. I completely agree with you that the person will never replace the radiologist or the pathologist, but you would be better off using it. You would be better than the other person who doesn't use art. The whole world is there for us to use and to individualize patient treatments on the basis of this particular new art, which is booming all over the world.
Yeah, thank you so much, ma'am. And with this end of the session, I would thank all of the eminent chairperson, all the speakers. Wonderful session. Thank you so much, all of you. So now we move on to the next session, which is multidisciplinary tumor board meeting. And I would like to invite for the first MDT session, Dr. Kanika Batra Modi, who is our gynae oncologist in MICC Saket, and she would be moderating the next session. Dr. Kanika, please.
Thank you, Shifali. So to begin the session, let me call my esteemed panelists, Dr. Shaunak Walame, who's a consultant med-onc at HCG Nasik, Dr. Ibrahim Pidiakar, who's a senior consultant gynae-onc, currently at Sultan Qaboos Comprehensive Center in Oman, Dr. Kaustaf Talapatra, who's Director Radiation Oncology at Nanavati MICC Mumbai, Dr. Swarupa Mitra, who's Senior Consultant and Chief Unit of Genitourinary and Gynecological Radiation at Rajiv Gandhi Cancer Institute, and Dr. Samar Gupte, who's a gynae oncosurgeon at Hinduja, Surya and Breach Candy Hospital in Mumbai. I welcome you all. Is my screen visible? Okay.
Yes,
yeah. Great. So we're going to be discussing a case of recurrent cancer endometrium. So just describing the case in brief to all of you. She's a 37-year-old female, known case of CO endometrium, well-differentiated subtype, stage 3C, surgery followed by chemo, followed by radiation, all done starting in 2017, no comorbidities, and 3 years post that, she came to us with complaints of pain lower abdomen and bleeding per vagina. So just details about her previous surgery. It was a well-differentiated endometrioid adenocarcinoma. And overall, on IHC, it was consistent with endometrioid adenocarcinoma. So at that time in 2017, in June, when we got her MRI, there was a lesion from the endometrium going into the cervix, but no extension into the pelvic wall. And we got, these are her images. This is the mass going into the cervix as well. And all the coronal and the sagittal sections. PET-CT also suggested bilateral adnexal masses and a few iliac lymph nodes which were enlarged. No other enhancing lesion in the rest of the body. So we did a Vadheim's hysterectomy with bilateral salpingo-oophorectomy with bilateral pelvic and retroperitoneal lymph node dissection and infracoelicomentectomy. And this was a biopsy report. It was a well-differentiated endometrioid adenocarcinoma with squamous differentiation involving the ovaries and the lymph nodes, so stage 3C. Then she received adjuvant chemotherapy, 6 cycles, paclitaxel and carboplatin, followed by external beam radiation, IGRT, 45 gray, followed by 2 sessions of brachytherapy, 5.5 gray each. So with a PFS of 3 years, she had come with bleeding per vaginum now, for the last 2 months. And on examination, there was an irregular growth seen and felt at the vault region, which was about 3 into 2 centimeter, right-sided, and in the upper part of the vagina and the paravaginal tissue, not reaching up to the lateral pelvic wall, and POD and rectal mucosa were free. The MRI suggested a well-defined lesion of about 2.7 into 2.4 centimeter. We can see it clearly over here, if I can point out with the arrow. So this is the lesion that is there, and it is indenting onto the bladder, and it is not going onto the lateral pelvic wall. And over here, if we see, the levator ani muscle is also getting effaced. And biopsy from the mass now is suggestive of endometrioid adenocarcinoma. So as we can see, this is recurrence in a case of CA endometrium post-chemotherapy and radiation therapy. So this is just how we are going to progress in this panel, loco-regional recurrence with prior RT. So this first one is for Dr. Samar. Who are the surgical candidates in cases of recurrent endometrial cancer?
Hi, Kanika. First of all, thank you and the entire team for having me here. Well, if you look at it traditionally, this is what we believed in traditionally, that patients who've had surgery followed by radiation for endometrial cancer with or without chemotherapy, if they do get a recurrence, which is proven central pelvic recurrence and is the only point of recurrence, say we do a PET scan, we find out that's the only point of recurrence and there are no enlarged nodes or no PET positive nodes or extra pelvic disease. So these are the candidates whom we traditionally believe to be surgically amenable, right? So the question is, what are we looking at doing for them? Obviously, one would like to go in and say if that's the only mass in the center of the pelvis, one would like to kind of remove that and then take it forward. But we also know that this is a point of time when we are entering a pelvis that is subjected to surgery, subjected to radiation. It's a nice big blob out there, very difficult to get something out intact. And more often than not, these are the patients who require a very drastic surgery like an exentration surgery, either anterior, posterior, or total. And that becomes a very difficult choice to make, especially because if you look at the SGO paper that came out in March 2021, where they looked at, re-irradiating these lesions also, and they've got variable success with that. I'm sure my radiation colleagues would be able to talk about that also. So currently, I think the only candidates who I would think of surgery are those where re-irradiation is also not possible, because say the mass is in such a point where it's actually going into the bladder or actually going to the rectum or something like that. So it's a kind of a difficult choice, but yes, we're looking at just a central pelvic recurrence where we might consider surgery for these patients.
Yeah, thank you, Samar. So just the basic pointers where distant mets have been ruled out and a complete resection is technically feasible and the patient can tolerate surgery and willing to accept the functional post-op changes. So the next one is for Dr. Ibrahim. how would you like to counsel such a patient for a surgery like exenteration and explaining them survival outcomes and quality of life?
Thank you, Dr. Kanika. I think the patient as well as the relatives really need to understand this is going to be a very major operation, life-changing surgery. I think the findings have to be explained to her and also the reason why this operation needs to be done. Alternative options also need to be discussed, such as palliative supportive treatment, palliative care, and also maybe considering chemotherapy or interstitial brachytherapy, all those things which anyway would have been discussed in the multidisciplinary team meeting. So to the patient and relatives, we need to explain the nature of the procedure, that general anesthesia would be required, what are the structures that are going to be removed, what are the reconstructive aspects of the operation, the need for ICU care, post-operative care, and problems to be anticipated. Also need to explain that frozen section and thorough evaluation would be done during surgery and that even surgery might be abandoned. Of course, we have to talk about, if bladder is removed, then the diversion, and if bowel is resected, the colostomy, and also if vagina is removed, then the need for vaginal reconstruction with flaps. And patient needs to understand that it might take 6 to 9 months for full recovery from the operation. The short-term risks have to be explained, such as the pain, DVT, pulmonary embolism, hemorrhage, sepsis, wound breakdown, bowel leak, the need for reoperation, readmissions, pneumonia, and so on. They need to understand that the risk of major morbidity would be about 40 to 50%, and that there's even a chance of perioperative death of about 5%. They also need to understand that the disease could recur in spite of this major operation. And so we really need to present that, the positive as well as the negative aspects. The positive would be that a 5-year survival of about 50% may be possible.
Absolutely. And something about the long-term quality of life that you would like to say, Dr. Abraham?
Well, quality of life, yes. They need to understand that, persistent symptoms of survivorship would be there. And there are many problems that keep coming along the road. I mean, lymphedema, psychosexual problems, change in body image, intestinal obstruction due to adhesions, fistula formation, stoma problems. They could have, repeated infections, even leading to renal failure. And also the expense and energy to manage these complications. So they really would require a lot of social, financial, implications are there, and also spiritual support. And sometimes there would be regret. So all these things have to be borne in mind.
Yeah, I think that's a very important point that you made. Regret, which comes in a lot of patients who've undergone such an extensive surgery with permanent stomas. And most of the papers just highlight the same. So my next question is to Dr. Swarupa Mitra. Can you explain the role of intraoperative radiation in such cases of recurrency endometrium?
Hi, Dr. Kanika. It's so nice to see you again on this platform. And thank you for Dr. Charu and your team for inviting me over here. So now the question you're asking is the intraoperative radiotherapy. This is something not many of us practice, but we would probably like to practice. Now, in this case particularly, intraoperative radiotherapy theoretically would probably have some indications. Now, let me be very brief and discuss what intraoperative radiation therapy is and how does it score over other methods of treatment. In such a case, re-radiation, the different options would be brachytherapy. I'm not talking of this particular case. I'm talking about a local recurrence post-radiation, post-surgery, post-radiation, a brachytherapy, or SPRT, or any form of external radiotherapy, or intraoperative radiotherapy. Now, for this case, since the disease has been removed, so probably the brachytherapy does not have a chance. But yes, before the surgery, brachytherapy would have been a very, very good option. Brachytherapy, I mean the interstitial brachytherapy, would have been a very good option. But since the surgery has been done, The next two options are intraoperative radiation or an external beam radiation. Since it is a re-radiation only 2 years, external beam radiation would probably be the last option. Intraoperative radiotherapy would be a very good option if the surgeon feels that there would be a positive margin, there are chances of positive margin. Intraoperative radiation does not have much role when there is a gross residual disease. So the difference, the intraoperative radiation scores over the other forms of radiation the way that one, it is a single shot, just a single fraction. Second, you can actually visualize the site where you want to deliver the radiation. That is the site where the surgeon is also there. That is the site where the margins are probably close or positive, where the chances of a positive margin are more. So you can actually visualize that site and you can plan your radiation that well. And third is you can push away, like in this case, the bladder is very, very close. With any other form of radiation, probably we will not be able to protect the bladder that well. So intraoperative radiation, we have different methods where we can push off the OARs, and we can give a good dose of radiation at the same time protecting the normal structures. So theoretically, this is the way our intraoperative radiation could go. But what is very important to understand, we need a intraoperative radiation suite kind of a thing. We cannot open the abdomen and carry the patient to another OT or another radiation machine. So that is not, it used to be done before, but it is no more recommended. We should have a suite where the radiation can be given intraoperative.
Right. Thank you, Dr. Swarupa, for the detailed answer. In fact, even in our OT, we take the patient for intra-op OT, instead of having a suite. But yes, ideal is having a suite in which you can provide the radiation therapy there itself. So next question is for Dr. Shaunak Balame, the indications of adjuvant systemic therapy.
Yes, ma'am. Thank you for inviting me here, ma'am. And for the adjuvant systemic therapy, I would look at what the grade of the tumor is, especially if it's high grade, I'm tempted to give, whether this surgical resection has been complete or whether the margins are positive. If there are multiple pelvic deposits rather than a single occurrence. And of course, for our patient here, her age she's 37 and we need to salvage her as much as possible. So those are the features.
And what would be the choice of your adjuvant therapy given,
Yes, ma'am.
Yes. Chemotherapy, now we have a plethora of things available to us.
Yes, ma'am. So one thing I'd consider that she's recurred after 3 years. So her initial response is a kind of a platin sensitive tumor. So I am tempted to repeat a paclitaxel plus carboplatin, but I will keep in mind what are the long-term toxicities that she's already facing with the 6 cycles given to her previously. She would be at a higher risk of developing neuropathies. Considering that, I'll keep an open mind whether I want to give 6 cycles or maybe reduce it to 4. Plus, you have other options. Again, if it was a low-grade tumor, well differentiated, ER/PR positivity, the option of endocrine therapy is also there for her.
Right. Thank you. So, Dr. Kostav, I would like to ask you about the role of re-irradiation. Is it a possibility in such cases?
So, yeah, technically, if you go through the recent publication, there are case series, even the SGO publication in 2021, as Dr. Samar has talked about, they have been talking about re-radiation. The recurrence is after 2 years, there is a theoretical possibility. However, we have to understand that in this particular patient, being so close to the bladder and the anatomy of the tumor, re-radiation would be morbid and it is not going to be easy. But if to your question, technical feasibility, future studies going on, more data being available, yes, definitely re-radiation would be a possibility in the future with modern radiation delivery systems, with image-guided radiotherapy. As a blanket statement, yes.
Right.
Particular case may not be.
Right. Especially, re-irradiation with stereotactic radiotherapy and perhaps perineal templates with interstitial brachytherapy salvage.
Sorry, I should have elaborated on that.
perineal templates with interstitial brachytherapy, when you have the actual tumor, the dose distribution and the collateral damage is much lesser. Of course, it's a operator dependent and skill dependent procedure. You need highly skilled personnel to do that, but the collateral damage is usually much lesser in terms of radiation dose spillage. Stereotactic radiotherapy in endometrium primary, based on the alpha by beta and the radiobiology of endometrium, we have to be cautioned about it, but yes, there are publications coming on it.
Right. And I would kind of, put this as an open question to all of you. If any of you believe that neoadjuvant chemotherapy can be given to such patients to avoid exenteration.
Yes, ma'am. I haven't used neoadjuvant in a recurrent setting, but if with the discussion of the surgeon, if we can do that, then it would be good for it. It's a better quality of life rather than undergoing a pelvic exenteration.
Yeah. In fact, I would ask our surgeons also, Dr. Samar, Dr. Ibrahim, if you could comment any such experience where you've given neoadjuvant chemotherapy and avoided exenteration.
Yes, I think, many times patients refuse exenteration, and so then we do give them chemotherapy. And of course, hormonal treatment, chemotherapy, these are options. And now with immunotherapy, these are newer modalities that are coming in. So definitely, there may be a role for these before jumping into exenteration.
Anything to avoid surgery.
And the surgeons vouching for that. Glad to see that. Thank you so much, everyone. And I think we can move on to the next session now.
Thank you, ma'am.
Thank you.
Thank you.
Thank you.
Thank you, Dr. Kanika. That was an excellent moderation, and you tried to clarify many practical points. Let's move on to the second MDT, which is role of HIPEC in the recurrent versus upfront setting. There was a gray zone discussion yesterday on the same topic, but that was part of it, only the role of HIPEC in the upfront setting. Now it has been more complicated by addition of recurrent word to this thing. So I would request the moderator of the session, Dr. Anbu Subyan, to moderate this session and call her panelist. For the brief introduction, she is consultant gynae-oncologist with a special interest in the gynae-oncology at KMCH Coimbatore and has got fellowship from IGCS as well. So may I request Dr. Anbu to please unmute herself and introduce her panelist and carry forward the discussion.
Good evening, everyone. Thank you so much for having this team as part of this fantastic conference. I'm really impressed with the way the topics have been chosen and the way in which they're presented. So I'm really glad to be here. It gives me great pleasure to introduce a panel of distinguished doctors from across India, from north to south. And I'll call the ladies first, which is Dr. Rama Joshi, who's the director and head of the Gynae-Oncology and Robotic Surgery Division at Fortis in Gurugram. Dr. Lata Balasubramani, who's my colleague here from Coimbatore, who's from GKNM Hospital. My teacher and mentor, Dr. Bhavna, who's the HOD of Gynecological Oncology at BM Jain Hospital, Bengaluru. Dr. Rahul Modi, who's the clinical lead in Gynae-Oncology Cancer Research Institute, Himalayan Hospital, Dehradun. Unfortunately, Arunava, who's at TMH in Kolkata, is not able to join us because he's down with fever and it's not COVID, and he's had to get admitted in the hospital. So we will be missing him here, but we will all step in to fill his shoes. So I'm going to present my slides. And I hope the AV gets on. Is my audio visual all right?
Yes.
Thank you. So we've heard the gray zone discussion yesterday, and I thought that was a fantastic idea on HIPEC, and that was in the primary setting. We've had a lot happening right from 1893, apparently, when Colles actually discovered that cancers in patients with high fever showed regression. And from then on, in the last 10 years, the amount of evidence that that's actually come out in this area is fantastic. So not just HIPEC, but IP chemotherapy in itself has shown benefits, but still we know that uptake of IP chemotherapy as well as HIPEC is very patchy. And just in the gray zone discussion yesterday, about 60% of this conference's attendees would not do HIPEC even after the discussion that followed, but that of course was in the primary surgical setting. So there are still a lot, there's still a lot of hesitation, and there are a lot of unanswered questions as well, despite the evidence that's out there. So what we aim to do in this discussion is to achieve a little bit of clarity on evidence as it stands and to learn from Indian experts, because one of the things about these trials, and that's constantly being told as well in forums, is that what happens in a high volume center with experts doing this day in and day out cannot be extrapolated to real world scenario many times. And we know India is a place of diversity. We've got corporate hospitals right down to government centers, to tier 2 centers like us. And how do these experts actually circumvent their problems? What are the difficulties they face? And hopefully at the end of it, if you are a fence sitter like me, I am not a HIPEC practitioner, I'm still a fence sitter. I'm really keen to see how this discussion goes so that I get convinced as well. So hopefully we'll get some leads on how to start a program as well. So I'm starting with this one case, and 80% of the ovarian cancers we see are follow this prototype. This was a 65-year-old who presented with progressive abdominal distension and vomiting and a possible loss of weight. She was nulliparous. On examination, she could walk into the OPD with a little bit of breathlessness, and her PS was 2. Her systems examination was normal, and her abdomen was grossly distended with ascites with scattered nodular masses, probably indicating momental nodules. On pelvic exam, there's a hard mass felt in the pelvis with marked pelvic POD nodularity. On her labs and radiology, the significant thing was she had a low serum albumin, and her CA125 was 1633. Her thorax, abdomen, and pelvic contrast enhanced CT showed that she had bilateral ovarian masses, 8 centimeters and 6 centimeters. She had gross ascites. She had multiple omental nodules. She had light subdiaphragmatic and liver capsule deposits as seen, and a right pleural effusion as well. So she was a possible stage 3C or stage 4. Now, this is the prototype of cases that we see. Can I ask Dr. Rama, how will you proceed with this case? And does this case flash into your, when you see this case, does it flash immediately that you have to possibly earmark HIPEC as one of the treatment plans? And based on current evidence for a fence sitter like me, how would you convince that HIPEC has its value in this patient?
I don't think so. I will consider this patient for HIPEC. This patient has pleural effusion, and I have a suspicion maybe that she is stage 4 disease. And so she didn't have, I think, chemotherapy, right? This is the way she's just
primarily, she's just presented to us. So where do you
I think there is upfront, there is no evidence to suggest with that of the primary surgical cytoreduction, there is any evidence for the HIPEC. And we must consider actually which patient we are dealing with, how we are selecting the patient. It is not the answer for each and every patient of the advanced ovarian cancer.
Which
So I think in this patient, I would not like to offer HIPEC at all.
Okay. So which patient, when comes into your OPD, you earmark as HIPEC?
Okay, it's not a question of earmark. Again, I think we are very choosy, we are very selective. And once you are asking me the evidence, I can tell you evidence. Other than that, I mean to say this is not actually, cannot be correlated with this patient, but on whatever the present evidence we have for the HIPEC in the upfront setting, again, as I made very clear, there is no evidence so far as the primary surgical cytoreduction is concerned. But yes, there is an evidence when we are considering the interval surgical cytoreduction in advanced ovarian cancer, that too in stage 3 disease, not in stage 4 disease. And we have one phase 3 Vendreal, I think, randomized trial by Vendreal. I think that has become the landmark so far as the HIPAC is concerned, a HIPAC can be practiced for, and this is how this study has looked into this. I think this has included fair number of the patients of about, say, I think 240 something patients were included in this study, and they had actually randomized the patients into two groups, one group having only the surgical cytoreduction and the interval setting after 3 cycles of the neoadjuvant chemotherapy. And in the other group, they had added HIPAC to it. And what they had basically been looking at as the primary endpoint was the recurrence-free interval, as well as the overall survival. So actually the recurrence-free interval and the overall survival, and they had also looked at the secondary endpoint as the morbidity. What is important actually outcome of this trial is that the overall survival was significantly better in the group receiving HIPAC. And that was about, say, 12 months. So that's how I think this is a very positive study. Of course, there are limitations of this study also, because it has also included some of the patients. Majority of the patients included in the study were having CC0 at the end of the surgical cytoreduction. But they also included the patients of CC1. That's, I think, so from that point of view, this is really encouraging to address the issue. But here I would like to share one of the principles on which I think the ovarian cancer is being managed. We know that primary surgical cytoreduction and the systemic therapy is a standard of care. And the survival could be correlated very well with that of the residual status of the disease. Actually, no residual status of the disease is taken as the optimal status of the disease today. So definitely, if HIPAC works on the microscopic disease or into these cells, basically, which have been correlated with that of, you can say, the theory or entrapment of the cells to extend to that of any kind of the implants later on. So it is justified.
I'm just going to interrupt you and say, because for want of time, I'm going to just have to interrupt you and say, you believe that in stage 4, you would not offer it. And of course, I agree that in primary ovarian setting, it is not offered. And therefore, in an interval debulking, if there is possibility of achieving CC0, we would offer HIPAC. So I'm going to move on to the next question, which is, let's play the devil's advocate. And what is, Professor Bafna, what is your critical take on the current evidence? Do you think there is enough convincing advice for offering a HIPAC for eligible Indian patients? Because here we have a huge load of logistics and financials. So do you think there is enough evidence now to offer it at least?
Yeah, Amambo, I'm not a great fan of HIPAC.
Yes.
And there is no strong evidence to support HIPAC. In fact, the guidelines given by various international agencies like SCCN and the guidelines given by European Society of Medical Oncology, they do not recommend HIPAC as standard of care. HIPAC can only be practiced as a clinical trial modality. So it should not be practiced as standard of care. That means it cannot be given to all the patients routinely. So let us be very clear.
What about the patients that you've done HIPAC on? What are these patients like?
I told you, I am not a very great fan of HIPAC. My patients usually, they are not my patients. They are being referred by gastroenterologist with pseudomyxoma peritoni. These are the patients which present to the gastroenterologist first, and they are very keen on doing HIPAC. So all my cases, I think, are referred by gastroenterologists. So I've been doing with my gastroenterology colleagues, and I don't have a very great experience in HIPAC. I've been doing HIPAC only for the last 1 year now. So far, I think I've done 7 to 8 cases. And I'm not very convinced about HIPAC as a routine practice for our Indian patients because it is logistically very, very difficult to organize HIPAC and most of the centers in India. It's very expensive, very tedious, and most important thing is, I think, which we forget, we talk about HIPEC, but I think most important thing is the completeness of cytoreduction. So unless you do complete cytoreduction, HIPEC is not going to be of much use.
I agree. There is another person here who doesn't practice HIPEC as well. Lata, do you have anything to add on it based on the evidence, even if you do not practice it?
I mean, I think I agree with Dr. Bafna when he says the cytoreductive surgery is the most important component. The only RCT we have is a one-trial trial, and we have to remember that it took 10 years to complete. There was huge underreporting of the morbidity. Currently, there's a lot of work on BRCA and PARP inhibitors coming up, and the case selection did not, I mean, the subjects recruited were not stratified based on BRCA. In fact, they are reanalyzing the OV-HIPEC, taking BRCA into consideration.
Absolutely.
So taking this into consideration, I think CRS is the first and the best step. And in India, with financials, with logistics, I really do not think we have enough evidence to emphasize on HIPEC for
every patient.
For every
Absolutely.
patient.
Yeah. So let me call on my colleague Rahul. What is the evidence in the recurrent setting? I know that this like one RCT and most of it is retrospective data. What is the available evidence for use of HIPEC in recurrent setting, Rahul?
Good evening, everyone. I think, like all my respected colleagues have told, there is no good level evidence for either in the upfront setting, only in the interval cytoreduction, even in the recurrent setting. On the contrary, there is some evidence against it. If you look at the recent MSKCC data for platinum-sensitive ovarian cancers, which was recently published, there is evidence against it. And if you look at the PFS in that data, it is actually less than the PFS which you get with GOG 213 and desktop, where they have used BEVAC and PARP inhibitors. So,
yes.
So when you can get the same without doing HIPEC, 5 months better PFS, if you look at the data, so it is controversial to use HIPEC in recurrent settings. But if you go through all these studies, like everybody has been telling, that it is a very selective group of patients where you can use. Usually it is that patients you have higher platinum-free interval, they do well, low PCI, less tumor volume, you get a CC0 resection, all these patients do well. But yes, I think in any case, they would do well if you don't give HIPEC to such, because these all are good prognostic factors anyways. So yes, whether it is the impact of HIPEC or not, it would be very difficult to judge in the recurrent setting.
So pre-selected good performance status, platinum sensitive, PCI less than 15 and optimal cytoreduction, again, are all factors which would anyway help in good outcomes. So as of now, especially in Indian setting, I think the cost is prohibitive in recurrent settings, but there is some evidence for use. So let's go into, if you were to select a patient for HIPEC, how would you assess a patient? How do you assess PCI? How do you assess the patient's acceptability for a HIPEC? Dr. Rama, could you take this question?
Yeah, I think we don't select upfront. We basically consider the patient for HIPEC.
Okay.
And the selection is always on table. We counsel the patient, even if the patient comes, and patients are very well informed. They just come and they ask you, what about HIPEC? So I think what is important is that when to do HIPEC, when not to do HIPEC. So even when we are considering, so we take these patients and then, of course, we counsel them. If suppose we go for CC0 and the patient is totally informed of all the morbidity and what other complications we can expect and how the stay in the hospital is likely to increase, the stay in the ICU is likely to increase. So we select our patients on table, as I said, that those patients who have achieved CC0, even in the recurrent setting. And in the recurrent setting, we are very choosy and selective of our patients for the surgery even. So in surgery, usually we go for the platinum sensitive patients and those patients who have comparatively the oligometastatic disease, means at 1 or 2 sites or 3 sites where we think that yes, we can cytoreduce it to CC0. So these patients also we choose for these HIPEC, or we select finally on table in the interval surgical cytoreduction as well as in the recurrent setting. So the patient factors are very, very important because the patient has to be in a good general condition and PS has to be ECOG 0 or 1. We don't select 2. And also at the other factors like comorbid conditions, you have to see any kind of the renal disease, chronic renal disease, we won't select them. And also those patients who are having hepatic dysfunctions, sometimes the patients do have some kind of the fibrosis, or you can say the cirrhotic kind of the changes, and also the cardiac conditions. These are very important that we don't consider any kind of the HIPAC for these patients. The disease factor is only one. What I feel is the CC0, as I think once we achieve this, then we go ahead for that of the HIPAC, otherwise we don't.
Okay, so solid take-home message, CC0 on the table is the most important thing for offering HIPAC. And if you probably already talking to somebody about this, do you have any checklists to optimize it? Because we know that preoperative optimization needs to be done for every single patient. But Rahul, can you just tell me, is there any checklist that we can follow? How do you prepare the patient? And most of all, how do you prepare your team? Because I know HIPAC probably needs like 2 teams, to step in, finish your CC because it goes for long hours. So quickly just run me through any checklist you use and your preparation of the patient and yourself.
Yeah. So at the outset, like Madam has told regarding the patient and the disease factors, we rule out, and then we specifically choose patients with less morbidity. Now there is a concept of modified frailty index, which we actually give to our onco anesthesia guys to calculate and have a say on that. So we basically divide after clearing from our side that this patient can be taken up for HIPAC, we actually send them to anesthesia people. And they have to look into a lot of things about their albumin levels, their frailty, and what complexity they expect from us. And also, is there a reserve ICU bed or a HDU bed for the patient post-op? So if it's not there that day, we won't take it. And rest, I think, with the perfusion team, we make modification in the type of the drug which is used. So for example, like Madam was telling with kidney disease or chronic diabetic with shrunken kidneys, maybe choose carboplatin over cisplatin. But as of now, nothing is standard protocol, even in literature. So the MSKCC team used carboplatin outside the data with interval CRS with cisplatin. So we don't know actually, but cisplatin definitely is too nephrotoxic in the post-operative period. So with our experience and also the dose modification, like we used 100 milligram per meter square for one patient.
Okay, I'll get to that. I'll get to that next. So it's just general optimization, or like for all ovarian cancer patients. Now, quickly, because we're short of time, can you just walk through just these 4 points? Dr. Rama, which method do you follow, open or closed? What's your drug of choice? What is the dosage that you use, and what's the runtime?
Yeah, I think the preferred method, what we use is the semi-open. Actually, usually there are closed methods also people have used, and also the open. They have got advantages and disadvantages, but on the whole, I think the outcome is the same. So we choose the semi-open technique. And also the drug of choice with us is cisplatin, because cisplatin has been used and the evidence is there with that of the cisplatin. The cisplatin dosage usually is 100 milligram per meter squared. This is how we are calculating. Most of the time, we are giving 50% of the dose at the beginning of this procedure, and then 25% after 30 minutes, and then another 25% we add after another 30 minutes. Usually the temperature is about, say, 42 degrees. That should be there in almost all the 4 quadrants. It depends on the type of the machine which you are using. That is the HIPAC machine. This is what is our concern. And the the drawback of the open method is that the temperature maintenance may not be that good, because it is open and temperature maintenance is a problem in the open system. And the runtime has also been, it is about, say, 90 minutes. We are using 90 minutes. And these are all the drug of choice. What kind of the drug should it be? What should be the characteristics of and the qualities of the drug can be chosen for the HIPAC. It should be water soluble. It should have the high molecule. What is important, I just want to mention one thing, that it is the penetrance into the peritoneal surface which is important. And cisplatin has got 3 millimeters of the penetrance, you can say. And as Rahul was just mentioning about the carboplatin, it doesn't penetrate to 3 millimeters actually onto the peritoneal surface. So we really don't know whether carboplatin can be used in this setting unless we have more information.
Absolutely. So the other thing is also to remember that these are all.
Anbu, we are short of time.
Yeah, Dr. Anbu, please.
So I'm going to just skip through this and come down to a couple of questions just that I want to focus on. Is there a legal implication for not offering this? That's one question that anybody can answer that. Lata, would you like to answer that? Is there a medical legal implication for not offering this to our patients?
I really do not think so, because it is not yet the standard of care. So only when we know that this is standard of care, not offering this becomes a problem. So I think we can explain this to the patients and refer them to centers that do it on a routine basis. But I do not think as of yet we have medical legal implications.
Okay, so I'd like to end saying we're still very divided on this, and I think the most important factor that still continues to rule the roost in ovarian cancer management is CC0 at surgical time. And of course, with new modalities of targeted therapies coming in, HIPEC is probably going to take a lesser role, or maybe more after OB HIPEC. We'll probably know more. Thank you for giving us this opportunity, and I end this here. Thank you. Thanks to my panelists. Thank you.
Thank you, Anbu, for that beautiful moderation of a very controversial topic, but you beautifully managed to discuss this. And thanks to all your panelists for sparing their time for this discussion. Let's move on to the next MDT, which is sort of uncommon and uncommonly discussed, but whenever a case comes, we need to scratch our heads and find the literature, what is the current evidence, which probably has not seen much over the years. So I would invite Dr. Colonel Tony Jose to moderate this session, and I would request him to invite his panelists, please. Dr. Tony Jose, please.
Thank you. Good evening to all of you. So as has been already said, we are in this panel discussing an uncommon but not rare ovarian tumor. So firstly, let me invite the esteemed panelists. Dr. Nisha, the unit head of in the Department of Gynae and Gynae Oncology at KGMU Lucknow. Dr. Mahapatra from the Department of Gynae Oncology at Postgraduate Institute Cancer, Cuttack. Both of them are gynae oncologists. We have a pathologist, Dr. Sandeep Mathur from the Department of Pathology in AIIMS, New Delhi. Dr. Mansi Shah is the medical oncologist on the panel. She works at HCG Cancer Center, Ahmedabad. And Dr. Advaita Gore, senior medical and hemato-oncologist from Prince Ali Khan Hospital, Mumbai. So let me start sharing my screen. We'll start with case history. So we'll start the case. We are discussing the case of a 56-year-old para-3 lady who presented with one episode of postmenopausal bleeding which lasted 3 days. She also had some heaviness in the lower abdomen and occasional pain. On clinical examination, there was a 10 by 10 centimeter abdominopelvic mass in the right lower abdomen. And on internal examination, this was a firm globular mass in the right adnexa, which was mobile, non-tender, and could be lifted out of the pelvis. Otherwise, uterus was essentially normal. So here we have a 56-year-old lady who presented with postmenopausal bleeding and a right adnexal mass, possibly an ovarian tumor. I would like to ask Dr. Mahapatra, with this history, what would be your initial clinical impression and how do you go about evaluating this patient?
Good evening, everybody. Thank you, Dr. Tony, for your kind introduction and moderating this panel. Coming to this case, according to her age and history of postmenopausal bleeding, and on examination, there is right adnexal mass and normal uterus and healthy cervix. It looks like a hormone-producing tumor which goes more in favor of sex-cord stromal tumor. Other diagnosis can be CA endometrium, metastasis to ovary, or ovary metastasis to endometrium, which is synchronous, which is very rare. So further investigations can confirm the diagnosis.
Yeah, Dr. Nisha, how would you like to investigate such a patient? How would you start evaluating this patient?
Right. Thank you so much, Dr. Tony. So the patient who has come with an adnexal mass, most likely an ovarian mass and an endometrial, there is a doubt that there is, because she's having postmenopausal bleeding also. So obviously one is an imaging that we need. The mass is mobile and all, we can go for an ultrasound and later for a CT, but in this age group, we can directly go for a CT scan abdomen pelvis also. That is one, to know about the extent of the mass, any infiltrations, involvement of the other ovary, and also looking at. Apart from the imaging, we also need to do one endometrial biopsy in this case, definitely. After getting the endometrial thickness and knowing whether there is a lesion or it is just a thickened endometrium, whatever, but it is required that we do an endometrial biopsy also. Apart from that, the third would be the tumor markers that we would like to do in this particular case, with the suspicion of course, I mean, if there are a clear cut, because it is like the postmenopausal bleeding, which is associated with it. So obviously it goes more in favor of the one of these sex cord stromal cell tumors, the estrogen producing tumors, although those markers which are specific to that can also be added along with your CA125, and so the specific ones that will have the estradiol levels and the inhibin can be done also in addition.
Thank you, Dr. Nisha. So
about ultrasound, color study and iota scoring.
Because as I said, since it is a big mass, we know it has to be removed only. Considering benign or malignant, we'll get features on the, I did not specify those, but it, in this age group having such a big mass, and it has to be removed only, and with that menstrual also. I agree, benign or malignant, the markers will add up to that, and the features on imaging will tell us.
Definitely, depending on the availability of the modalities of investigation, one may go with a higher imaging also. So this particular patient underwent an ultrasound abdomen and pelvis. The endometrium was thickened and the right ovary showed a predominantly solid lesion with cystic areas. Otherwise, the ultrasound was essentially normal. Now,
so
yeah.
You want me to? Okay.
We also did an endometrial biopsy, which showed a simple endometrial hyperplasia without atypia in this particular patient. And as discussed, the whole tumor marker panel was done. It showed the CA125-105, which was elevated considering she was a postmenopausal lady, and the serum inhibin levels were grossly elevated. CT scan was done for further characterization of the mass. So it was confirmed to be arising possibly from the right ovary. Size was 12 by 10 into 13 centimeters, and it was again predominantly solid with cystic areas. The left ovary, the uterus, was essentially normal. There were no enlarged lymph nodes and there were no ascites. So now, going back to the diagnosis, Dr. Nisha, how would you now arrive at the diagnosis?
Yeah, definitely with the investigations, what our suspicion was has become more this thing. And even in the clinical and the imaging, I wanted to add that because it was a solid, more solid tumor, lack of ascites, these are also the features which are going more in favor of that. And so, so the imaging findings, and then your endometrial biopsy also, which is endometrial hyperplasia, though without atypia, and also your tumor markers, all of them are going towards a sex cord stromal cell tumor, more likely to be a granular cell tumor. And a stage of the disease, of course, because you do not have the lymph nodes, the other ovary looks normal. So most probably it is still a stage 1A disease, but obviously the final histopathology will confirm that.
Okay, Dr. Sandeep Mathur, basically, we were talking about tumor markers and we were talking about inhibin. So there is a little bit of confusion about inhibin A, inhibin B. Which one is more reliable? Do we have to do both when we have to rule out a granulosa cell tumor?
So actually, as far as the serum markers go, the gynecologists usually go for inhibin A, but if you see, the inhibin B is considered also more specific in this case. Okay, so inhibin B is
it's considered to be more specific for the granulosa cell tumor.
Yeah, just to add, we had done one study also on this in our place, and there also it was inhibin B which was better correlated with that.
Right. So, Dr. Mohapatra, how would we plan further management? I'm sure our plan is ready.
Surgical staging is preferably by laparotomy to prevent spillage. Laparoscopy can be done in expert hands.
Okay.
Fluid for surgical staging, fluid for cytology, frozen section study, THBSO mendectomy, excision of any intraperitoneal disease, removal of any enlarged lymph nodes, routine systematic lymphadenectomy, but not beneficial, not recommended even in advanced disease, as nodal disease is rare.
Okay, Dr. Nisha, would you consider laparoscopy, at least for initial evaluation?
I think what he said is very right. Experience, skill of the surgeon will make that difference completely. So although the tumor, and it's a big tumor, it's a solid tumor, it's not a cystic tumor. So the removal with, with in the bag and then morcellation and whatnot. So I myself would prefer to go for an open surgery. It's a big mass that is there. And yeah, that was for your specific question.
Yes, intraoperative frozen section. Dr. Sandeep, how will you be able to help the surgeon if a specimen comes forward?
So it depends. If most of the times it would be a classical adult granulosa cell tumor, then the diagnosis would be fairly straightforward. But I do agree. I want to say that on frozen, sometimes the morphology may not be so clear and you may confuse it with a low-grade endometrial carcinoma or some other sex cord stromal tumor. That's possible. But usually it would be very bland with very few mitosis. So you will not consider a high-grade carcinoma or some other differential. So I think we should be able to give them a on-table diagnosis of an adult granulosa cell tumor and any further information which is specifically needed regarding separately sent biopsies or something.
Right. And Dr. Nisha, what would be the extent of surgery that you would do?
So in this case, because the patient is a 56-year-old postmenopausal lady, and so here I would go for a total abdominal hysterectomy with bilateral salpingo-oophorectomy.
Specifically, would you do a lymphadenectomy?
No. No. The pelvic and para-aortic, you have to palpate. If you find enlarged lymph nodes, then you can remove them. But that's incidence of metastasis in the granulosa cell tumors is very, very low. They usually spread in the adjoining areas rather than through the lymphatic approach. So that is why only if there are enlarged lymph nodes, that's what is the recommendation through whatever studies and all there, although it is a relatively rare tumor. So they do not have randomized studies for many of the things, but whatever is available. So they, whatever evidence I have.
Routine lymphadenectomy is not generally practiced. I would like to ask Dr. Mansi, what is your take on a complete surgical staging? Would you expect a complete surgical staging before, for any reason, the patient comes to you?
So I think for, especially for postmenopausal females, I think a complete surgical staging is considered to be one of the gold standard, especially because this is a tumor that is highly curative by surgery alone, especially in early stage cases. And adjuvant therapies, the role for adjuvant therapies, we're not
Yeah,
sure
we'll come to
exactly how
adjuvant
much
therapies
they have.
later. Basically, there is a lot of confusion and there's not enough evidence supporting a complete lymphadenectomy when you are dealing with a
Yeah, so I agree with Dr. Nisha that if there is no evidence of radiographic or at the time of intraoperatively, if the lymph nodes are not enlarged, if they don't do a lymphadenectomy, we would take it at face value.
Okay, so the bottom line is, if there are enlarged or suspicious lymph nodes, we go for the lymph nodes. Otherwise, we may omit lymphadenectomy in such a case. So coming back to the case, she underwent a full staging laparotomy. The capsule appeared intact and there was no evidence of any spread. But she underwent a full surgical staging, including a lymphadenectomy. And the histopathology confirmed what our suspicion was. I would again like to ask Dr. Sandeep Mathur, anything specific in the histopathology that can give a clue regarding the aggressiveness of the tumor?
Right, exactly. So I was reading the description associated with this figure. So it's showing a classical adult granulosa cell tumor as far as the morphology goes. You can see solid patterns. You can see these chorded patterns. You can see the Kohl-Exner bodies, nuclear grooves, and all the everything classical about it. So I'm rather surprised at the mitotic count, which is around 8 to 10, which to my mind is really on the higher side, because usually one would expect less than 4 mitosis in a classic adult granulosa cell tumor. So this itself seems to be an area, although there is no necrosis, nuclear atypia is definitely not there at all in these pictures which you have shown. So the only
how does IHC help in the diagnosis? We have
in such a classic case, the IHC is just a kind of a formality, but you can do calretinine, inhibin. That's the usual markers which we do in routine diagnostic setup. You can also do FOXL2, SF1. These are the other markers which are very specific as well as sensitive for picking up.
Thank you, Dr. Sandeep. Here, this particular patient, as expected, it was an adult granulosa cell tumor, but there were malignant cells reported in the peritoneal washing. So it was reported as FIGO stage 1C. Now that brings us to the question of adjuvant treatment. And Dr. Gore, would you be advising any sort of adjuvant treatment for this patient? Dr. Gore, are you there?
No, sir.
Okay, sorry. So I'll pose this question to Dr. Mansi again. If the patient comes to you, would you advise any adjuvant treatment in this particular patient?
So I think in whatever small retrospective studies we have for this rare tumor, it has been shown that stage 1C is kind of an independent risk factor in terms of the risk of recurrence. And adjuvant treatment has shown to improve the recurrence-free survival. Not sure about the overall survival. I don't think it has a great impact. So I would recommend adjuvant, maybe
And
paclitaxel.
what drugs would you routinely be using in case you use adjuvant treatment?
I think I routinely, for older patients, use paclitaxel. I don't go with the conventional BEP regimen.
BEP, okay, right. Okay, right. And is there any other modality that is commonly used? We particularly interested in hormonal therapy and immunotherapy and or targeted therapy.
I don't think in the adjuvant setting there is any evidence for using
So it's possibly in the recurrent setting that you would be.
Yeah.
Yeah. Okay. Right. So even the NCCN guidelines are not very clear as to the use of adjuvant therapy, and what is the follow-up that we would advise in such a patient? And Dr. Nisha, do we need to follow up such a patient?
Yeah, definitely we need to follow these patients, although these are relatively indolent, and we will like to follow her up in the first 2 years, every 2 to 4 months, and then later on maybe 6 monthly. But we understand that this group of tumors have late recurrences relatively compared to the others, and they have shown to have very long as I was reading 40 years, so that is how it is, the late recurrences. And because we were talking about
has to be pretty long.
Yes. So it has to be kind of a lifelong, maybe. And so every time you do a clinical examination, definitely, and you can do the tumor markers, imaging only if any of those shows a suspicion. So maybe like every visit clinical, definitely tumor markers initially you can do. And imaging, you wrote PET CT, not that like only if they are showing any suspicion.
Put it there only because it is very fashionable nowadays to do a PET scan.
Okay.
So, but generally, there is no evidence at PET scan.
Yeah.
So this is the NCCN guidelines, and what is noteworthy is that it is a very long follow-up. Even after 5 years, a 6-monthly follow-up is recommended. Though use of tumor markers every 6 months and imaging is there is insufficient data as of now. So that is where we stand. Dr. Mahapatra, you were saying something?
Dr. Tony, ESMO guidelines says recommending pelvic examination and tumor markers every 3 months.
Correct.
It has 2 years, and then every 6 months after the 3rd year until progression, a pelvic ultrasound should be carried out every 6 months in those patients who have undergone fertility sparing surgery. Whereas the CT scan of the abdomen and pelvis is usually carried out according to clinical indication.
So whenever there is recurrence suspected, a further imaging is definitely indicated. Yes. So we'll skip this because we have exhausted our time. So just to summarize, though uncommon, it needs to be considered in the differential diagnosis, and it is common. Granulosa cell tumors are common in the later part of life. Inhibin B is the tumor marker of choice. And endometrial malignancy needs to be ruled out, especially if one is considering a fertility sparing surgery, even in a younger age group. The most important prognostic factor is the FIGO stage and the completeness of surgery. Lymphadenectomy is not recommended routinely. Adjuvant therapy, yes, there is some controversy, but Paclitaxel is commonly used. Most important take-home message should be the follow-up is lifelong because late recurrences are not so uncommon. So I thank my esteemed panelists and I hand over to the organizers. Thank you.
Thank you, Dr. Tony.
Thank you so much.
Thank you, Dr.
So much.
Tony Rose and the panelists for making this complex and uncommon disease discussion a very interesting one. Let's move on to the fourth MDT of the day. That's treatment of the stage 4A cancer cervix when the disease is involved anteriorly, either the bladder or posteriorly the rectum or both. And to carry forward this discussion, I would request the moderator, Dr. Bhavna Rai, who is the professor and head of Department of Radiotherapy at PGIMS Chandigarh, to carry forward this discussion. And I would request her to call upon the panelists who she is going to take the help for moderating this discussion. Dr. Bhavna, please.
Good evening, everyone. Thank you for this opportunity, and I would like to congratulate the organizers for an excellent program since yesterday. We have a very esteemed panel on board. Introducing the same, we have Dr. Anubha Bharatuar, who's a medical oncologist at Patel Hospital, Jalandhar. Dr. Mathangi is a radiation oncologist at the BGS Hospital, Bangalore. Dr. Monica Malik is professor and head of radiation oncology at NIMS, Hyderabad. She is stuck in traffic, so she will be muting herself and will try to answer the questions if possible. Dr. Neha Kumar is a gynec oncologist at the BLK Max Super Specialty Hospital, New Delhi. And Dr. Karnal Bidhan Roy is a gynae oncosurgeon at the AFMC, Pune. I'll be sharing my screen now.
Good evening to you all. Am I audible and visible to you all? I'm Colonel Bidhan Roy.
Yes, sir, you are visible and audible.
Thank you very much.
Just a minute.
May I, ma'am?
Yeah, I am just trying to share my screen. I think there is some glitch at the last minute. Okay, is this being shared from your end?
Yes. Yes, ma'am.
Okay. So we'll be just okay. I would like to go on to the next slide, please. So we have a case who's a 54-year-old lady who was referred to us with history of bleeding and discharge PV for 8 months. She had no other significant complaints except for that there was an additional history of UTI, 2 episodes over the last 2 months. She had a biopsy done outside, which was suggestive of squamous cell carcinoma non-keratinizing type. Her hemoglobin was 10.8, TLC was slightly on the higher side, and platelets were within normal limit. Blood urea creatinine was essentially normal with creatinine on slightly higher side. A CT scan pelvis done outside showed a large growth at the cervix, which was measuring approximately 6 into 8 centimeters, infiltrating the posterior bladder wall. There was correction seen in the uterus causing distension and thinning of the myometrium. There was sub-centimeter bilateral pelvic lymph nodes seen. Next, please. So a clinical examination of this patient revealed that there was a large infiltrative growth which was there at the cervix, and this was involving all the fornices and was extending to the anterior vaginal wall in the upper 2 to 3 centimeters. Bilateral parametria were involved in medial half. Based on the clinical findings and the CT scan findings, she did have query suspected bladder infiltration. Next, please. So a PET CT was done. The uterus appeared, there were multiple subcentrometric enlarged para-aortic lymph nodes, iotocaval, paracaval, and pelvic lymph nodes, largest measuring 10 to 10 with SUV max of 1.2 to 1.6. The uterus appeared bulky. There was a circumferential growth which was seen at the cervix measuring approximately 6.2 into 7.3 into 8.8 centimeters with SUV max 10. There was cervical canal stenosis with associated collection in the endometrial cavity. The lesion appeared to involve bilateral vesicouterine junctions, and it was infiltrating the posterior wall of bladder. The rectouterine fat planes were lost. Next, please. So these were the images. Next, please. So my question to the panel is, this goes particularly to Dr. Neha. Would you like to investigate this patient further? Do you think there is any role of cystoscopy and biopsy now that we have advanced imaging?
Yes, definitely. I think the CT findings are suspicious, and I would like to go for a diagnostic cystoscopy plus minus a biopsy to see whether there is, and to confirm whether there is bladder infiltration, and if so, if it is focal or invasive or extensive. A cystoscopy will definitely help me in staging the disease and deciding the treatment further.
Okay, so you mean to convey that even if we have advanced imaging to prove a stage 4 disease, ideally a cystoscopy or a proctor rectal?
Yes, the reason for that is that many times in cystoscopy, we may just see bullous edema, which does not categorize it as stage 4A. So ideally, if cystoscopy is available, and this can be done as an office cystoscopy, you don't need the patient to be under GA. So just for a diagnostic cystoscopy, if it is available, yes, we should go and confirm whether the bladder mucosa is involved or not.
Okay, thank you. So next, please. Next, please. So rightly said by Dr. Neha, yes, definitely. This is recommended. A cystoscopy and proctosigmoidoscopy should be done for evaluation of bladder and rectum. Next, please. So what is the treatment intention in this patient? Do we consider for radical treatment or palliative treatment? Dr. Monica, are you available? In case
yes, Dr. Bhavna, this is Dr. Monica. Thank
Yeah.
you. Yes, so basically the intent would again depend on the specific features of the individual patient. The bulk of the tumor, the extent of infiltration, especially gross parametrial infiltration up to pelvic side wall, frozen pelvis, or even the extent of vaginal involvement, if lower third is involved or not, and if there are nodal metastasis or hydronephrosis. So all these would decide the intent of treatment, whether radical or palliative, in addition to patient factors like age, performance status, comorbidities, and expected survival.
Yeah, I mean, rightly said, because stage 4A actually is a wide spectrum of, it represents a wide spectrum of disease from a central disease which infiltrates maybe anterior and posteriorly to a disease which could be bulky with nodal involvement as well. So, Dr. Monica, what do you think are the prognostic factors that actually determine the outcome in patients with stage 4A disease?
Yes, so as I was saying, the bulk of the tumor and the extent of
question was Dr. Neha. I already asked you. Yes, I'm sorry. I was wanting to have a surgeon's overview as well.
Should I answer this question, ma'am?
Yes, Dr. Neha,
Yeah,
yes.
okay. The prognostic factors will be the tumor size, definitely the tumor size, the extension to the lateral pelvic wall, and more definitely the involvement of pelvic and para-aortic lymph nodes, which significantly, if positive, significantly decrease the survival outcomes. So these are the main prognostic factors, as well as the age of the patient and the performance status.
Yes, because we know that in stage 4, now that we have results of the embrace, you could have good local controls as high as 90%. And on the other hand, you could have patients who are just fit for palliative treatment. So it is important to rightly choose the patients. Okay, so next, please. So what do you think are the treatment options in this particular patient? My question goes to Dr. Bidhan, who's a surgical oncologist.
Yeah, good morning to you. Good evening to you. Actually, as a gynae surgeon, our intent for the stage 4 alpha patient should be to give you the extent of the disease, to give you a surgical extent of the disease so that the treatment line can be modulated. Say, for example, with such a large mass, I would like to add that there is a definitive role of surgical staging also with laparoscopy or laparotomy, because it's such a large mass. I doubt the finding of the PET-CT because I will definitely expect some nodal presence also with that large size of the lesion. Say, for example, if there is even micrometastasis in the para-aortic lymph nodes, I would like to bring out this point that this will require either an extended radiotherapy, extended field of radiation will be required. Otherwise, there will be distant failure of the disease. Now, so our aim is of seeing such patient in the OPD should be primarily to mark the extent of the disease, to delineate the extent of the disease, both loco-regional as well as the distant. Now, PET-CT, I agree, is a good modality, but it will not definitely give you the picture of micromets. And equally so, the micromets is a failure of the distant. If there is a micromets, as Dr. Neha has said, that the para-aortic lymph node is a significant prognostic factor. So, in addition to what has been done said so far in the workup, I would like to add that the surgical staging can be added to this patient. And this will help in basically delineating the role of extended pelvic radiation. Now, coming to the other things, the mode of surgery. Now, surgery primarily in such cases, primary exenteration is not warranted because we have other good modalities of radiation. And in case where the radiation is contraindicated, or in case where there is a metachronous tumor, metachronous cervical tumor, wherein pelvic radiation has already been given. These are the cases where we can give the option of primary exenteration surgery, or where there has been impending fistula. So where the radiation therapy would be contraindicated. So my take on this patient is that the primary surgery is not warranted for unless and until there is contraindication for radiation therapy.
Okay, thank you. Dr. Mathangi, would you want to add on in terms of, would you want to treat this patient with radiotherapy? Like Dr. Bidhan said, yes, he would also opt for radiotherapy in this patient, but I want to know that, would you want to do surgical staging in this patient for evaluating the extent of microscopic nodal involvement? Dr. Mathangi.
Thank you for this wonderful question. So in this particular patient, when we consider there's a bulk of the disease, what are the factors that I'm really considering as a radiation oncologist? Because it's a microscopic metastasis, I will be anyway including the pelvic nodes. Whether to include the parietic nodes comes the next point with SUV max of only less than 3. And parietic nodes are not significant. Whether
Collection in the uterus, of course, I mean, we know that could be the cause of.
Another point I'd like to say is that as a gynae surgeon, I would like to drain out the pyometra also.
Yeah, I understand that, sir. I agree with you. The thing is, what happens is what I would be looking mostly as a factor in this patient is what is the surface area of contact? Because with my radiation, whether in between during the radiation, if this patient is going to go for a fistula, then it will be like indeterminate treatment. Like I would have done only half radiation and then I have to give it to a surgeon saying that I've developed a fistula. So what are the probabilities of getting a fistula is more important rather than irradiating anyway. Pelvic nodes, parietic nodes is a part of all cervix. Especially when we consider 4A, I will be thinking what is the contact surface area? If the entire thing is in the rectum area or in the bladder area, what is going to be the response? How am I going to treat further with brachytherapy? All these factors will tell me whether I'm going to give us a radical treatment or a palliative treatment. If there is, in this patient, almost 2.5 centimeter contact area is there to the vaginal area and the tumor and the bladder area. So I have to mentally prepare the patient, though I will be going in a low dose per fraction, like only 1.8 per fraction. And then I'm expecting a fibrotic response developing during the course of radiotherapy. And the tumor response should be good for me to help in brachytherapy. These are all like goodwill. Yeah, but still I have to prepare the patient with the worst outcome, saying that be prepared for fistula, then I'm ready to do with radiation. Preparing for them worst and giving a good response has always yielded me a good results in my practice, because they're always scared, but that doesn't happen. They praise you, but you don't prepare them mentally and then you result in fistula. They are not ready for this. So as far as stage 4A concerned, we have to plan only patients' mental preparation and ourselves being prepared how we are going to encounter in such a situation is going to arise. This patient, I would be happy enough after a good counseling to take them for a chemoradiation, radical intent chemoradiotherapy in a fractionation of 1.8 per fraction would be ideal for me. 45 grade 25 fractions, and then we can discuss further. Yeah.
I think we are running short of time also because we probably started a little late as well. So I think yes, you said that maybe you would consider 2.5 centimeter contact. Do you think there is a cutoff, and what makes you say that? Is it based on any evidence?
So there are papers which says more than 2 centimeter clinical infiltration. If it is there, then it might result in a clinically significant fistula. For example, small focal infiltrations. In our clinical practice, we have not seen those patients also developing fistulous formation. But the bigger the lesion, obviously the chances of fistula, it's a logical thing. And also papers have proven that the cutoff value is somewhere between 2 centimeter.
So very rightly said, communication is again very important. So coming to chemotherapy, I think I will be just moving on with a few questions. So next, please. So regarding chemotherapy, next, please. So chemotherapy, my question goes to Dr. Anubha. Do you think there is a role of neoadjuvant chemotherapy in this patient?
Ma'am, good evening and thank you. Yes, as I agree with a lot of things that Dr. Mathangi said, but I think we all know that there is no actual standard of care for stage 4A. You know, we have to individualize the treatment and we have to look at our patient and decide that what would be best. And while neoadjuvant chemotherapy is not a standard again, I would say there is a role of neoadjuvant chemotherapy in such patients because it would tell us the biology of the disease. You know, there are some papers, small patient groups, which have shown that if you give a few cycles of chemotherapy, 2 to 3 cycles, you can have a good response and then go on to do concurrent CTRT. And if you don't have a good response, that already tells you that this is a patient who is not a candidate probably for CTRT and probably would benefit from maybe palliative radiotherapy. So it would help us to decide. Again, I think it's very important what you said, is our intent, you know, definitive or is it palliative? So maybe neoadjuvant chemotherapy would have a role to play in that because it would tell us about the biology of the disease. And we also know that right now, again, there are a lot of things we don't know. We don't know the exact regimen. Most of us favor carbopacly, but there is some meta-analysis to say that dose-dense chemotherapy is better, you know, weekly chemotherapy is better. Some people we have some papers even from your institute about cisgem along with CTRT and then adjuvant. So, I mean, what I'm trying to say is that nothing is written in stone. And that is the purpose of the MDT. But this is a patient that I would consider for CTRT also, given that she has a very high risk of having a fistula. You know, if we can prevent that, yes. And if we can prevent that, if you give chemotherapy, she has a good response, you do a cystoscopy again, you see that, you know, that has gone away, then that would probably help the radiation a lot better.
So the primary treatment you feel would be chemoradiation. with upfront chemotherapy. Okay, thank you. So next, please. So as you said, it's not really backed by evidence, but according to the NCG also, that is something we could do for these patients. And the evidence that I found was basically only from a small retrospective series, again from India. Next, please. Next, please. Next. So the patient was planned for IMRT with 46K, 23 fractions with concurrent weekly cisplatin. Now, post-external radiation, I mean, for stage 4A particularly, once they've completed external RT, is there anything else that you would want to now go ahead? I mean, how do you go ahead with? Because do you want to go ahead with concurrent chemoradiation, with brachytherapy? You want to go ahead with SABR or with surgery? So my next question would be to Dr. Bidan. Post-external radiation, what treatment do you think you would consider surgery?
Actually, I'd like to wait for at least 4 or 5 months, at least 4 to 5 months, and I'll do a repeat PET-CT as well as an MRI.
I mean, would you want to stop? I'm sorry for interrupting you, but would you want to stop at just external radiation? I mean, what I'm trying to ask you is that post-external radiation, something like we used to do in, say, endometrium, upfront radiation and then surgery.
Yeah.
That's something that you would practice.
Not exactly like that, but there's something known as the adjuvant completion hysterectomy or something which known as the adjuvant hysterectomy. But the evidence do not support such events. What I would like to see after 3-4 months, do a PET-CT and an MRI to see the residual disease mass, and then accordingly delineate, accordingly go ahead with the patient. Definitely.
I'm really sorry I'm cutting you short, but we just have to wind up with this.
Definitely.
So like you said, so perhaps that would come if the patient has a residual disease post-external RT and brachytherapy. That's what you mean. And currently there is no
evidence to support my.
Yes. So Dr. Mathangi, would you like to have do brachytherapy for this patient?
Yeah, we generally do. Most of our cases we have only taken for brachytherapy because I feel an SBRT is not still established in such situations, and I'm not even comfortable. It also depends on what is the response. Like, for example, it is a bladder infiltration or a rectal infiltration. Rectal infiltration, obviously, the response to EBRT, whether my brachytherapy dose has to be contributed to the rectal wall, then I will be probably considering SBRT in such situations. But in case if there is a good response,
Yeah, I can get it. You said you would be considering.
I'm sorry. The thing is, if it is infiltrating the rectum, that is where the brachytherapy or your SBRT, because how to boost that dose to the rectal wall will be my situation there, how to manage this, because that is a major constraint and the disease is also there, still not responding to EBRT. But as far as bladder infiltration, we have treated with good number of interstitial needles and interstitial brachytherapy in our setup, and we have had a good response to and good disease control also.
Yes, Dr. Monica, what is your take on SABR as boost?
Yeah, I agree with Dr. Mathangi in the sense that if the patient is suitable for brachytherapy and has good response, then we would prefer to do a brachytherapy. If the geometry is not suitable, if there is gross parametrial involvement or lower vaginal involvement, or we think we cannot give adequate dose coverage, then probably consider SBRT. And also the other situation where I would consider SBRT is if eventually an exentration is planned and the idea is to get as good a response as possible.
So I think we just heard a very wonderful talk yesterday. So SABR, basically, if you can do brachytherapy, then SABR does not really have a role. But yes, it could have indications if brachytherapy is not possible, which I think would be very few situations. So going to the next question, and perhaps the last question. Next, please. Next, please. Okay, my question, previous one. My question would be to Dr. Anubha. Is there a role of adjuvant chemotherapy in this patient?
Ma'am, again, this is not a standard of... hello, ma'am, can you hear me? Yeah.
Yes.
Yes, sorry. As of today, there is no role of adjuvant chemotherapy. We've all heard right now there was a large phase 3 trial that was presented at ASCO, the Outback trial, that showed that, and it randomized around 1,000 patients to getting 4 cycles of carbopacly after concurrent CTRT, and there was no benefit. And in fact, in the elderly population, which is over 60, it showed that CTRT was a little bit better than at getting adjuvant chemotherapy. So definitely, right, as of today, there is no role because there was no difference in PFS or OS, and both the groups did equally well. Yeah, at 70. I think the 5-year survival, 3-year survival was 71% or 72% in both the groups. And there was increased toxicity, even though at 1 year that went away. So, yes.
So currently there is no role. Evidence does
There
not
is no role.
support. Okay, so next, please. Next, please. Next. So I think we would just like to summarize because of shortage of time. We will just wind up. So according to the NCHG guidelines, we can kind of stratify our treatments based on the extent of infiltration of the organs of bladder and rectum. So if there is a focal infiltration, it is upfront pelvic chemoradiation followed by assessment with cystoscopy or rectosigmoidoscopy followed by image-guided adaptive brachytherapy with dose as possible, or radical RT alone in patients who are not fit for concurrent chemotherapy. If there is focal bladder or rectal infiltration with paraortic lymph nodes, you can give 2 to 4 cycles of NACT followed by evaluation of response and extended field RT with concurrent chemotherapy and brachytherapy or palliative RT depending on the parameters and the patient performance status. In case of frank infiltration, it's upfront palliative radiation or palliative chemotherapy or just a palliative care reference with best supportive care. Select patients may be considered for exentration after pelvic artery depending on the treatment outcome and availability of infrastructure and expertise. Thank you.
Thank you. Thank you, Dr.
Thank you very
Bhavna.
much.
Thank you.
Thank you, Dr. Bhavna. And I think over last 1 hour, the panel moderations that have been done, if we practically emulate these type of moderations in all our centers are going to become the centers of excellence, and the patients will get the best evidence-based care. Now it's time to move on, and the next session is regarding video presentations. And I hand over to our gynae surgical oncologist, Dr. Manas Biswas and Dr. Kanika Batra to carry forward the proceedings. Thank you once again.
Thank you very much, Dr. Sandeep Batra. This is Dr. Sharan Chaudhary. I'll be conducting the video presentation session. This is our penultimate session. And may I now invite the chairpersons, Dr. Sabita Gupta. She's the chairperson, Department of Gynecology and Gynec Oncology at the Medanta, Gurugram. Dr. A.K. Anand, who's the Principal Director of Radiation Oncology at the Max Institute of Cancer Care. And Dr. Harshad Parasnis, Consultant Gynecologist and Gynecological Oncologist at Parasnis Hospital, Pune. So may I invite Dr. Sabita Gupta to introduce the first presenter, Dr. Subramanieshwar Rao from Hyderabad, to present his video on laparoscopic ovarian transposition.
Thank you, Doctor. And yeah, so I'll be inviting Dr. T. Subramanieshwar Rao. He's the Medical Director and Chief Surgical Oncologist at Indo-American Cancer Hospital, Hyderabad. He has many publications to his credit, many awards and achievements. And actually, he needs no introduction because we all know him very well. So over to you, Dr. T. Rao, for laparoscopic ovarian transposition video presentation. Is he there?
This one is online.
Watching Dr. Rao's videos is always a treat. And yeah, he's a great teacher. He's a great teacher, I must admit that. Yeah. Yes,
Sabita, I took some time to share screen, expecting you to talk a little more about me.
I knew it. This is coming.
Anyway, thank you so much, Sabita. Thanks a lot, Manas, Kanika, and all of you at Maxcon for this wonderful opportunity. Now I'll get straight to the video. There's no data here. What we understand is this procedure, whether it's open or laparoscopic, could be robotic also, is grossly underused all over the world. Our data also is equally appalling, and that was the stimulus for me to develop this video and the talk. In 6 years, 320 patients were 20 to 40 years out of 2,400 patients who received curative intent radical RT in the institute. And ovary transposes were done only in 26 patients, and 25 of them had actually reached us and not the radiation oncologist. So that's how less it is used as a procedure. What is also important is the fact that you should always try to transpose high in the abdomen, because not all systems and not all radiation oncologists can actually contour well enough to avoid scatter radiation, and ovary does not require too much of radiation for it to die. So it's important to learn this technique well, so that you would help your radiation oncologist keep the ovaries. And we know that the gonadals come somewhere in the center of the abdomen, above the inframesenteric, almost always. It is between the mesenterics and the renals, sometimes from the renals. And the arc of rotation becomes very important. If it is a low transposition, then it's not a major challenge at all. Any basic laparoscopic surgeon can do it very easily. But if you have to do a high transposition, that's when you need to actually have an obtuse angle of the vessel here, so that there will not be any kink. And unless it is at the L4, L5 level, the ova does not reach the liver or the spleen, depending on which side you are transposing. So this is something that we need to understand. There should not be any compromise in a good complete mobilization of the pedicle till it reaches the lateral border of the aorta or the cava. Patient positioning is same as most other procedures. Whenever you're doing a hysterectomy for cancer of the cervix, or pelvic malignancies like rectal cancers, commonly in young patients wherein you do ovarian transposition, best is to have Allen stirrups, so that if it is truly necessary to go high. And for ergonomics of suturing, it's always good to stand between the legs. Some surgeons do believe and actually stay comfortable doing the left transposition from the right side and right transposition from the left side. Always good to have two screens so that the entire team is comfortable. These are ports for paraortic lymphadenectomy when you add paraortic lymphadenectomy, but otherwise what you need are 4 ports, 1 camera port and 2 other ports, depending on which ova you need to transpose. One second. I don't know, there's some problem with the video. I'll go to the next one. Isolating the IP ligament is extremely important to be far away from the ovary, as far away from the ovary as possible. And your graspers, it's much more difficult to keep the ovary and the pedicle intact in minimal access surgery. The instruments are not as soft as your hands. In open surgery, you can use your hands, and hands are soft, gentle, more gentler than the instruments. So it's important not to hold the ovary or the pedicle at all during the entire procedure, and that is achievable by doing flaps of peritoneum. I call them flags, but they are flaps of peritoneum on either side. Never stay close to the pedicle, because that's when injuries happen, both thermal injuries and mechanical injuries happen. And it's important to get the entire utero-ovarian ligament to the ovary, because it will be very useful while you actually take it up into the upper abdomen and while you suture too. And that it is, the dissection is not based on the pedicle. It's based on the vessels the ilioinguinal nerve, the retroperitoneum, the first major. So everything that is in front of these structures is something that is swept towards the pedicle. So all the teasing should be done towards the pedicle and not away from it, because there are multiple small vessels, not in this patient, multiple small veins that drain into the IP ligament, and that's when there can be hemorrhage. You can see a vessel there. So important to coagulate that and tease it towards the pedicle without ever holding the pedicle. So the flags of peritoneum that you raise become very, very useful. And the anxiety of devascularizing the ovary is generally ill-founded as long as you stay very close to the tube. You don't do a wide excision of the tube. You just do a tubectomy, a salpingectomy. The dorsal limit is ureter, and it's important to identify the ureter in the upper part of the pelvis and sweep along the ureter so that you get a good peritoneal flap along with the pedicle. So this is when two things don't happen. One is physical injury, mechanical injury. The other thing is twist. The peritoneum does not allow it to twist because it acts as a scaffold and allows a good clean lift into the upper abdomen. So you can actually, there is a clean plane between the pedicle and the ureter, avascular plane, and that is something that you must hold on to while the pedicle goes up. So what you are holding is everything else except the pedicle itself. On the left side too, depending on how comfortable you are and which side of the abdomen you stay while you operate, the lower part, the pelvic part of it is preferably done on one side of the patient or the other. Most gynecologists trained while the primary training is in gynecology, most of them stay on the left side of the patient, but we operate from the right side of the patient predominantly. But if I'm doing a single ovarian transposition, and if it is the left one for various reasons, especially in rectal cancer, I stay on the side and do it. Rectal cancer, because you want to bring the sigmoid later on, if you are considering radiation therapy, that is when you would always prefer a right ovarian transposition. Otherwise, I think for anybody who is learning initially, probably you must choose the contralateral side of the side that you are actually operating from. Once you have done that, on the side, once again, it's just the mirror image of the same, although the anatomy is different. The sigmoid colon is much more difficult to handle on the left side. It's much more bulky. The cecum actually helps you with the mobilization. And then the cecum comes along, and it's basically something that can be high in the middle of the abdomen. That way, right transposition becomes easy. So it's important to keep most of the loops of vessels that run from here so that the ovary maintains maximum blood supply while you're doing the salpingectomy. You also preserve the round ligament, sweep it along the round ligament. And what is also very crucial is the ovarian ligament. It's probably the toughest structure that you should preserve so that it will be there for you to grasp while you put the ovary into a buttonhole that you create later on. So the same thing is continued dorsally, and then the procedure is completed. We need to stress and tell the youngsters that during the entire procedure, I've never held the ovary. I was pushing it away, but never held the ovary. I've never held the IP. It can be time consuming. Sometimes with a tough sheet of congenital adhesion like this, it can be difficult, but I think it's important to get onto the vessel, onto the nerve there, into the retroperitoneum, and sweep everything in the retroperitoneum along. So once you do that, the pedicle is surrounded by tissue, and that's where you will never lose an ovary, and it looks healthy at the end of it. The next step is the people who retroperitonealize it completely. You could definitely do that, but that requires a lot more mobilization of the colon and especially the left colon. Right side, it's much more easier. So keep driving upwards. This part of the procedure, I always find it much more easy while you stand between the legs. Ergonomically, you're comfortable. You don't have to turn your shoulder and look upwards. That's when the monitors can be in an uncomfortable position, except if you have a very robust unit where multiple monitors are there. And this is probably the most important part. These two stay in different facial planes. God makes things very, very carefully. You can see that the pedicle and the surrounding tissue, you can see a big large pedicle there far away from here, are in different plane. Always is a bipolar tool so that there is no lateral thermal damage. It's a little more time consuming, but it works for the patient. You can actually see that there is a potential plane, nothing much that you actually need to dissect or develop. As long as you follow this and climb up into the abdomen, it's quite possible that you will have a very good ovary going up. You can see the big long pedicle there. While you do this, especially on the left side, you can really reach the utmost of the abdomen. Transposition, when you reach the spleen, the splenic flexure, rather, many times you can actually see the spleen that I would show in the next video. And then you make a buttonhole. You can see the spleen there. That is the splenic flexure. Make a buttonhole there. The multiple methods of fixing the ovary there. If you are a good endosuturer, you can place it anywhere, but this actually works. Buttonhole always means a buttonhole. It has to be smaller than the size of the ovary. This is where the ovarian pedicle becomes important. Further mobilization. And then with a curved grasper, you go inside. With a bit of a push and a pull, this comes out with a lot of ease. Once you do this, you do not have too many instruments working here. This step is much more difficult if you are staying on one side of the patient or the other. It's easier if you are in between the legs of the patient. It comes up, and then you could check with pneumoperitoneum. If it is lying like this, once you decompress, it lies very loose and very comfortable. I suture practically every day. So suture, I clip, and then I use a few metal clips so that the radiation oncologist and the future scans, when they are done, the radiologist understands that it's an ovary and it is not a tumor. We routinely do a ICG to understand that the ovary is actually vascular. You can see the dye coming in, and then the pedicle itself becoming green, blushing with green on both the sides. Right transposition can be easy. Probably it's better if you are a left-sided surgeon. It's better to do a right transposition first when you're picking up skills, and that is the actual plane, very close to the muscles, and then you go behind, tease everything, every bit of tissue onto the pedicle. Keep everything on the pedicle, so that provides safety for the pedicle. Same maneuver on the right side. At the hepatic flexure. You can see the vessel here going up like that. A bit of an angle here. Probably not the best thing to do, but when you do an ICG, it was quite good. You can see the liver there taking up the isotope, the dye rather, just under the liver. Here again, very well vascularized. Very well vascularized in this ICG mode, and that is the liver that is taking up the dye. Very well vascularized ovary. It remains an unmet need. Post-treatment quality of life is growing in emphasis. It's important to alert our radiation colleagues to refer these patients for these procedures. It's a fairly simple procedure if you protocolize it and become a good team. Always aim a high position, barely outside the pelvis, I would feel is insufficient, except if you have the best of the radiation teams who do dose painting and things like that, so that the ovary stays alive. Thank you very much.
Thank you, Dr. Rao, for the wonderful presentation. And
now may I call upon Dr. Harshad Parsnes to invite the next presenter, Dr. Rohit Ranade, please.
I'll stop sharing. 1 minute.
Yes, thank you.
At the outset, let me thank Dr. Manas and Dr. Garg and Dr. Sardana for inviting me here. It's actually a pleasure to be on this forum, and I've been listening for the last 2 days about the deliberations. And am I audible?
Yes. Yes.
So moving on to the next topic is exenteration, and to present it we have Dr. Rohit Ranade. He's a consultant gynecologic oncologist and a robotic surgeon. He's an alumni of Tata Memorial Hospital and presently is working with Narayana Healthcare Bangalore. So the stage is all yours, Rohit.
Thank you. Thank you, Dr. Harshad. At the outset, I thank Dr. Manas and Dr. Kanika for this invitation. I have a video of robotic assisted anterior exenteration. Just allow me a minute to share my slide. Share my screen. Just a minute. I'm not able to share the video.
First open your video, sir.
Yeah, I have already opened it.
And then share again. Yeah, it's coming up.
Coming?
Yeah.
Yeah. Can I see? Can you see the video?
Yes, sir.
Yeah.
Okay, so this is basically a robotic assisted anterior pelvic exenteration on the SI system. It's a robotic assisted one. So, being greetings from Bangalore, from Narayana Health City. So this was a 70-year-old known case of squamous cell carcinoma of vagina, and she had received chemoradiotherapy for the same, and she basically presented with dribbling of urine through the vagina, and unfortunately she had a large fistula between the trigone and the vagina, and it was also extending to the upper urethra as well. So not much significant in the obstetric and menopausal history. So we had an MDT discussion in the tumor board, and a preliminary PET scan was done, which was non-metastatic. So these are the ports. So this is the center camera port. We use total 5 ports. So the R1 is the monopolar one. This was the assistant port, which is put in a right side, and the arm 2 is the bipolar one, and the arm 3 is the progress one. So we're more comfortable putting 2 arms on one side. There is also an option of putting the arm 3 on the right side, so that you can have 2 graspers, one on each side. And the position is the Streep Trendelenburg's position, common for pelvic surgeries. So the surgery starts with the dissection of the spaces. So we develop the paravesical and the pararectal spaces. You can see there are post-radiation changes. Fortunately, they are not that much. They can be much worse than this. And then the first step is to dissect the ureter. The ureter is dissected as low as possible. And you can see the structures in the pelvis. You can see the pararectal and the paravesical space. The ureter is dissected as far as possible so that you can get a good amount of ureteric length. Left infundibulopelvic ligament is cut, coagulated. And then the ureter is further dissected down, because it's good to preserve the length of the ureter as much as possible, so that especially on the left side, because you have to bring the left ureter to the right side for the conduit. The round ligament is cut, and then the space is further developed into the paravesical space. You have to go flush till the pubic bone. This is the paravesical space where you go low up till the levator ani. The same steps are done on the right side. The ureter is dissected again similar way, as low as possible, so as to give adequate length. Instead of using bipolar, you can also use clips as well. This is the right round ligament being coagulated and cut. And you can see the interiliac artery or the obliterated hypogastric artery is held. These are the various structures. You can see both the spaces, the paravesical space and the ureter in between. Then the interiliac artery is clipped with 2 Liga clips. And then the ureter is again further dissected, taking all the tissue to the specimen side, so as to give adequate ureteric length. Same dissection is continued on the anterior, and the entire bladder is taken to the specimen side. All these bleeders can either be coagulated with combination of bipolar, and then the ureter is clipped as low as possible once you're sure that you're going ahead with the exentration. And then you can do a hybrid technique, like if you have a good assistant, then the assistant you can dissect with a robot, and then your assistant can fire the ligation or any other energy device. The further dissection is continued down, and the entire tissue is taken to your side. The rectum is further dissected, because that is important, because you need to make a good plane between the vagina and the rectum, because you need to suture the vagina and also save the rectum. Further dissection is continued. You can keep something like a gauze piece into the vagina or a sponge. Usually, most of the times, post-RT, the vagina undergoes a significant stenosis. So it is not possible to put the vaginal tube. So you can put a sponge on stick. Same dissection is done on the left side. The ureters are clipped as low as possible. The rectum is further mobilized down. These are the parametrial vessels which you can clip. And then once you have opened the vagina one, that acts as a good guide for you to continue the dissection. Again, you can use ligashore and then continue the dissection same way as that you have done on the right side. The rectum was further dissected so as to give a good adequate vaginal margin. This part tends to bleed a little more. The anterior dissection is done at the last, because if you do the anterior dissection first, then the entire bladder drops down and then it becomes a little difficult in MIS. So the anterior dissection is done in the last, but when you do both from the sides, very little remains in the center, and then you go down as far as possible. Fortunately, in the females, the dorsal venous complex is not very well developed. So you can either cut it with bipolar or use a ligashore. There is no need to suture every time, and then you can cut on the Foley's. The Foley's catheter acts as a good source. So in this patient, we didn't do pelvic node first. We did pelvic nodes later because the PET did not show any enlargement of the nodes, though there are some centers where the pelvic node dissection is done first. And then the Foley's bulb is, Foley's catheter is cut. The specimen is delivered. The specimen was not delivered, it was kept in the abdomen. And then the vaginal vault was closed with V-lock. If the vaginal opening is quite good, then you can even deliver the specimen from outside. And then the reconstruction was done by a 3 to 5 centimeter infraumbilical midline incision. The ureter a hole was made in the sigmoid mesentery, and the ureter is shifted to the left side. The post-operative stay was uneventful. The ICU stay was around 2 days, and the total hospital stay was 7 days. Thank you.
Thank you, Rohit. Thank you, Rohit. Do we have some time for a question, or do we proceed to the next session?
We have time for one question, if there's any.
Rohit, do you routinely not do pelvic node dissection before you're going in for any exentration?
I mean, normally most of the times we do a pelvic node dissection first, but this lady already had a big vesicovaginal fistula. So we were going to go ahead with an exentration. So in this case, that's why we didn't do a pelvic node dissection first. But yes, routinely, normally pelvic node, it is better to go ahead with a pelvic node dissection. If there is nodal disease above the common iliac, that is above the pelvis, then you need to abort the exentration if it is not done for a VVF.
Okay. Thank you, Dr. Harshad and Dr. Rohit. May I now call upon Dr. Supriya Chopra, who's a radiation oncologist at the Tata Memorial Hospital, to deliver a video on MRI-based brachytherapy. Dr. Supriya Chopra is professor and radiation oncologist at the Tata Memorial Center, Mumbai. She has several honorable awards and achievements. She's been an editor at the Journal of Clinical Oncology and guest editor of the Indian Journal of Medical Research special issue, and a research committee member. Dr. Supriya Chopra, please present your video.
Good evening, everyone. Thank you very much to the entire Max team for the invitation. I'm just going to share the screen. I hope that's visible to everyone.
Yes.
So in the next 10 minutes, I'll be talking about, I have been specifically asked to talk about advanced brachytherapy techniques. And most of the audience, at least who are radiation oncologists here, would know that the standard treatment has been just to put, devices in the uterus and in the vagina. And essentially, we have been treating for many, many decades what's equivalent to a type 2 hysterectomy. So when patients have gross residual disease after external radiation, so tumors used to not be covered properly, but in the last decade or so, there have been host of devices. Here I show on the screen intracavitary interstitial applicators, which can be used to improve the local control And here are few examples. I'll describe some of these procedures. So this is a case example of a lady who had stage 2B disease. And you can see that she had a very large tumor infiltrating the parametrium on both sides, endocervical extension, exophytic and vaginal extension. And we started her on external radiation and brachytherapy, which she completed with central residual disease and medial parametrial disease. So in such a patient in our institution, we try to do advanced brachytherapy with the aim to cover the target with as high dose as possible and as low dose to adjacent nearby structures like sigmoid, bladder, bowel, and other structures. So I will not go too much into, the trolley preparation and what all instruments are required because I've already shown them. So generally we start our procedure with localizing the cervical os, and after cervical os has been localized, we perform dilatation of the canal because most of these applicators are at least six French Higar size. So generally we dilate up to 8 French. And you can see when I'm doing this, along with that, there is a trans-abdominal probe on patient's abdomen, which is showing us live ultrasound pictures because unlike many other techniques where you can open and do the procedure, this is essentially a blind technique. And you can see that I have placed the uterine tandem inside, and the vaginal applicator will be slided above it to put it inside. So this is when you are doing standard procedures. However, if you choose to do advanced procedure, then the first thing that is done is to assemble these applicators outside the patient because there will be needles that are involved which go inside parametrium. And as you've seen in previous videos, most of the parametrial space will have blood vessels, and you want to be sure that you don't unnecessarily harm either the vaginal mucosa or hit on the parametrial or any of the major vasculature. So you can see in this video how I'm externally assembling this applicator, and these titanium pre-bent needles are introduced into the hole of the applicator. And when they are inserted inside, they go to the medial parametrial space and also giving dose slightly to the lateral parametrial side. So once this applicator is assembled, we make sure that needles don't come out on the proximal end of the patient. And this is a device which I use to push the needles inside. We introduce it from outside. This is what I'm showing outside the patient to rest at this particular area and then go in the direction of the uterine canal and the parametrial space, because that is how the structures and anatomy of the patient would travel. So once this is done, so I've already shown you how we insert the main applicator. So once the ring travels inside, we try to push in the needles anteriorly and superiorly in the direction of the uterus. And you can see here I'm pushing the spanner and pushing the needles inside and then slowly removing one by one the spanner. So you can also do it with your hands, but your hand should hold the needle at the level of the bend. These are titanium needles which bend very easily. And if it is not done appropriately, it can bend inside the patient and sometimes also not proceed ahead to the parametrium space. You can see how this needle has beautifully gone inside. And we repeat this in stepwise manner for all the needles that we are planning to put. In this case, the position of needles is pre-decided based on the parametrial extent of the disease. And you can see how I'm going step by step. So this is what we call as a Vienna applicator. Now, what has happened is that in the market, these sharp needles and manufacturers have gone out of vogue. And right now, a new generation of applicators have been developed, which are called as Venezia applicator. So in a subsequent video, I will also try to show you that applicator. So you can see how I'm using rotating motion to, just remove the spanner. Otherwise, the needle can come out along with that. So once these needles are placed, we pack the vaginal space and then patient is taken for imaging and then brachytherapy planning. The second applicator, which is available in the market, is called as Venezia applicator. And you can see it is no more metal, but has plastic needles. But here you have two planes of needles. One is the parallel, which can go to medial parametrium, and the other is divergent, which can go beyond the ureter and uterine artery and treat poor responders. And there are also additional vaginal caps, which can treat the vaginal extent of disease. So this is the applicator preparation for insertion. I'm trying to assemble it externally for those who want to see how the procedure looks like. So this is a different applicator than what I have shown you of the Vienna applicator, because it fixes in a very different way. And you can already see that if it's not fixed properly, it will split apart. So fixing this requires a particular technique. Also, this applicator is made up of plastic, and if you've not done it well, it can break. It's quite an expensive applicator. So knowing this is very important. You can see how I am fixing the obturators at the level of the applicator. And these are the obturators from which the parametrial and distal parametrial needles will go inside. And I'm putting plastic tubes here to travel inside. So once this is prepared, the next step is to insert it inside the patient. So you can see, like in previous patient, I have already negotiated the cervical canal. And then in next step, what you do is take the half of the ovoid and insert it into the vagina of the patient, and making sure that it rests at the level of cervical os. And you can see that this patient has a uterus that is slightly tilted to one side. And once you put all this applicator in place, it's very important to fix it properly, because if you don't fix it properly, needles don't go into the right space. And if it is rotated, they can land up in mesorectum or in sigmoid region. So you can see how I fix the applicator. And then now I will put the assembly on the right side, the right side of the patient. So this is the right side ovoid that has been put. Here the disease was not extending laterally, so we have not used any particular needles on this side. And once this applicator is inserted, the next step is pushing off these needles, and that requires a bit of skill and simultaneous assessment of the parametrium to decide the direction of pull and push of these needles so that they land in the right place. I use a speculum to visualize where these needles exactly are, and then start pushing them inside the parametrial space. So once this is done, we image the patient, and you can see this is the residual tumor. And with the combination of intracavitary and interstitial, in a vast majority of our patients who are poor responders, we can reach anywhere between 85 to 95 gray, in this particular case 94 gray, with a very favorable bladder, rectum and sigmoid dose. And I was specifically requested by the organizers to also show how these applicators are removed, because there is of course a risk of abrasion and bleeding. So I have just added one of the video of the metal applicator. So as a first step, we remove whatever gauze and packing that we have put in the vagina. We dismantle the applicator, first removing the central tandem. This is for the Vienna applicator, not for the Venezia applicator. So once I have made the applicator loose, the first thing that we remove for Vienna applicator is the uterine sound, or the uterine tandem as we call. And you can see that I'm very gently removing it, because patient is awake, patient is not anesthetized. I have given patient just an injectable tramadol and also Trenexa just to control bleeding. And once the tandem is removed, I hold the rest of the applicator with one hand. One of the finger goes ahead of the applicator so that needles don't touch the vagina when I'm removing the applicator, because that can cause abrasion. And needles are at an angle to the vagina, so direction of pull has to be tilted. You can see how my hand is moving. So it is towards upside so that needles don't touch the vagina, and we've removed the applicator, and you can see that there is only minimal bleeding in this entire process. And once I remove the applicator, generally it's a habit to do a pervaginal examination to rule out any abrasion or tear.
Dr. Supriya, could you please conclude? We are running short on time.
Yeah, so this is my last slide where you end up packing the patient, and that is the end of the removal of the applicator. And the packing has to be tight, and later on this pack can be removed in 3 to 4 hours. Foley is removed and patient can go home. Thank you very much.
Thank you, Dr. Supriya. For paucity of time, we won't be taking any questions. And now we come to the end of this.
End of the session.
So we come to the end of this excellent session. We have had top class videos, and I thank all the presenters, Dr. T.S. Rao, Dr. Rohit Ranade, and Dr. Supriya Chopra. And also it's my pleasant duty to thank the chairpersons, Dr. Sabita Gupta and Dr. Harshad Parasnis. Now I hand over to Dr. Kanika Batra Modi to conduct the next session, which is on poster presentations. Over to Dr. Kanika.
Thank you, Dr. Sharan. So we had a great response to our abstract series, and we received 75 abstracts in all. So that was a huge lot of work for our judges to do. And of these, we had 2 categories, the case series and the original research work. So there were 31 in the case series and report category and 39 in the original research work. And of the 39 in the original research, there were 28 from surgical part, the gynec oncology, and 11 from the radiation. So buck up all the medoncs, no research by you. And let me introduce our stellar judges for the session who have done a great job, an immense job of marking out all these abstracts on various, quantums that we had for them. First one, Dr. Geetu Badoria. He's an associate professor at Command Hospital, Kolkata. And Dr. Kapil Suri, he's a radiation oncologist at BMMC New Delhi. Dr. Amit Agarwal, who is a medical oncologist at Fortis Shalimar Bagh. Dr. Seema Singhal, who's an associate professor at AIIMS New Delhi. And Dr. Dipanjan Panda, who is a medical oncologist at Apollo Hospital. And Dr. Indu Bansal, who is a senior radiation oncologist at Narayana Hospital, Gurugram. So our original research work prizes are, the first prize is 25,000, second prize 20,000, and third prize 15,000. So for the original research work, the first prize goes to Dr. Garima. Dr. Garima, are you here? Can you unmute Garima?
Good evening. Thank you for this.
Garima, are you here?
Yeah, ma'am.
Okay. So in the meantime, we can go on to the next winner.
I am here, ma'am.
Winner for the original research.
Dr. Kanika, Garima is there.
Dr. Garima is here,
Oh,
ma'am.
I can see Garima also. Garima, can you unmute and present your work?
Yes, ma'am. Yes, ma'am.
You're not audible, dear. You'll have to unmute yourself at the bottom left. There is a mute button that is perhaps pushed on.
Audible, ma'am.
Your volume is low. You need to increase your volume.
Just a minute, ma'am.
Yeah, Garima, can you start your screen share? Yeah, you're audible.
You're audible, ma'am?
Yeah, can you
Yeah.
start your screen share?
Thanks a lot, ma'am.
And in case it's taking you time, you can just start speaking by the time your screen is getting shared. Like, just tell us about your abstract.
Very good evening to all of you. Myself, Dr. Garima. First of all, I would like to thank the organizing committee of Maxcon for giving me this opportunity to present our study. So my study is result of intravaginal candidate for image-guided volumetric brachytherapy in carcinoma cervix. This study is conducted under Dr. Shashoban Banerjee, Mr. Venkatesh, and Dr. Tejendra Kataria in Department of Radiation Oncology.
Garima, your screen is not visible, dear. Yeah, thanks.
Ma'am, is it visible?
Yes, Garima, it is. Please go ahead.
Okay. So the aim of this study is to report our experience regarding the development of a novel low-cost hybrid template applicator and its clinical implementation. The objective of the local regional control, acute and acute toxicity. The study was conducted between April 2019 to 2021. After IRB approval, 12 patients were included in this study. EVRT was given. Post-EVRT, MRI is taken. A standard brachytherapy protocol was done. A novel Medanta applicator, Medanta anterior oblique and lateral oblique indigenously designed template for the volumetric brachytherapy after multiple iteration has 19 needles with central tandem and dosimetrically with different range of high-risk clinical target volume. The details of applicator and its validation have been published in national and international platforms. So there is a brief introduction of the applicator. This applicator was developed with the aim of pushing more dose to the lateral parametrium distribution in the center. So here this is a Teflon applicator with a needle. This is an assembled applicator showing the anterior oblique, lateral oblique, and lateral and the central tandem. Series with 2 mm slice thickness were acquired for all patients. The images were transferred to on-center brachytherapy system. So this is how the CTV was drawn on pre-EVRT finding, post-EVRT MRI finding, and clinical examination under general anesthesia. Catheter construction was done, optimization, manual optimization was done, but in some cases we did the graphical optimization for Medanta applicator. Now come to the result. 12 patients of advanced carcinoma cervix, ego stage 2B, 3C were enrolled. Mean age was 61 years, range is 46 to 71. SGR of 24 to 28 gray, info fraction was
Thank you, Garima. So we'll move on to the next presenter, which is Sahana Punyashetty. She has won the second prize in the original research work category. Sahana, are you here?
Yes, ma'am. Good evening, everyone.
Congratulations, and please go ahead with your presentation.
I'm not unable to share, ma'am. Somebody else is sharing.
Avinash, can you give the rights to Sahana?
Yes, ma'am, it's already given.
Sahana, it's with you.
Oh, yeah. Can you see, ma'am?
Yes, please go ahead. Put it full screen.
Yeah, good evening, everyone, and thank you. I'm Dr. Sahana Punyashetty, MCH Registrar, CMC Vellore. I'll be presenting an audit on management of advanced ovarian cancers as per ESCO 2020 updated guidelines. The aim of this study was to assess the compliance of the Department of Gynecological Oncology in management of advanced ovarian cancer as per the ESCO updated 2020 guidelines. This is a retrospective audit where electronic hospital records of 106 patients with advanced ovarian cancer between January 1, 2019 to 31st December 2019 from an ESCO accredited center were identified. We identified a total of 194 patients, out of which 106 patients were advanced ovarian cancers and 106 underwent surgery. The ESCO indicators my slides are not moving, ma'am.
It's okay. Keep presenting. Are they moving for you?
No, not yet.
Okay.
So
just click on it. Yeah.
There are a total of 10 indicators. Each indicator has a score, a total score of 40, with 32 is taken as a cutoff. The first three indicators indicate about the caseload of the institution. The middle three indicators, they tell about the overall management of the patient. And the last indicators tell the transparency of flow of information within the system. The first quality indicators, it describes complete resection rate, which we could achieve in 49%, and primary cytoreduction in 37%. A total of 90 cytoreductive surgeries were performed in a year, and more than 95% of the surgeries were under supervision. Third indicator, almost 100% of the surgeries were performed by a trained gynecological oncologist or a surgeon. We actively accrete our patients to clinical trials, hence quality 4 indicator was also achieved. There is 95% of our cases are discussed in multidisciplinary team meeting, and more than 95% of our patients have adequate preoperative workup. We have an established ICU care unit, and however, an active perioperative management ERAS needs to be established. The 8th indicator, which describes the operative minimum elements required, the operative structure is maintained in more than 95% of our patients. Pathological reporting was achieved only in 64% of the cases. Post-operative complication reporting was achieved in almost 100% of the cases. So summating to a total of 10 indicators, we were lacking in the first complete surgical resection rate and also number of cytoreductive surgeries performed per year, and also the minimum element required in pathological requirements. So a total score of 25 on 40 was obtained. So audits lead on to quality assurance programs. There is evidences which support that centralization of care leads to improved oncological outcomes. So audits like these help in self-assessment and improvisation. Thank you.
Thank you so much, Sahana. We move on to our third prize winner, Nidhi.
Good evening, ma'am.
Hi, good evening. Nidhi, can you please share your screen?
Are my slides visible?
Yeah, Nidhi, you're visible, audible, everything. Please start.
Good evening, everyone. Today I'm presenting a study, a prospective randomized study comparing IMRT versus 3D CRT in locally advanced carcinoma cervix. The aim and objectives were to compare both the arms in terms of dosimetry parameters, acute toxicities, and immediate loco-regional outcome. The study was a prospective randomized study conducted between April 2018 to June 2019. 54 patients were selected of stage 1B to 4A carcinoma cervix. The randomization was done computer-based into the two arms. Similar treatment protocol was followed in both the groups. Radical CTRT of 50 gray in 25 fractions with concurrent cisplatin followed by brachytherapy. The inclusion criteria was newly diagnosed carcinomal cervix of stage 1B to 4A of FIGO 2009 staging with normal blood parameters and ECOG performance status of 0 to 2. All the patients underwent immobilization and simulation followed by contouring and planning. Then they were randomized to 3D CRT or IMRT arm. Further plan evaluation was done and the parameters were compared. So 54 patients were randomized into two arms, 3D CRT and IMRT, 27 in each group, and all the patients completed the treatment. And at 3 months, all the patients were available for the follow-up. So the baseline characteristics in both the arms were equally divided in both the groups, and there was no statistical significant difference. In terms of PTB coverage, as we can see over here, there was no statistical significant difference among the two arms. In terms of D99, D95, and homogeneity or conformity index. In terms of the dosimetry parameters to the organ at risk, there was a statistically significant difference for the urinary bladder. As we can see, a low dose was achieved in the IMRT arm as compared to the 3D CRT. However, there was no difference in the rectal parameters or bowel parameters. There was a statistically significant difference in the IMRT arm with low dose in the IMRT arm as compared to 3D CRT. When we compare the acute toxicities, there was no difference in GU and GI in genitourinary and GI toxicity. However, more of anemia and neutropenia was seen in the 3D CRT arm. When we compare the local regional response at the 3 months, there was no statistical significant difference. So in low resource settings, 3D CRT may be a good option, and IMRT can be effectively used to reduce the irradiated volume. However, long follow-up is required to assess survival difference or long-term toxicity. Thank you.
Thank you, Nidhi. And with this, we move on to our case series and reports category. And the first prize goes to Dr. Carwin. Dr. Carwin, can we have
Good evening,
your
ma'am. Yes. Sure. Can you see my screen, ma'am?
Yes.
Good evening to respected judges and the audience. First of all, I extend my heartfelt gratitude towards all my consultants, S.K. Giri sir, Jita Parija ma'am, Bhagilakshmi Nayak ma'am, Manoranjan sir, Janmeja sir, and Ashok sir for making this happen. And myself, Dr. Kabin Nillava, representing Acharya Harihar Postgraduate Institute of Cancer, Cuttack. My e-poster is on unusual types of malignant transformation in ovarian dermoid. Malignant transformation in ovarian dermoid is a rare event occurring in about 1 to 2% of cases. Squamous cell carcinoma is the most common type of malignant transformation. Adenocarcinoma and carcinosarcoma are extremely rare. We present two cases of malignant transformation. One is papillary serous adenocarcinoma, and the second one is carcinosarcoma occurring in a mature cystic teratoma of ovary. My first case is a 14-year-old girl who presented to us with abdominal pain and distension for past 1 month. On examination, she had 20 into 10 centimeter abdominal pelvic mass occupying all the quadrants of the abdomen, which was cystic in consistency and was mobile. All her tumor markers were within normal limit, and contrast-enhanced CT imaging of abdomen and pelvis showed 14 into 14 into 14 centimeter of heterogeneous solid cystic mass with few septations arising from left adnexa. Multiple retroperitoneal lymph nodes were enlarged, and there was no ascites. We proceeded with staging laparotomy, and intra finding included left ovarian mass of size about 15 into 10 centimeter. There was a surgical spillage, and the frozen section analysis of this left ovarian mass showed a malignant germ cell tumor. So we proceeded with infragastric chromatectomy, left pelvic lymph node dissection, paraortic lymph node sampling was done. And the final histopathology and immunohistochemistry confirmed the diagnosis of papillary serous adenocarcinoma arising from a dermoid cyst of left ovary, and she was staged as 1C1. After extensive tumor board discussion, we decided her to give adjuvant chemotherapy of 6 cycles of paclitaxel and carboplatin. She's presently 1 year post chemotherapy on regular follow-up, alive and well. My second case is a 40-year-old para to living to. She came to us with complaints of abdominal distension for past 1 year, abdominal pain for 1 month. On examination, she had ill-defined abdominal pelvic mass of size 20 into 15 centimeter with ascites. In her tumor marker, CA125 was 2281 and LDH was 767 international unit per ml. And on contrast, enhanced CT of abdomen and pelvis showed unilocular cyst of size 27 into 27 into 18 centimeter with fat fluid level and focal nodularity in the wall. And there was also presence of ascites. She underwent staging laparotomy, which showed intra finding of ascites. There was ascites of 2 liters and left ovarian mass of about 30 into 20 centimeter, and the entire peritoneum was studded with tumor deposit. And we proceeded with THPSO intracolic omentectomy, and multiple peritoneal biopsy were taken, though we couldn't achieve, though we were not able to achieve optimal cytoreduction. On post-op day 15, patient succumbed to disease, sepsis-induced multi-organ dysfunction. The final histopathology report showed carcinosarcoma arising from dermoid, which was again confirmed by immunohistochemistry. To conclude, optimal cytoreductive surgery and early stage at diagnosis are considered to be good prognostic factors. Fertility sparing surgery is considered to be safe for early stage disease in reproductive age group. Elderly age carcinosarcoma histology, tumor rupture preoperatively, and advanced stage are considered to be poor prognostic factors. And adjuvant treatment are tailored according to the malignant histology present in the dermoid. Given the aggressive nature of the disease, early detection and correct diagnosis using imaging, frozen section analysis, as well as choosing multimodal treatment approach according to the malignant histology present is of utmost clinical importance. Thank you so much.
Thank you so much, Dr. Carwin. So our the second prize winner for the case series report category is Dr. Vashaspati.
Yes, ma'am. Good evening, ma'am.
Hi, good evening.
Good evening, ma'am. A very good evening, everyone. First of all, I would like to thank my mentor Madhu Prastogi sir, Ajit Gandhi sir, and Smriti ma'am. I'm presenting the case of a rare case of papillary squamous transitional cell carcinoma of cervix. These tumors are rare in cervical lesion and very difficult to differentiate from other papillary lesions of cervix because of its exophytic nature. It has got high probability of late metastasis and local recurrence. Currently, there are no specific treatment guidelines for this tumor. This is a case of 45 years old lady without any medical comorbidities presented with the chief complaint of irregular menstrual cycle for 8 months associated with lower abdominal pain and significant weight loss. On examination, there was no abnormality detected on USG pelvis, which showed left ovarian cyst, and CA 125 was 60 unit per milliliter. MRI pelvis showed 2.1 by 1.5 by 2.8 centimeter cervix lesion involving the lower uterine segment. Then she underwent radical hysterectomy with bilateral salpingo-oophorectomy. The post-operative histopath was suggestive of infiltrating papillary squamous transitional cell carcinoma of cervix with tumor size 3 by 2.5 centimeter involving the endocervical canal with lymphovascular invasion, and cervical stromal invasion was more than 1/3. There was no lymph node involvement. Multiple follicle cysts noted in both ovaries and margins were negative. Then patient was referred to our department. She received external beam radiotherapy to whole pelvis with a dose of 50 gray in 25 fraction by IMRT technique, followed by two sessions of intravaginal brachytherapy 8 gray per fraction. There was no significant acute and late toxicity seen. Patient was kept on follow-up and she was asymptomatic, and on clinical examination she showed clinical response. PET CT done at 1 year of follow-up suggestive of complete metabolic response. So from this case we can conclude that papillary squamous transitional cell carcinoma in the cervix is a rare presentation, and it has got higher propensity of local recurrence and distant metastasis. Multimodality treatment may yield good local control and distant metastasis-free survival, as in our case. Thank you, ma'am.
Thank you. Thank you so much, Dr. Vashaspati. And our third winner of the case series and report category is Dr. Mohan Priya. Mohana Priya.
Share screen.
Oh yes, another point. It's quite a female-dominated winners group.
Can you hear me, ma'am?
Yes, yes.
Good evening, everybody. I'm Dr. Mohana Priya, bringing warm greetings from Manipal Comprehensive Cancer Center, Bengaluru. I'm presenting a case of bilateral high-grade serous ovarian cancer in a Mayer-Rokitansky-Kushner-Husser syndrome. MRKH syndrome is quite rare with an incidence of 1 in 4,500 women. They have absent Mullerian structures. However, the ovaries are generally normal in them. In other differential diagnosis of primary amenorrhea like Swyer syndrome and AS syndrome, we generally remove the gonads because of the increased incidence of gonadal tumors. However, in MRKH, we retain the ovaries are normal and we retain them. Our patient is a 47-year-old married nullipara who presented to us with abdominal distension. She never had her menses. On evaluation, she had a CA 125 of 1251 and imaging showed bilateral complex adnexal mass with ascites with omental thickening. And uterus was absent for her. We did a diagnostic laparoscopy for her, followed by optimal cytoreduction. We did total omentectomy, total peritonectomy, bilateral diaphragmatic peritoneal stripping. We removed bilateral adnexal masses, and intra-op we found 2 rudimentary structures, 2 rudimentary uterus and 2 fallopian tubes. Pelvic and paraortic lymph node dissection was done for her. The final histopathology came as high-grade serous ovarian cancer in both the ovaries, and the uterus did not have an endometrial cavity, showed fibroid. Why we are presenting this case is the intraoperative challenges because of the varied anatomy which we faced. Till then, this patient did not know she had a uterus, but intraop we found 2 small rudimentary uterus. She had a fallopian tube. We started the peritonectomy extraperitoneally. So initially we came across the round ligament, which had a different origin. Then we had the ureters, which was very, very close. We had a problem in dissecting the vesicovaginal and rectovaginal places, rectovaginal planes, and ureters were very close to the vault. Just for that reason, we are presenting the case. And following cytoreductive surgery, she underwent 6 cycles of adjuvant chemotherapy. She was BRCA2 positive, and presently she is on olaparib and she is doing fine. We know that gynae malignancy is rare in MRKH syndrome. However, because the ovaries are there, ovarian cancer is a possibility. And when we attempt a surgery, we have to be aware of the anatomical changes. That is the aim of our presentation. Thank you very much. Regards from Bangalore, Manipal Comprehensive Cancer Center. Thank you, ma'am.
Thank you so much, Dr. Mohana. And with that, we come to the end of this abstract session of this series. And we would like from the entire organizing team to thank our judges for having taken out the time to really, it was quite an immense task to put a mark to all 75 of them. Thank you so much again. And with this, we move on to our last session, which is a very special session, the showstoppers. And I would like to invite Dr. Manas to take over now.
Very good, Bala.
Thanks, Dr. Kanika. I welcome you all for the next session. This one is really special. It is truly for our warriors, and it's by the warriors. We as doctors and caregivers forget sometimes what's in the mind of the cancer patients. Many of them, however, have a positive attitude and are great motivators. In this session, we are keen to hear of their life's experiences. May I call upon Ms. Mona Chaudhary to conduct this session, the showstoppers. Ms. Mona Chaudhary lives in New Delhi, works for United Nations Department of Safety and Security. She's 55, single, and lives by herself with her house help and her pet. Diagnosed with ovarian cancer in August 2016, stage 1A, detected during routine checkup. She is a volunteer at the Max Lajpat Nagar Cancer Institute since 2017. She's really closely associated with MICC, and she's also passionate about cooking and trying out different cuisines. Ms. Mona Chaudhary, please take over the session.
Thank you so much, Dr. Manas. Very honored to be here. And I am trying to start my video. Has my video started? Because it's not coming on. Okay, now I'm starting it. The video still hasn't started, so maybe I'll just keep talking.
Mona, you're not audible.
I have been talking.
Okay, yeah.
Yeah, already. My video hasn't started because I think the link to the video needs to be started.
Yes, you may continue, Mona.
Okay, so we have some very special guests with us this evening, and let us start by introducing to the group our first guest, Ms. Rita Bhalla. She is a cancer survivor and currently the director of Cancer Sahyog, a part of Indian Cancer Society. She also set up Prerna in 2002, which is an emotional support group for cancer patients at the Army Hospital Research and Referral. She is also the founder secretary and later the chairperson of Prerna. She was awarded the AWA Award for Excellence in 2006. Ms. Bhalla is currently the president, she was the president of Jagriti, part of the Indian Cancer Society for 3 years in 2013. She is the organizer for awareness talks, training of new volunteers and interns, radio talks, and train the trainer programs. She manages volunteers, interacts with doctors, and updates knowledge base of volunteers. She also organizes various annual events of Sahyog. She's also associated with the Shakti and e-learning programs. So over to you, Ms. Bhalla, and a very warm welcome again. Thank you.
Thank you, Mona. Good evening, everyone. So I'll take you today with my journey through cancer. Life was beautiful. My husband was posted in Delhi and we had a beautiful home. Kids were growing up well when life suddenly took a U-turn. In 2001, I had this sudden vaginal bleeding, and because I had had a hysterectomy earlier, I was really concerned. So I immediately rushed to Army Hospital R&R. In retrospect, I feel that that was the best move, as early detection is key to a successful cure. Anything that's not normal should be shown to the doctor without any delay. After numerous tests, I was told that I had vaginal walled sarcoma, a wound-related cancer, which is quite rare. It was bad news, as like most people, I felt I may not survive. My son was in the all-important class 12, and my daughter was just in class 6. A lot of uncertainty set in, and it made me very nervous and unsure. Doctors were good, not only professionally, they were more like psychiatrists. They explained to me that one needs to face and deal with problems and not brush them under the carpet. The earlier we start the treatment, the better would be the outcome. After they had explained me all the modalities, there was no looking back. I knew exactly what to expect and I faced it with courage. So I feel it's very important that the patient knows about his problem and what to expect during the treatment. He can then develop the strength to cope up. The complete treatment took around 7 to 8 months. I took 1 day at a time. I had 2 rounds of aggressive chemotherapy of 5 days each with a 21-day gap. It came with its usual side effects. I lost all my hair and it was very, very traumatizing. My children pampered and humored me no end. I wore a scarf and even attended an all-important function. People mistook me to be from Iran. I got ulcers in the mouth. There was a loss of appetite, a lot of nausea. My mom took great care of me. She took great care of hygiene. She made food which had no mirch masala, only namak and haldi. After a couple of days, I loved that food. And believe me, food has never tasted better. So till date, I advise the patients not to have pickles and spices to make the food tasty. It's a vicious cycle, as these irritate the ulcers in the mouth and then they can't eat at all. As my immunity was low, my husband ensured that we had no visitors. We asked all our relatives and friends to pray from me and send me good vibes from their home. It's important that people around you know that what your condition is and what are the precautions that you need to take. Then only they can be your support system. I asked my doctor, is it worth undergoing the massive surgery? Will I even survive? The doctor said, you will live to see not only your grandchildren, but also your great-grandchildren. Of course, I know life is in God's hand, but this statement made me even more positive and so happy. The anesthesiast was like a God-sent angel. He assured me that he would take great care of me and that I would do just fine. This relaxed me completely before I lost consciousness. My surgery was successful and the doctors declared me cancer-free. I was discharged, but returned to the hospital with mild fever after 10 days. The fever kept coming back each day. And this caused a lot of frustration because I was mentally prepared for the next step of treatment. That was the radiation. So I advised the patients to add a couple of months to the estimated time that the doctor gives them. That way, if they finish their treatment on time, they are happy. And if, God forbid, there is some problem and the treatment prolongs, then they don't feel frustrated. After nearly a month of fever still lingering on, I took an outpass and I went home. I made my children's favorite dish and went back to the hospital. And believe me, the fever never came back. I then had my 30 rounds of radiotherapy and 2 internal ones. I feel I could complete my treatment because of my strong willpower and a positive attitude. All through my treatment, I didn't do anything that my body didn't permit. I didn't eat unhealthy. In fact, I avoided food which I did not feel like eating. I followed the doctor's orders to the T, didn't meet people who were negative, didn't let any negativity affect me. I prayed a lot, counted my blessings and thought positive. I prayed for others too and silently blessed everyone I came across. And these blessings came back to me many folds. I believe the whole universe wants to help you, to heal you. Your family, friends, near and dear ones want you to get well soon. So does the universe. That's why God has made these lovely fruits and vegetables with all the good nutritions. Nature heals you because it's so soothing. The birds, animals, trees, flowers, sun, moon, stars. I used to just sit out and ask all of them to heal me. Whenever I took any medicine or food, I prayed that it should benefit me. I prayed to God to give me life so that I could look after my children, fulfill my duties, and enjoy this beautiful life. God listens to prayers. With God's grace, both my children have now grown up and are bankers. My husband retired as a general from the army, and I could fulfill all my social commitments. Happily saw my son marry a beautiful girl. I value each day of my life. But I found my true calling after my illness, meeting patients at the request of doctors and telling them to be positive, telling them to have faith in the doctor and medical science, further strengthened my inner belief. I love being with people, helping them, holding their hand, and just being there for them. This is how Prerna started. An emotional support group at Army Hospital R&R was set up by a couple of survivors, including me. And with the help of the doctors from R&R and the Indian Cancer Society in the year 2002. As a founder member, secretary, and later the chairperson, I made out handouts with do's and don'ts during chemotherapy and radiotherapy, held orientation programs for new volunteers, held awareness programs for families and troops. We celebrated all the festivals in the hospital. We had weekly tambola. We set up a fun activity room, a playroom, a library, a kitchenette for patients. In short, we tried to keep the patients, who were mainly soldiers, in good cheer as they were so far away from home. When I was President Jagriti, Indian Cancer Society, I was involved in awareness talks at schools, colleges, institutes, corporates, bastis. I strongly believe it's important to remove the myths around cancer, inform people about the signs and symptoms and importance of screening and early detection. We also held a number of train the trainer programs, radio talks, initiated new volunteers, and had intern programs, organized a number of talks and workshops. At present, I am Director Cancer Sahyog. It is the emotional support group of Indian Cancer Society, Delhi. Okay. We feel that no one should be left alone to fight cancer. We visit 15 hospitals and talk to the patients there. We give financial aid to those in need, and we also give bras and prostheses to the mastectomy patients. I feel very passionately about my volunteer work, and I feel it's very important and immensely satisfying to give back to society. I truly believe cure is in the hands of God, but care is surely in the hands of man. In the end, I would like to say that life is not only beautiful, it is very precious. Life is a gift from God. Enjoy each moment, respect, love, and take care of your body. Each one of us is responsible for our own health. Cancer is a lifestyle disease. You need to inculcate good habits and make healthy lifestyle choices, as many people are dependent on you. They love you and they want you in their lives. We all need to work together to make cancer just a zodiac sign. Thank you so much.
Oh, God.
Thank you so much, Ms. Bhalla. It was wonderful to hear you and very inspiring. With this, may I welcome our guest, very well-known Indian actor, social activist, a super talented and multifaceted Nafisa Ali. Good evening, ma'am, and welcome to the show.
Hi.
This is Mona here. The camera, I don't know, something has happened to it, but we'll continue. If I may just carry on with introducing you, there is so much to say about you. You are a celebrated actor. Who can forget you in Junoon? Politician, social activist. You've also been Miss India. You've been the second runner-up at the Miss International competition. Several times national swimming champion and a jockey. The list goes on and on, Miss Ali, and what an incredible journey. But today we are meeting Nafisa Ali, a cancer warrior who was diagnosed with the third stage peritoneal cancer in November 2018. And ma'am, while you have been an athlete and a very fit person all your life, what was the first thought that came to your mind when you were diagnosed with cancer? And how do you feel today, almost 3 years later?
Well, I think that firstly, I was misdiagnosed by the doctors who I went to, because I think the doctors felt that I could never get cancer. So they said that, I had a stomach infection and blah, 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 and take some antibiotics and take deworming and take all these things. And so I think I did what the doctor said. They did an ultrasound also. They said everything was fine. And then I was getting a lot of pain in my abdomen. And I said that it doesn't feel normal. So that is why I went to the doctor. And then they said, go and do ultrasound. And then they said, no, everything's fine. And then after I came to Goa and I was busy gardening and swimming. And I found that I was getting very tired. And I normally never get tired. So after 2 months, I went back to Delhi and I went back to my doctor. Can you hear me?
Yes.
You can hear me?
Yes, ma'am. Yes, ma'am.
Yes, we can.
You can.
I went back to the doctor and I said, look, I know you said that but my radiologist was Dr. Mathur. So Dr. Mathur, who saw my old scan, he says the only thing I noticed is that your omentum, which is of course, all these words I never knew existed. The omentum is, you have a lot of fat in your, the omentum is very thick. So it may be why you are getting pain, because it's pressing on the organs and etc. etc. So when I came back from Goa after 2 months, I went back to Dr. Mathur and I said, Dr. Mathur, I'm sorry, I don't feel well. And I'm not a doctor, but I can only tell you that I don't feel well. And he says, okay, I'll send you to another doctor. And of course, I became very emotional and I cried to Dr. Mathur. So poor Dr. Mathur, who used to be with Max, he says, no, don't worry. And he sent me to another hospital. And there the doctor said, no, I feel you should have a dye-injected CT scan. But then I started getting fever and the pain, which was in one area, had gone to many, many areas. And then after that, I went back to my original doctor and I said, look, I'm giving you a chance to redeem yourself. There is something wrong with me. So then he did another ultrasound in that hospital. And it had metastasized because it had gone to stage 3 because of the delay to stage, and the whole abdomen was full of liquid. And he says you need urgent care. So then I went to the Max Hospital, Dr. Julka, who was my all-time old friend. And Dr. Julka then put me in touch with Dr. Harit Chaturvedi and Dr. Rotagi. And they were trying to die. They said, maybe you have TB. So then we all had a bet in the Max hospital. Doctor, I said, look, whatever it is, if it's TB, I'm happy, but I feel it's something more serious. But you are the doctors, you tell me. So they did an FNAC, they pulled out some liquid from me, then they put it in, I don't know, whatever machine. And there they found some carcinoma cells. And so they did, okay, then they said, okay, do a PET scan. So I went to do a PET scan. And then I walked into the room and all the doctors were sitting on the monitor and I saw all their faces. And I said, okay, I can see that you're all distressed. So I'm sure that it's cancer. They said, yes. I said, so I've won the bet, pay me my 5 rupees. They said, no, we can't pay you 5 rupees because you're feeling very bad. I said, I don't care. A bet is a bet, you have to pay. So I treated my cancer as a big joke. And then I went to Dr. Harith and I told Dr. Harith, I said, these are the places I have pain, so please check me out. And then he did a, what is it called?
Laparoscopy.
What is it called?
Laparoscopy.
Laparoscopy. Of course, Dr. Harith's camera was not working, so only Dr. Harith got to see what was inside me. But the fact is, then they saw that everywhere I had said that I had pain, the cancer had spread everywhere inside my peritoneal cavity, and one pouch of Douglas and appendix and cervix and fallopian tube and I don't know what all and nodes and whatever. And so I told Dr. Harith, I said, look, now when you do my surgery, because they had done the laparoscopy, I was advised that since the peritoneal was a primary source, it should be, chemo should be started first, which is, I think, very important because cancer spreads everywhere. Like a little crab, it goes and attaches to other parts of your body. So then I did my, I think it was 3 doses of chemo. Then then Dr. Harith did my surgery and I told Dr. Harith, Dr. Harith, I don't want to know pain. I don't want to feel pain. I don't want to know anything that you're doing to me because it's an invasion of my body and my self-respect. So whatever you want to do to me, you make sure you do it to me after I'm under anesthesia. And he kept his promise. And of course, I went through a huge surgery. And when I came out, I felt no pain. And Dr. Harith came and told me that the more you walk, the faster you recover. So from the moment I could get off, my anesthesia wore out, I started walking about in the ICU immediately. And that's it. I remember the chemo when it was started, which no doctor ever tells you, or nobody ever tells you. On the 12th day, exactly after the first chemo, my hair started falling. That's the time I actually cried a bit because I realized that I actually did have cancer. And then I treated it like a joke. And I said, what is this cancer? How dare it come into my body? And I told my body, get rid of this silly disease that has now tried to overtake me because it's not going to get the better of me. And the doctors of Dr. Harith, Dr. Rotagi, Dr. Julka were just adorable and gave me full inspiration and made me a fighter that I always was. And I think it's because of my athletic activities that I think my muscle memory is strong, my mental and emotional strength is there. And also I had a lot of, supplements. For example, I did a lot of research all over the world. People are using hemp oil to cure cancer. And I used that also along with all my other treatment that I was having. And a miracle happened in my life. Whatever it happened, it was a miracle because peritoneal cancer is a very aggressive form of cancer. And Well, here I am today. And I have my checkups once a year. And I'm in Goa. I'm in Goa. I'm busy. I'm happy. And earlier, I used to take, if something used to go wrong, I used to become really upset by it. Now I've let things go. And I'm sad. My time is perhaps limited or it's long on earth. So whatever I do, let me enjoy myself. So now I'm taking life as a breeze.
That's so wonderful to hear. And we do share our doctor. Dr. Julka has also been my doctor. You have mentioned in several interviews that your family was a great support, and you just left it to them. You didn't worry much about what
I'm the last person to take medication.
Yes.
And I'm the worst patient, in fact, and never listen to doctors. So I saw the doctors to Hello?
Hello,
Yes.
yeah,
Hello.
I can hear you.
There's a power cut. There's a power cut in Goa
Okay,
right
we
now.
can hear you. So, ma'am, if I may ask.
So basically, I left it to my family because whatever they gave me, I used to have it like a good. I would not even think about it. I would take water and just drink it up. That's all I do. And of course, I was fed up of food, and so my best friend, her name is Gabby. She used to make me continental food, and my children were all we were like they all came to me to have my chemo. They all came to me to have my FNAC, and it was like a big party. I treated it like a big party, and I must say the Max Hospital were amazing because when I was in the ICU, I remember I said, I cannot take light, I cannot sleep. So all the nurses were so sweet. They stuck newspaper in my cabin so the light would not be bright. So things like that, which I really remember because they were too sweet. Three nurses had to carry me, walk with me so I don't fall down.
Ma'am, if I may ask you, is there any specific advice you would have for women undergoing these gynae cancers? Because it's quite
It was
unique.
not a gynae cancer. Mine was, I don't know what. Mine was a peritoneal. Is that peritoneal cancer? Is a gynae cancer? I mean, it spread everywhere after that.
Peritoneal cancer behaves like ovarian only. So it very much
behaves like ovarian. Okay.
So for all practical purposes, it is like ovarian cyst. But yes, yours was primary peritoneal. That's
So
right.
is there any specific advice, ma'am, you would have for women, especially who are fighting cancers,
No,
because
I would have advice for doctors.
Yeah.
The doctors misdiagnosed me, and I would advise doctors today when there are CA 125 and whatever else CAs are there.
CA 125.
No, and there are many other cancer markers also. I asked, this is what I asked the doctor the first, because they did my CA 125, my readings were like 650 or something. And I asked the doctor, I said, if there is such a test, why don't you do it then? No, you could get false reading. I said, forget about the false reading. You have all put my life at risk. And therefore, today on the Max chat, all doctors, I say that when we have markers without doing any invasion, what is it called? Invasive anything. First, do these marker tests, because when as a person, I'm telling the doctor something is wrong with me, and the doctor is telling me, no, there's nothing wrong with you. You have to hear the patient, no?
Correct.
And I'm the last person to go to a doctor, and the last.
Okay.
I think we can't hear you, ma'am.
So, Manoj, if I can make a comment.
Yes. Yes, Dr. Chaturvedi.
Yeah, so I wanted to say that it's a big challenge to diagnose ovarian cancer early, and it's a global challenge.
True.
What Nafisa's saying is absolutely spot on, that she needs and there needs to be doctors to be more alert about this. if there's a suspicion of ovarian cancer, threshold should be very high. So she's absolutely spot on, and I fully respect that sentiment. But just batting a bit for the practitioners, what happens? The index of suspicion for this is slightly, it should go up, awareness should go up. And I think gradually things are changing, but it's a global challenge, not an Indian challenge, not anywhere. It's a global challenge.
It is difficult
Point
because
I want to make, Mona, that he did not tell you that she was always full of energy. See, even on the operation table, she took a selfie and then posted on Twitter before she got under the knife. So she had amazing willpower and enthusiasm even at the time of diagnosis and everything. So I think that sets her apart. And I think most of our patients are very energetic and positive. Yeah.
Can you
Yes,
hear me? Hello.
are you back?
I'm
Yes,
back.
ma'am.
I'm back.
Okay, ma'am. Thank you. Thank you. It was wonderful to have you here. And, you know, your words have been most inspiring. Just one last thing. What would you want to tell? Any special message for families and caregivers? Because sometimes, you know, they get lost in a treatment. And,
You know, the amazing thing in my life after my cancer is that people from all over the world have reached out to me. Even there were, and for advice, opinions, help. What's the alternative therapy? What did you take? And I say with all humility, doctors cannot say it, but I say it, that please research hemp oil in cancer treatment. In India, we need to make it legalized. There is something called CBD oil and there's something called TLC. I was in a lot of pain. And when I started this with chemo and with all that, my pain went away. And I think it just made my body feel so relaxed that the cancer went to sleep.
great. So I think that's something doctors
have to fight for.
I
Fight
agree.
for with the government
I
of
agree.
India to make it legal.
I agree.
Because
Thank you
the
so
world
much.
is recognizing hemp oil as a treatment and
We are all
a
on the same
support.
side. Nafisa, we are all on the same side. We are not on the opposite side.
Absolutely,
We are
ma'am.
with you.
No, but I'm only a patient if the doctor has to fight for it.
Sure.
Absolutely, ma'am. Thank you so much. It was it was very, very inspiring and motivating to hear you. There are so many of us out there who are survivors and, you know, battling on and leading very normal lives today. So thank you so much, ma'am, for your time. And it really was a pleasure. Thank you again. May I now introduce our third guest, Miss Poonam Kamdar. She is a counseling psychologist trained from NCRT Delhi with more than 25 years of experience in school setups. Ms. Kamdar is also a parenting coach, a certified trainer for skills for adolescents programs. She is a consultant with the Times of India NIE. She is also has been an ex-panelist for talk shows at the All India Radio and a very proud member of the Delhi Laughter Club. So a very warm welcome to you, Ms. Kamdar, and over to you. Thank you.
Much, Mona, for such a wonderful introduction. Yes, I'm a cervical cancer survivor. In fact, I will not use the word survivor. I'm a winner and a champion. That is what I perceive myself as today. This journey from cancer to cancer free, it lasted for almost 6 months, and it began in the year 2015. I was diagnosed with stage 2 in 2015, was operated in January, underwent series of radiation, chemotherapy, brachytherapy, and by June 6, I was all free from all these things. But yes, follow-ups were there later as well. I would like to share here ki before the diagnosis, like what happened, like my body was giving me signals. अपने आप बोलती थी, आवाजें आती थी, like, and I think I failed to listen to it. In fact, I ignored it totally. I used to feel very tired, irregular flows, extreme pain in the pelvic region, then irritation, बहुत ज़्यादा irritation छोटी-छोटी बात पे होने लगा था, muscle cramps आते थे, but I did not pay any attention to it. And later I was diagnosed with cervical cancer. Now, again, if I say that, you know, I realized when the test came out with the rest of the things also, my high blood pressure, then high levels of sugar, hyperthyroidism. Then apart from that, cholesterol. Then on top of it, कहते हैं ना सोने पे सुहागा, obesity. It was like for the doctors, I'm sure it was a great challenge. सारे lifestyle diseases साथ साथ आए हुए थे. So when I went in for the treatment and all, frankly speaking, जब news आई कि news क्या मतलब information आई कि like I'm suffering from cancer. So I was not at all in the denial mode. Somehow like लग रहा था ठीक है तो है, हो जाएगा, इसका ट्रीटमेंट हो जाएगा, बल्कि थोड़ा लग रहा था कि ट्रीटमेंट हो जाएगा तो आई फील बेटर. देन नीदर वाज, मेरे को ऐसी फीलिंग भी नहीं आई, बिल्कुल कभी भी नहीं आई कि बाय मी. आई नेवर थॉट अबाउट दैट. मैंने कहा नहीं, फाइन, it's timely diagnosis maybe, and I'll get rid of it. I'll feel more, I feel comfortable about the whole thing. But then once I was operated upon, after the surgery was over, uske baad, उस समय पे I would like to share कि psychologically like how I felt. बहुत ज्यादा, कई बार तो एकदम low, कई बार एकदम high. मतलब high का तो level इतना होता था कि like after getting my chemotherapy being done और radiation भी जब मेरी हुई, उसके बाद मैं आकर के kitchen में चली जाती थी थोड़ी बार fresh होने के बाद, and I used to make dosas for everyone. And सब कहते थे अरे क्या radiation करा के आए हो, तुम क्या करा के आए हो, मतलब कहीं से तुम, you're feeling so energetic. But then after some time I was again थोड़ा sulk होकर के बैठ जाते थे. So I was trying to collect the threads of my life, frankly speaking. टेस्ट बड्स एकदम खत्म हो गए थे उस समय पर, और लगता था कि कोई किचन में कुछ बनाता था ना, लगता है why are people cooking, are they fools, are they mad or what. और बल्कि एक बार तो मन में ऐसी फीलिंग आई कि क्यों नहीं मैं किचन में ताला लगा देती हूँ, ये लोग किचन में बनाना ही बंद कर देंगे. एंड अपार्ट फ्रॉम दैट थिंग, जब साथ में आवाजें बिल्कुल अच्छी नहीं लगती थी, लाइक people मतलब इंफॉर्मेशन एक तरीके से सबको बोलती थी कि she doesn't like to meet anyone right now, don't come. But फिर भी कभी आ गए तो आवाजें लगता था क्या बात कर रहे हैं, क्यों कर रहे हैं. I mean, I just wanted to be at 100% peace, without any sound and noise, just to be within myself. अपने आप से connect होना चाहती थी, and I used to get a lot of time for it. Now, one thing what I realized here कि simple जो daily life मेरे जो रोजमर्रा के जो काम है वो एक तरीके से बहुत एक टास्क बनते चले गए. And walking was again a burden for me. But then on the advice of doctors, I walked, चाहे थोड़ी देर मैंने walk किया, बैठ गए, फिर उसके बाद फिर शुरुआत करी. That really helped me a lot. And not only that कि ये टाइम मैंने जो कनेक्ट होने में अपने साथ लगाया, connected with myself via laughter yoga also. मतलब इसमें क्या था, एक बच्चे जैसी जो निश्चल हंसी निकलती थी ना, तो लगता था लाइक पेन्स आर ऑल अवे, बिल्कुल तकलीफ ही कोई नहीं है जिंदगी में. Then I got engaged in lot of good things. मतलब जो मेरे को लगता भी नहीं था कभी मैंने अपने लिए टाइम निकाला इतना ज्यादा इसके लिए. लाइक मैंने अमर चित्र कथाएं पढ़ी, वो पुरानी अपनी कहानी जो होती है ना जो हम पढ़ते थे बचपन में, उनको रिलाइव किया. साथ साथ I bought my favorite movies, बावर्ची, धर्मवीर. I mean, ऐसा लगता था लोग कि लाइक ये तो बड़ा लेजर में आ गई है, बहुत एंजॉय कर रही है. लेकिन yes, life was actually enjoyable at that time. और मजे थे, कुछ भी इंटरनेट से रेसिपीज निकाल के I used to cook, कुछ ट्राई करती थी, थोड़ा बहुत ज्यादा अपने आप को एक्सर्ट कभी नहीं किया. Then I used to write हास्य कविताएं, मैंने कोशिश कर करके उस समय पे सिंपल थॉट्स, वो छोटी छोटी तुकबंदियां होती है ना, बड़े आराम से आती थी, ज्यादा दिमाग वाला काम तो हो नहीं पाता था. But then I used to utilize all these things. Diet, I try to take it as per the dietitians. पूरी मेरी कोशिश रहती थी because I wanted myself to be hale and hearty. और मैं वापस आना चाहती थी अपने पुराने उससे भी, in fact, stronger उसमें एक दूसरे के सामने example बन गए. Somehow that thought within myself, I think, helped me a lot. I never overdid anything. थक जाती थी, छोड़ देती थी, and nor did I ever indulge myself in self pity. अब एक एग्जांपल आपको बताती हूँ कि यहाँ पे डॉक्टर्स के साथ इंटरेक्शन में लाइक जो एप्रीहेंशंस होते हैं, एक एप्रीहेंशन था, मैंने एकदम डॉक्टर से पूछा, डॉक्टर साहब वो जब हम आप कीमोथेरेपी जब हमें देंगे तो क्या उसमें तो सुना है कि सांप का जहर होता है. And you know, every doctor was like, he did not laugh. What reply he gave, like he must be wondering कि कैसा क्वेश्चन है. He said, क्या हम आपको सपेरे लगते हैं? मतलब, and myself and my sister, both of us burst into laughter. हम लोग इतनी जोर से हंसने लगे, लोगों ने सोचा बाहर निकल के कि ये पेशेंट भी है, ये कहाँ से आ गए इस तरह हंसते हुए. Another instance I would like to share over here is कि like एक बार मैं किसी ग्रुप से बात कर रही थी, इनसे जनरल बात करते करते मैंने कहा कि see, I'm a cancer survivor, and promptly the person replied, अरे वाह. I said, हाँ, yes, it is अरे वाह only. And then in another group, again the same thing. When I shared to कहते अरे लगते ही नहीं हो. I thought, हाँ यार, this is something good, so powerful. मेरे doctors ने मुझे इतना अच्छे तरीके से खड़ा कर दिया है कि like I'm not separated or segregated in any way. कहीं से भी नहीं लगता कि इनके अंदर कोई कमी रह गई है. एंड एक बार तो एक कैंसर सर्वाइवर ग्रुप में जब उन्होंने देखा कि मैं इतना डांस कर रही हूँ, हंस रही हूँ, उन्होंने मेरे जल्दी से आके बाल खींच लिए. मैंने कहा हाँ क्या हुआ? तो कहते हैं कि देख रही हूँ असली है कि नकली है. मैंने कहा आ जाएंगे. मेरे वैसे गए नहीं थे, मेरी इतनी स्ट्रांग नहीं थी कीमोथेरेपी, आपके भी आ जाएंगे. कहती है आपसे बात करते तो बड़ा अच्छा लग रहा है. मैंने कहा यस यस, आपको अच्छा लगेगा, थोड़ा ट्रीटमेंट खत्म हो जाएगा ना, यू फील ऑल द मोर गुड. नाउ सिंपली टुडे आई हैव अ वेरी सिंप्लीफाइड वर्जन ऑफ लाइफ. कोई भी क्लटर गैदर नहीं करती, मेंटली भी और घर में भी. आई ट्राई टू गेट रिड ऑफ द थिंग्स एंड ऑल. बहुत है, इतना ज्यादा है जिसकी मुझे लगता नहीं कि अब इकट्ठा करने की कोई जरूरत है. आई लिसन टू द डॉक्टर्स, उनकी एडवाइजर्स, उन्होंने जो कहा, बिकॉज दे आर एक्सपर्ट्स. हमारी हाफ बेट नॉलेज होती है, गूगल करके हम चले जाते हैं. वी ट्रबल द डॉक्टर्स एंड वी ट्रबल आवरसेल्व्स आल्सो. सो प्लीज अवे फ्रॉम दैट. ओपिनियन ले, डेफिनेटली ले, बट क्लटर इकट्ठा ना करें. देन इसके अलावा मैं यस, it has given me new set of friends. बहुत सारे friends मिले, support groups जब मैंने join किया तो I met Sister Shivani. Today I'm blessed to meet Nafisa Ali ji. Then and today I am my own priority. I am my favorite and I have a responsibility toward myself and I love myself because I'm a much better version of myself. अच्छा, before I end मैं ये जरूर आपको सुनाऊंगी. ये मैंने self composed कुछ lines लिखी हैं. That is, निराशा के साए में घिरी, मिलने जुलने से कतराने लगी. रात के अंधेरे क्या, दिन के उजाले में भी डरती थी. मन खेलता था आंख मिचोली, कभी गुस्सा कभी हताशा तो कभी ठिठोली. पर एक दिन जब स्वयं को शीशे में रही थी निहार, अचानक शक्ति का होने लगे संचार. शायद रिसेंटली ज्वाइन ग्रुप का प्रभाव था या फिर फैमिली डॉक्टर्स का मिला जुला साथ था. आई स्टार्टेड इमर्जिंग एज अ न्यू वुमन. व्हाट आई डिड स्टार्टेड डूइंग इज करके वॉक एंड योगा. अच्छे विचार आए और मन शांत होने लगा. डाइट पर जब मैंने दिया ध्यान और वजन को किया अपना कंट्रोल, तो चेहरा भी मेरा सुंदर निखर आया और आंखें भी आगे बन लगने लगी गोल गोल. मन लगाया हॉबीज के साथ, माँ बहन के साथ मन की करी बात. तो यस, टुडे नाउ आई नो इट्स ऑल इन द माइंड. द न्यू यू हैव टू फाइंड. And yes, I'll not stay behind. Shukriya to all my doctors, to my family, my friends, that I am alive. Not now just to live, but to thrive. And I urge all the survivors, those who are listening, कि चलो जिंदगी की करे hello hi और उदासीनता को करे bye bye. क्योंकि ये जिंदगी ना मिलेगी दोबारा, ये जिंदगी ना मिलेगी दोबारा. With gratitude to all the doctors, thank you so much.
That, Ms. Kamdar, was absolutely amazing. Most delightful. Enjoyed the poetry very much. Thank you so much for sharing your awesome journey through the treatment and your life, the way you live it. A lot to learn from it. Thank you once again. And with that, I hand over the floor to Dr. Manas Biswas again. Thank you so much, Doctor.
Thank you. Thank you so much, Ms. Mona, for having conducted this session. And thanks also to our esteemed speakers, Ms. Rita Bhalla, Ms. Nafisa Ali, and Ms. Poonam Kamdar. All very wonderful people. So with this, we come to our last session of the day, and it's a fitting finale. So I'm here to conduct this very nice and important panel. Like we said, this is real special one for our warriors. So I have this panel which is led by Dr. Harit Chaturvedi, our very own chairman, Max Institute of Cancer Care. Welcome, sir. Dr. Gaurav Chandana, he's a senior consultant, pain and palliative medicine of Max Institute of Cancer Care, Delhi. Dr. Surveen Ghuman, she is the director, fertility and IVF, Max Super Speciality Hospital. Ms. Hiba Siddiqui, a very special and senior psycho-oncologist of MICC Delhi. Ms. Pallavi Sharma, she's a physiotherapist at MICC Delhi, and Ms. Kalpana Gupta, Assistant Manager, Department of Clinical and Nutritional and Dietetics of MICC Delhi. So here we are telling you what we feel, what our warriors should know. So my first question is to Dr. Harit. Actually, it's not a really question, but I would say I would like his comments. So, Dr. Harit, once the initial therapy is done, what is the most important advice you give to your women patients and their relatives, especially those with breast and gynae cancer?
Thank you, Manas, for asking me this and also doing such a wonderful program throughout the last 2 days. And I think the answer has been very well given by our previous session survivors and winners of cancer, whether it was Nafisa or Kalpana ji Namdar and Rita and everybody. They talked about so much of positivity and enthusiasm, and with so much of enthusiasm that they have believed that cancer is not going to stop them. And they're entitled to full, normal, enthusiastic, energetic life. So my first advice to my patients and my those who are treated in Max and we engage with them, I would say that you are entitled to full normal life. In fact, life into two, I always say, because before cancer, and I think that came out very well as these survivors were talking, that whatever you were doing before the treatment, before the diagnosis, suddenly everything multiplies. You start valuing time, relationships, and your hobbies, and put yourself in priority. So my first advice is that everything should be normal as usual or better than usual, not before, and you are entitled for everything, whether it's a physical well-being, sexual well-being, spiritual well-being, social living, whatever aspect, everything has to be taken care of. And if something is not getting fixed, then talk to your doctors, talk to the support team, how to get it right. Don't accept a inferior comfort, get it full throttle. And second aspect is that while this is very important, it's equally important to remain in touch with doctors and the treating team so that any problem, any so-called recurrence or any issues which may come up at any point, that should be addressed in time. So follow-up should be maintained and life should come back to normal.
So there is one more, I just cannot help but ask you this, being, being a surgeon and you being the surgical head. So surgically, what do you do? What do you and your surgical team do to preserve body image in female patients?
So this is today, it's the mantra, not just for female, but for every cancer treatment. It's not the radicality which is defining everything, that overdo things. We have to optimally do things. If I give the example of breast cancer, for example, and there we do oncoplasty, breast reconstruction, the body image has to come back to normal self-esteem, and that should help the patient to be bounced back in every aspect of life. If we talk of gynecological cancers, today, sentinel node biopsy, laparoscopic surgery, robotic surgery, it should be minimally invasive without compromising on the overall outcome of cancer treatment. Likewise, whether we talk of head and neck cancers or limb salvage surgeries or every aspect, the mantra is very simple, that we must respect every normal cell, every normal part of the body. While we are addressing the cancer, the normal should be preserved as much as we can. And that is important for body image, addressing the body image issues.
Thank you, sir. So I would go on to our next panelist, Dr. Surveen. Dr. Surveen is a fertility specialist and a very special colleague of mine. We are often sending, young women to her who are suffering from cancer. So, Dr. Surveen, could you tell us how you would, counsel or help out young women who are undergoing cancer therapy for fertility preservation? And what do you advise us as surgeons?
Yeah, thank you, Manas, for that. And yes, you very rightly said we work very closely with the onco team. I think Max has a very strong onco fertility program, and all our oncologists, oncosurgeons are very much aware that they have to send patients, have to counsel patients. And thank you for having me here. Fertility preservation for a cancer patient is one of the most important things, because the survival rate has become so long. And I pick up from where Harit left, that yes, the quality of life is important emotionally, socially, and in every aspect. And one of the main things in a quality of life of a woman is to have her own biological child. And we at that stage are responsible for helping her to preserve that child for later on. So it's a major life crisis when you're diagnosed with cancer, and it's a big dilemma that having a child is the last thing on your mind. And that is what we try and overcome with the patients. However, it has been shown, whenever we ask the patient, they say, yes, we want to be informed that we have options, and we would even like to accept certain changes and delay in treatment to be able to take up those options. So firstly, I would like to say that the option starts right from the time you get a biopsy diagnosis of your cancer. That is the time when you should first visit your fertility specialist, so that she gets enough time to do what she has to with you. She could ask for a conservative surgery, like Harit said, that preserving is one of the most important things. So maybe the ovaries need to be preserved, only the tumor needs to be taken out. Maybe in a cervical cancer, only the cervix can be taken out for a while. But in doing all this, it's very, very important that we counsel the patient of the risks of delaying the treatment, of doing a conservative treatment, of a recurrence occurring, of a second surgery being needed. But on top of all that, the reason for what we are doing it is her pregnancy. So we need to assess her fertility before we actually start doing these things. So if she has a low AMH, if she has a low ovarian reserve, she is not going to conceive in any case. So the fertility preservation would be useless. That is where you need to meet your fertility person right before the treatment to assess your fertility, whether you are the right candidate for fertility preservation or not. So that's the first step. Now, there are many things which can be done. There are medicines which can be given, like a GnRH agonist. I'm not getting into those. There is preservation as far as your eggs are concerned, your embryos are concerned, your sperms are concerned. What are the main questions that we are asked when you come to us? One of the very important questions is, will the fertility treatment impact my cancer? So fertility treatment in no way impacts the cancer, other than the fact that, yes, you need a 12-day delay in your treatment, in the start of your treatment. We need those 12 days to be able to do what we have to with you. And we do give you drugs to bring down your hormonal levels if you have a hormone-sensitive cancer. The second thing is, will the pregnancy cause a recurrence? No, it has not been known that breast cancer recurs with pregnancy. The third question we are asked is that, what is the chance of my pregnancy when I freeze eggs? Now, that's a very important question. Many patients feel that I have preserved my eggs and that is equal to pregnancy. No, that is not equal to pregnancy, because IVF has a failure rate. So we need a set quantity of eggs to be able to give you even one pregnancy. And that maths has been done. And they say at least 15 eggs are needed for one pregnancy, because there are failures at every step. The fourth question which is asked is a frozen egg as good as a fresh egg? Yes, it is as good as a fresh egg. Are the children born, can they be congenitally abnormal? No. Then another question which is very often asked is, will my child get the same cancer? Now, if it is an inheritable cancer, we can do a pre-implantation genetic diagnosis and actually pick up the embryos which do not have that gene. How long can my embryo be stored? Well, it's written as 5 years, but we store it for much longer. So these are the questions which they come up with, the dilemmas. What are our dilemmas as doctors? We know that she is a cancer survivor. She has cancer. Is she going to survive? Is her lifespan going to be so short that the child will have no mother later on? So that is very important. This is an ethical dilemma which we have. In very sick patients, should we be going ahead with this treatment? And if we are, do we take the right signatures? Yes, we have to take signatures for discarding the embryo, for donating the embryo, or a posthumous, what do we do with the embryo? This has to be absolutely clear. In adolescent patients, again, it's a dilemma on whether who will give the consent. Often parents don't even counsel their children about it. And lastly, my question to the house is that should fertility preservation be insurance covered in a cancer patient? Yes, it should be insurance covered. If your doctor has not counseled you, is it medical negligence? Yes, it is, because your quality of life is being impacted. So definitely it is a multidisciplinary approach, and we need to take it up strongly with all our patients who are eligible.
So, in a very short, sometimes for appropriateness of the cancer surgery, we may have to remove both the ovaries, but we try to preserve fertility. So, in those cases, could we just save the uterus in oncologically appropriate surgery?
Yes, you can save the uterus, and you should save the uterus, because when you take a donated egg and you produce a child with a donated egg, the baby grows in you, you deliver the baby, you feed the baby. It's an entirely different experience. I haven't had a single patient coming back to me and saying that I do not like my donated egg child. They simply love that child. There is no difference for them. So the uterus is a very important organ.
So, and one more, last question to you is that could you please also tell us about any safe replacement therapy for common problems following loss of ovarian function or loss of ovary?
Yeah, there are plenty of non-hormonal therapies which are there. Firstly, stop smoking, no alcohol, weight loss, very important. Weight bearing exercise is very good for your bones. They must be done. There's certain herbal supplements like black cohosh, which has actually been recognized by the American College of Obs and Gynae. Soya supplements, which of course are not to be given to breast cancer patients with hormone sensitive tumors. Then ginseng is very good again for energy and for depression. There is another herb known as St. John's wort, which is very, very, very good for depression. There are non-pharmacological therapies like behavioral therapy, yoga, breathing exercises, acupuncture. All these have been tried. Vitamin D, calcium for bones, very important. Then there are these selective serotonin inhibitors, and these along with gabapentin, clonidine are very good for your hot flushes. Osteoporosis, again, there can be a non-hormonal treatment with zoledronic acid, oral biphosphonates. These are all non-hormonal, but mainly what really helps is regular exercise, aerobic exercises, weight bearing exercises. They are mood elevators. Your hot flushes actually don't occur if you're one of those who is doing a regular exercise and good diet.
Thank you, Dr. Surveen. So just going to our next panelist, Dr. Gaurav. So in very, very simple terms, what is palliative care? Many people, get confused with this word. They don't know the real meaning.
So in very simple terms, I would say palliative care is an extra layer of cushioning, which would help and which would cover the supportive things which you are needing during your journey with cancer. So like Ms. Nafisa Ali mentioned, yes, there are things which family and supportive doctors, they do and help to recover. And it is not just medications. Yes, medications, taking care of making the patient understand about the disease, what they're going through, and how would they come back from their journey with chemotherapy, surgery, radiation. So that is, I would say, that is where palliative care helps. And apart from patient, I mean, palliative care doctors would definitely take care of your family and other things which are going through in your mind also.
So sometimes we get confused regarding, the word palliative care, supportive care, and hospice care. So how would you, in simple again terms, tell us about these words?
So I think palliative care, like I mentioned, it starts with the diagnosis of the patient. It doesn't depend on the state of your cancer, or it starts with your diagnosis. And supportive care is usually needed when you are on some type of treatment and the treatment is affecting your quality of life. So it is sometimes interchangeably used with the term palliative care in certain institutions. And hospice care is mostly the care which is needed when your quality of life has been hampered, and sometimes it is probably also associated with the expected prognosis of a patient. And certain when you are unable to you are not self dependent, and it's found to be difficult for your family to take care of you, and they need certain types of help medically or otherwise just socially. I mean, they are unable to cope up with uh, the maintaining the quality of life of the patient.
So one of the main problems of cancer patients is pain. So what are the different types of pain condition by which a patient presents with gynecological cancer?
Yes, I mean, pain is often one of the most common presentations for any of the cancers. Similarly, for gynec cancers, apart from bleeding, which some of the survivors and champions they have mentioned. So, pain is also the presenting complaint in the lower abdomen region, and also it is sometimes associated with the treatment which they have been provided for management of the cancer. So it could be associated with the surgery during the surgery, and sometimes we have seen certain number of patients they are continued to have pain, and the pain changes from acute towards the chronic settings. And usually the definition of chronic pain is when we say it is more than 3 months, so it is said to be chronic. And also we have seen patients associated with the chemotherapy and radiation complaining of certain type of pain which is not usually experienced by patients on other modalities. They would have peripheral neuropathy or mononeuropathies, and certain types of skin reactions, perineal reactions. So these are some of the common presentations which we see the patients being referred by oncologists to palliative care physician if they are available. And likely Ms. Nafisa mentioned that yes, there are certain times when you need more than your general medications. I'm not supporting the use of hemp oil, but yes, we have recognized and medicated opioids preparations available, which are, I would say, under prescribed in our side of the world. And our consumption of opioids is totally inappropriate if we compare to the Western world, and would like more of oncologists to support their patients and especially with regards to pain management when it is concerned during the journey of the cancer.
And what would you say about a lot of patients having peripheral neuropathy? That's the last question to you.
Neuropathy is different because one thing, it is heterogenic. It is heterogenic. So the way the patients present, they get to know that yes, it is being given to them by one of the modalities of cancer, and certain patients in certain patients are more prone to have those side effects, who are like diabetic, or they are suffering with some other comorbidities like thyroid or other endocrine disorders. So they have more tendency to have peripheral neuropathy, and it is more likely with certain types of chemotherapy regimens, which include platinums, taxanes, and vinyl colloids. And there are various modalities to manage. Not all patients would require medications to manage peripheral neuropathy, but it needs to be observed, and there would be. See, neuropathy can be sensory, where you have symptoms, and symptoms can be positive symptoms or negative symptoms. Positive symptoms when you are experiencing pain, negative symptoms when you are experiencing numbness. So it can go to either side of it. And yes, difficult would be to manage positive symptoms, and also sometimes more than sensory, certain patients would have motor symptoms as well. When I say motor, it means that there can be weakness associated with it, and that would warrant your oncologist to sometimes alter the dosages of chemotherapy regimen which you are prescribed. And also you need to take care of your peripheries, because peripheral neuropathy is more in hands and feet. So what we call gloves and stocking, the region where you are wearing gloves and stocking. So it is like your nerves are more sensitized towards any harsh changes of weather or cold and extremes of temperature, and also sometimes to general normal living, where you get to give more preference to what kind of footwear you need to wear, how you should keep your hands, and what temperature you should really be exposing your feet and legs to.
Okay. So thanks, Dr. Gaurav. And with this, we go on to our psycho-oncologist of our team here at MICC, Ms. Hiba. So there is, we often talk about the impact of cancer on the individual who has been diagnosed, but and is on treatment. But many, or probably most of the times, we are ignoring the talk about the caregivers. What is going through the mind of the caregivers? And since we are doing this entire conference in a different way, so I'm going to ask you in different questions. So what are the different ways in which cancer affects the emotional well-being of caregivers?
Well, I think it's a very, very interesting question, and I'll try to keep it as quick as I can. Whenever I meet patients and their families, I often say that it's not the individual alone who's diagnosed, it's the entire family. And they find it very surprising. I've said something very new. And to answer your question, apart from the usual psychological, behavioral, or social aspects that get impacted, I'm just going to talk about very specific things. We deal with guilt, resentment. We're dealing with anger that I didn't sign up for this. I'm not ready for this. My family member is diagnosed and I had an entire life planned, which has suddenly come to a standstill. So you're also dealing with your own sense of losses, the grief of having lost the time, the conflicts that arise. And we were talking about, the impact on relationships at some point. And with caregiver perspective, we often forget the implications that happen on intimacy, sense of sexuality, desirability, and an overall displacement of communication patterns. So I feel these are issues which create distance and lack of expressions among caregivers, which often, like you said, get very ignored.
So taking, the cue on from our wonderful star, speakers of today, Miss Rita and Miss Poonam, who broached on the topic of, family ties and family, relationships, etc., which happen during, the treatment. We often ignore, and we are really hushed about the word intimacy. So when we come to this topic of intimacy, how do you define it in the in this context of someone's cancer journey and its impact on, both patients, caregivers, and the relationship during this journey?
actually about how we define the term intimacy. People look at intimacy only as a physical concept. There's also a lot of times emotional intimacy, spiritual intimacy, psychological, intellectual intimacy. And we all feel those with different people and aspects of our lives. Cancer is something that's because it's taking over your physicalities, you often ignore the mental aspects because they're submerged, right? They're not at the surface. And so it's important to redefine your own intimacies with your people. So partners, family, children, parents, and to redefine through communication, through expressions. Everyone's intimate language is different. Mine can be probably cracking a joke. Someone else's can be a hug. Someone else's can be, a small encouragement. No, so we need to redefine that to build some strengthen and bridge something that has sort of been shaken up.
Again, going towards caregivers, some practical tips you would suggest in how to focus on, self and take care of their own mental health during this process of diagnosis, treatment, and survivorship.
Yeah, absolutely. And in fact, speaking of Rita ji, she and I have been following each other since 9 in the morning, which is why I think both of us were having our glasses of water by now. We had the other panels as well. But to just quickly summate what you said, I think we need to, identify the psychosocial burdens that the caregivers are facing. You need to understand that your life is not just your patients. You're caring, and that's great. But you're going to start resenting. The cancer is the issue, but the displacement happens on the patients or someone else. So you need to take out me time. You need to find time to rejuvenate yourself. Reach out to your friends. If you're going out for a party or just a quick tea, coffee, whatever you like, don't feel guilty that my patient can't go because they are on, say, chemotherapy, or they've just had fresh surgery or some radiation impact. Don't compare your burdens with others, that person is in a worse condition than I am. That never helps. Comparing grief can be so counterproductive. And lastly, if all these things are jarring, not helping, please reach out to professionals, psychiatrists, psychologists, counselors, psycho-oncologists. Normalize help-seeking behavior, not just for your patients, but for yourself too. And with this, I think this is the maximum we can do to really take care of our mental well-being.
Thanks, Hiba. That was, very different. Like we said, we do things differently, here at our team. So the next person whom I'm going to just, ask a few questions is the physiotherapist of our team. So Dr. Pallavi, so there are questions, one of the very common questions, patients say is, I feel weak after my chemotherapy. So what type of exercises can I do to feel better?
Right. So I think, sir, the first thing to highlight here is not everybody will have the same experience during their chemo. So I would just like to highlight some of the common complaints that we generally encounter. So it can be just a feeling of fatigue, the patient feeling tired, not having enough energy. And another very common complaint that we generally get is that the patient experiences certain tingling sensations in the hands or the legs, which of course we call as neuropathy. And eventually with chemo, there can be weight loss, there can be muscle weakness. So where does physio come into all of this? So a good physio program is generally going to encompass your breathing exercises, and these are very essential to combat the side effects of chemo. And next, coming to the neuropathy, stretching exercises we have seen are very effective to give you relief. Now, of course, not everybody might have the same experience with physio, but these are commonly the interventions that we give. And coming to a bit of the technical part, we have certain modalities called the TENS and the IFT. So these are basically machines that work on your nerve. So when you get this tingling sensation, it can be improved by using the TENS or the IFT. And next we come to your strengthening exercises. Now, a good thing to remember is that if you feel well enough, only then should you be exercising. So according to the patient's own energy and the patient's own comfort level, we can gradually start with the strengthening and resistance program. Yeah,
The
so that's the
other
role during the chemo.
The other thing, many patients would ask is that their body feels stiff and tight after radiation. So, do you think that the physiotherapy helps in that?
Oh, absolutely, sir. So the very important aspect here for physio would be a stretching and flexibility routine. So this is going to help you combat muscle tightness, and it helps to regain your functional movement. So a very common problem with the tightness is going to be that you don't feel you're moving around the same way like you used to. You feel very restricted, you feel stiff, you don't feel like moving around much because the body is feeling very locked. So a good start would be maybe just at the beginning of your radiation, you should get into a good exercise program, speak with your physio, because each exercise routine is going to be specific to you. So get yourself assessed and you can start on with the stretching and the flexibility routine. And of course, this is again a good time to start with the strengthening program to help you combat the fatigue and to build up your muscle strength.
So I believe, I mean, in the days of super specialization, even physiotherapists are super specialized, and you are a specialist in lymphedema therapy. Now, both in breast cancers and in the gynae cancers, we take out nodes, and both have a problem of lymphedema. Many patients, I would say, and but we are early to tackle it, and of course, your role is there. And so, what would you tell us about that?
So, sir, for lymphedema, I would like to briefly divide my management into two parts because a lot of patients have this query. So, it can be preventive and it can be curative. So, what I mean is, if you are at a risk of getting
In
lymphedema,
simple terms, lymphedema, just for the others, lymphedema is like swelling of the arms on the side of where the breast has been, operated on, or the swelling of the legs. So, yes.
right. So full-fledged lymphedema is a swelling, and it can also start with just a feeling of heaviness. And so the treatment here would involve, if you're doing it as a precaution, which is something that we advise every patient post-surgery, there will be two aspects. The first is exercise. Now, what kind of exercises should you do? Very crucial is elevating your limb. Now, this can be simply by just using pillows to raise your leg up high as much as you are comfortable. Try to move your ankle, try to move your knees, do your ankle pumps. Just keep the circulation going. So this will prevent the swelling from accumulating in your leg, and it works as a very good prevention exercise. Next would be the massage. Now again, just to focus here, we are doing this as a prevention. So this massage is going to be very basic. You can basically start from your toes. So just imagining this to be my leg. You just start off with your toes, gentle strokes, and you're just trying to push up into the abdomen where you have the nodes, and you're just trying to move the fluid away. So this is the very simple way of preventing lymphedema, combination of your exercise and your massage. Now, in case you have full-fledged lymphedema, now this is where your complete decongestive therapy comes in. Now, this is again a combination of your exercise, and now the technical thing comes in here, which is the lymphatic massage, which is something that your trained therapist is going to do for you. And next comes in the pneumatic compression, which is essentially a machine where we put the sleeve and it gives you mechanical compression. So the sleeve fills up with air and it gives you mechanical compression to move the fluid away. And next comes the bandaging. So the bandaging is basically like a multi-layer bandaging kit where we use different sized bandages to give you various pressures at different levels to just move the fluid away and to decrease the swelling. So once we reach a good stage of management, we advise you to wear your pressure garment. So the garment basically help you to just maintain whatever swelling we have reduced. And this completes your complete lymphedema care. So everybody needs different intervention depending on what stage of swelling you have, which again needs to be assessed by your therapist.
Thank you, Pallavi. Thank you so much. Yes, with that, we go on to our next panelist, our dietitian and nutrition expert. So Kalpana, coming directly to the question, any special diet required for our survivors?
Actually, as a dietitian, I generally recommend there is no specific diet or special or fancy diet is required for our survivors. As a dietitian, I have three main goals for nutritional management. Is one is eating a well balanced diet, and second is maintain a healthy body weight, and third is avoid losing protein from your body, avoid losing muscles. So a balanced diet would include all major six groups of nutrients which we require on a daily basis. It's like carbohydrate, protein, fats, fluids, vitamins, and minerals. And specifically,
Kalpana, you just accidentally muted.
sorry. So it's patients require only a well balanced diet. It includes all types of nutrients like carbohydrates, proteins, vitamin, minerals, fats, and fluids. And we require it on a regular basis. And it should be minimally processed form. It should not be processed form. And eating a well balanced diet during and after therapy, it helps in speedy recovery, and patients feel better and have maintain your strength in your body. So a well-balanced diet is required for all our survivors.
And tips to maintain good health?
Yeah,
What do you say?
so that's very important. So first go, all the patients think that if we skip meals, then we can reduce our weight. So first and foremost is that don't skip your meals. Always take small and frequent meals. Second is limit your portion size. So don't take anything in a very higher amount or lower amount to control the calorie content. And third is add a healthy snacking in your day, and be physically active at least 30 minutes in a day, and stay hydrated with any form of fluid like water, coconut water, lemon water, or soups. In any form, you have to take good amount of fluids on a daily basis. Yes.
And some quick do's and don'ts for our warriors?
Yeah, so two main do's they should maintain healthy body weight first, and second is they should include anti-inflammatory foods like berries, tomatoes, olive oil. This is all very good, or fish. And don'ts is second, first and foremost is to avoid low inflammatory foods like refined carbohydrates, fried foods, trans fat, and very sugary drinks in the meals. And second is don't follow any specific diet for a longer run. It's very, very important, because many of the patients came with the specific diets and they are losing weight and proteins. That's not good for the patients.
Thank you. Thank you so much. And then to just wrap up the proceedings of this panel at the end, I call upon Dr. Harit once again. And sir, so what is the message to our cancer warriors from the team for a holistic approach to survivorship?
So I feel that first and foremost, there should be sense of entitlement, that yes, we are entitled for everything which is normal and which is good. We should not accept a compromised life. That is very important thought. Second thing, I would say that a lot of people are watching how you react to the situation as it emerges, unfolds, and a lot of surprises will come, a lot of things will. So you are an inspiration for your children. A lot of times I hear young parents talking that how will my children remember and things like that. I always tell them that they will remember your response. They will not remember how cancer treated you. How you reacted to the cancer is the most important thing. And that is why it is important to be strong. So for that, I will use one more slogan: fake it till you make it. That is that if you are not feeling so strong, don't be bogged down. Just artificially project yourself as somebody who's overcome. As I think all the warriors were talking, how Nafisa and Kalpana ji, everybody said that she was energetic, enthusiastic. So these things are very important, that if you are positive, energetic, a lot of negative thoughts will go away and you will be able to overcome that. And in the long run, it is not the cancer which will define you. Your response to cancer will define cancer, in fact. So remain strong, positive, use all the resources at your disposal, use the hospital machinery, use your support system. Be selfish for that period of life. Be selfish. Put yourself first for everything you want to do, and be there. That's it.
Thank you so much, sir. And with that, I thank all my panelists, Dr. Surveen, Dr. Gaurav, Hiba, Pallavi, and Kalpana. Thank you, sir. With this, we come to the end of this panel. And in the same breath, since we are at the end of our conference, I would invite Dr. Shefali Sardana for a vote of thanks. Dr.
Yeah,
Shefali.
thank you, Dr. Manas. These 2 days have been very wonderful. It's a great conference we had, and with all of our faculty, speakers, everybody's support. So I would begin my vote of thanks by first of all thanking, of course, Almighty, which is the supreme expert, and it is my honor to offer a vote of thanks. Especially on this closing day of this successful Maxcon Gynae 2021 today. So on behalf of Gynae DMG, MICC Saket and organizing committee of Maxcon Gynae 2021, I express my sincere gratitude to all the faculty for sharing their knowledge and contributing their experience and time to this wonderful learning and academic event. And I would also like to thank and congratulate the young and dynamic oncologists who participated and showed their original research, interesting paper, case series for their poster and abstract session. A very special and sincere gratitude to all the winners and survivors who are a real inspiration and a kick actually to work hard and sincerely towards our vision and goals. And in the queue, I would also like to extend my sincere thanks to our sponsors, Roche Foundation Medicine, AstraZeneca, Entas, Zydus, and J&J, without whom it would be actually not possible to make the dream come true. And last but not the least, my sincere thanks to our technical organizing event partner, meetings and more, so who really made this dream happening on a virtual but actually the real background, real platform. So my sincere apologies if I have missed unintentionally anybody or everybody who has contributed to make this event a success. And thank you everyone once again from the bottom of my heart. Thank you. Yeah, so Dr. Charu, I would invite you to give the closing remarks. Over to you.
Thank you, Shefali. And I think we had these 2 days of wonderful conference, and someone has very correctly said that no one can whistle a symphony. It takes a whole orchestra to play it. So I think we need to create a perfect symphony for all our patients. And this symphony can be created if we do a teamwork. I think we all know, like in our DMGs, we really have war zones inside and good friends outside. But I think that's the way forward, because none of the guidelines, none of the books would guide you how to treat a patient, because no one shoe fits all. So it has to be individualized, and that can be only done when all the 3, 4, 5 specialties sits together and curate out the best treatment for our patients. And with this, I would like to close this conference with 2 lines of Robert Frost. I have promises to keep, and miles to go before I sleep, and miles to go before I sleep. Thank you so much, everyone, for joining in.
Thank you, Dr. Charu. Thank you, Dr. Charu. Thank you, everybody who have been, sitting up so late, and for our, closing remarks. And once again, I thank all our, my co-organizers, and we've been all in it together. And once again, teamwork makes dreams work. Bye. Good night.
Thank you.
Thank you.